Friends, good morning and a warm welcome for this IMA Pune's CME on managing vascular diseases. Dear friends, IMA Pune, the largest branch of IMA in Maharashtra, conducts lot many CMAs with a very good content and academic feast to its members to upgrade their knowledge. We are still into post-COVID era, and we are seeing lot many cases of embolism, hypercoagulability. So we thought today we would be discussing about how to manage this vascular diseases which have increased a lot in this post-COVID era. Friends, before management, we need to understand the pathology behind it. We need to understand why and how this hypercoagulability is increased in this post-COVID times. We also need to understand the pathology behind it. To explain all this, we have excellent team of PathKind to explain us about this. We also need to understand the advances. Friends, what has happened is medical field has advanced a lot in the field of pathology and imaging. So we need first to understand how to diagnose, what the pathologists do, and what are the modern things that we have in our hand to diagnose all these things. Before starting this program, I would like our President, Dr. B.L. Deshmukh sir, to give opening remarks.
Good morning all. I welcome you for this CMEs arranged by the PathKind Laboratories and other CMEs by Abbott. In between Abbott on vascular disease and its management. In between there is a financial diary inauguration program. I hope you will enjoy both the CMEs. Thank you.
Thank you, sir. As you said, in the first part, we will be learning about pathology, and in the second part, we will be actually learning about the how to manage vascular diseases by the team of Dr. Dhanesh Kamirkar, sir. And at 12 o'clock, we have a very important function, that is IMA Pune Financial Diary Release Program. Our team has taken lots of efforts to come up with an excellent financial diary this year too. Now we will straightway go to our first session. In the first session, our first speaker is Dr. Sharvari Vishwasrao, who will be speaking on advance in modern pathology. Dr. Sharvari Vishwasrao is consultant pathologist at Hind Labs Life Niti Wellness, Pune. She has done her MBBS from Grand Medical College, which is my own college, and I'm a hardcore GM sites, madam. Thank you. Thank you very much for coming here. She has done her MD Pathology and secured first number from BJ Medical College. She has also done her DNB in pathology. She has worked as a pathologist in YCM Hospital and Hind Labs, Baudhan. She has many publications such as clear cell adenoma of female urethra in the Journal of Clinical and Diagnostic Research. She also has a publication on placenta accreta syndrome in New India Journal of OBGYN. She has many awards, and the most important is she stood first in MD Pathology exam in 2018 at BJ Medical College. And she has participated in many quizzes, and she has held good positions in all those quizzes. She has many paper presentations and papers in MAPCon and APCon. Her special interest is in hematology and molecular pathology. With this short introduction, I request Sharvari madam to start her first lecture.
Uh, 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 a very good morning to everyone present here, and thank you so much for the introduction. So I'm Dr. Sharvari, and I'm the lab head of Pathogenic Labs in Pune. I think most of us are returning to offline CMEs after a long time, so the excitement is palpable. So today I shall be presenting on advances in pathology. So just a short historical perspective of pathology. Through the ages, through antiquity and till the Middle Ages, pathology was mainly anatomic and morbid pathology, because what we were doing were autopsies. So although it was not diagnostic for the patient per se, it laid the foundation of what we call as the pathologic basis of disease. Later in the 19th century, Theodor Schwann propounded the cell theory, and Rudolf Virchow, who is called as the father of modern pathology, developed the concept of cellular pathology. Later, with the discovery of the microscope and better technology in optics, diagnosis on tissue and fluid specimens became possible, ushering in the era of diagnostic pathology. So as we say from the organ, the focus shifted to the tissue and cell diagnosis. Later, as technology advanced, the focus has shifted from the organs to the cell, and now to the genes and to the nucleic acids. Later on, apart from classic anatomical pathology, numerous subspecialties have developed, and it includes hematology, cytopathology, medical microbiology, neuropathology, molecular genetics, and clinical informatics. And today, as we know, there is fast-paced digitalization everywhere. And along with the development of artificial intelligence, we have come to the era of digital pathology. So right from microscopy to diagnosis to risk assessment, numerous machine-based algorithms have been developed which aid clinical decisions. So what is done is the patient information, that is clinical informatics, the molecular pathology information such as genomic and proteomic data, then the digital pathology information such as histology and cytology whole slide imaging, and the clinical pathology information, that is the lab results. They're all taken together, then algorithms are made. And these algorithms help the clinician make better decisions. So today we have come to a new era, which is called as computational pathology. Also, my topic today is recent advances in pathology, and it covers a vast variety of topics. I could probably go on all day. So I have chosen certain selected ideas, which I'm going to discuss, and I guess everyone will find them interesting. So I'm going to discuss certain advances in hematology, advances in diagnostic oncology, advances in the diagnosis of tuberculosis, and certain advances in prenatal diagnostics. So coming to the first section, that is advances in hematology. So when we hear hematology, the first thing which comes to our mind is the complete blood count. It is probably the most commonly ordered clinical test. So what happens in complete blood count? We give an idea of the RBCs, the WBCs, and the platelets. And its indications are mainly numerous infectious and hematological disorders. But today there's a question. Is it time for a paradigm shift in the differential leukocyte count reporting? So rather than telling the clinicians that there are these many number of neutrophils and these many number of lymphocytes, am I supposed to tell you whether the neutrophils and lymphocytes are mature or immature and whether they're activated? So recently, with technological advances in modern hematology analyzers, it is possible to give a broader picture of the hematological parameters. So we have come to what we call as the extended DLC. So apart from just neutros, lymphos, basos, eos, and monos, we also give what is called as the Ig count, that is the immature granulocyte count, and the HFLC, that is the highly fluorescence lymphocyte count. So what are these IGs? As the name says, IGs are immature granulocytes, and they include promyelocytes, myelocytes, metamyelocytes. And the presence of these immature granulocytes in the peripheral blood indicates that there's leukopoiesis, and it may represent the earliest indicator of bone marrow stimulation by infection, inflammation, or any other stimuli. Also, it has been found to be a useful clinical tool for detection, monitoring, and progression of inflammation, sepsis, and certain bone marrow neoplasms. And coming to the HFLC, that is the high fluorescence lymphocyte count. These parameters are mainly available on the newer Sysmex analyzers, and it combines two technologies, first being the flow cytometry, and second being the nucleic acid fluorescence staining technology. So right now it is a research parameter. It is not being used everywhere. However, what happens is that these lymphocytes, which are highly fluorescent, get stained during this analysis. So like why exactly are these particular lymphocytes stained? So what happens during any infection or inflammation is that during any antigenic stimulation, the amount of nucleic acids within the lymphocyte increases. So these particular lymphocytes bind a greater amount of the nucleic acid dye. So they appear as more fluorescent. So these get analyzed as the highly fluorescent cells. So just a short visual representation. So on the normal flow cytometer with fluorescence, the immature granulocytes, they too are fluorescent and they can be seen in this area, whereas the highly fluorescent cells have much more fluorescence with a different side scatter compared to the normal lymphocytes. So during the development of this test, studies were carried out that what exactly are these highly fluorescent cells? What is its lineage? So compared to the highly fluorescent cells, they were also studied on the normal flow cytometer. And it was found out that these highly fluorescent lymphocytic cells were actually B lymphocytes, which are antigen secreting cells. Also, further studies were carried out on the use of these parameters in patients of sepsis. So what they found out was that the immature granulocyte count and the highly fluorescent lymphocytes were raised much earlier in patients of sepsis compared to the normal biomarkers such as CRP and the PCT. So the new parameters derived from the cell counts, the percentage of HFLC and Ig was significantly raised from day 7 onwards, and they also dynamically reacted to antibiotic therapy. So certain other studies were also conducted, especially in COVID-19. So a new marker was developed, which was a combined WBC and HFLC marker. And they found out that it was the best diagnostic marker for both mild and serious cases of COVID-19, with a sensitivity of 90.6 and 90.3%, and a specificity of 64 and 73% respectively. Also, the use of these highly fluorescent cells in certain diagnostic dilemma cases like infectious mononucleosis was done. So what was done was 4 study groups were taken. First was the infectious mononucleosis group. Second were the healthy controls. Third were the upper respiratory tract infection. And then were the tumor controls. So what was found out was that the percentage of HFLCs between the IM patients and the rest of the patients was statistically significant. So the HFLC percentage can be used in the auxiliary diagnosis of infectious mononucleosis, thereby saving time and reducing cost of smear and manual classification. Also, it assists the diagnosis of IM with the following advantages: that this indicator, that is the HFLC, it has high sensitivity and specificity for the diagnosis of IM, which can effectively avoid the diagnosis being missed. Also, since it's a simple test, it can avoid numerous other serological tests. Also, the screening of dengue fever was done using HFLC, and it was found that the percentage in dengue positive patients of HFLC was 1.9% compared to 0.2% in dengue negative and 0.1% in healthy controls. So a cutoff of 1.75% was used for discrimination between dengue positive and dengue negative cases, with a 52% sensitivity, 90% specificity, 72% positive predictive value, and 80% negative predictive value. So although HFLC is still a research parameter, the extended DLC with these new parameters in the future, it could become an integral part of CBC reporting, and it could help clinicians predict and prognosticate patient outcomes, especially in infective conditions. So now I'll move on to the second part of my talk, that is advances in diagnostic oncology. So today, as we know, therapeutics in oncology, they're moving at a very fast pace. And the chemotherapy approach, which is more of one for all, it has moved to a more tailor-made approach in which the therapy is made according to each patient's genetic and immunological profile. So advances in molecular technologies such as NGS, that is next generation sequencing, have made it possible to match mutational profile for targeted therapies. However, similar advances are needed for the understanding of what we call as the tumor microenvironment, that is TME. And this is especially important in immunological based therapies. Also, immunotherapy targeting the PDL1, that is programmed death ligand 1, has been used in a number of cancers such as non-small cell lung carcinoma, renal cell carcinoma, melanoma, and Hodgkin's lymphoma. So right now, PDL1 is done by conventional IHC. However, it has certain limitations, such as on a single tissue, we can do only a single marker. But this becomes a disadvantage when only a small amount of tissue is available. So right now, what we have is multiplex IHC or multiplex immunofluorescence. So what it allows, that it allows simultaneous detection of multiple markers on a single tissue section. And this has been adopted in both research and clinical settings in response to increased demand for improved techniques. And the ability to label multiple markers on a single section is of particular importance when the samples are taken from where the donors are rare, such as lung tumors. Also, spatially resolved proteomic, genomic, and metabolic profiles of human cancer are now possible at the single cell level. Also, a large amount of data can be obtained from a single tissue, which with the help of artificial intelligence platforms can be used to stratify tumors for potential novel therapeutic targets. Also, multiple labs have used this multiplex IHC and IF to report prognostic or even predictive value of immune subsets in several types of cancer. So certain studies have been carried out. So in triple negative breast cancer, the multiplex IHC for PDL1 was compared to the conventional IHC. And what they found out was that there was a moderate to strong correlation in PDL1 positivity with the individual concordance of 67 to 100%, and a Spearman's rank correlation coefficient of up to 0.88. So what they concluded was that multiplex IHC or IF, it represents a promising tool in the era of cancer immunotherapy, as it can simultaneously detect and quantify PDL1 labeling with multiple antibody clones and allow accurate evaluation of tumor and immune cells. Clinicians and pathologists both require this information to predict patient response to anti-PD1 or anti-PDL1 therapy. Also, one study was carried out in patients of Merkel cell carcinoma with respect to response to pembrolizumab, which is an anti-PDL1 agent. So this is what multiplex IHC looks like. On a particular section, multiple antibodies are used, and even at the level of a single cell, we can come to know whether it expresses just one antigen or multiple antigen. So here we can see cells which are positive for two antibodies, that is PDL1 and CD8 or PDL1 and CD4. So what this study concluded was the complexity of the tumor microenvironment has surpassed the digital reads of single stain IHC as positive or negative. Value is gained by quantitating the density of cells expressing PDL1 or PD1. Spatial metrics such as the density of PD1 cells within distance of PDL1 adds a new feature to predictive biomarkers. And by incorporating both the partners of the receptor ligand pair, this parameter more accurately reflects the fundamental mechanism underlying the PD1 and PDL1 blockade. Lastly, evolving multiplexing technologies facilitate further studies of marker co-expression. So in the near future, the need for personalized immunotherapy in cancers will further focus on the need for multiplex IHC. Major drawbacks would, of course, include the cost and technical complexities. However, it is hoped that in due course, there will be a widely adopted, low cost and high throughput standardized technique. The multiplex IHC technique has great potential in translational research and clinical practice in the immediate future, particularly in the era of cancer immunotherapy. Now I will move on to the next part of my talk, that is advances in TB diagnosis. So tuberculosis, it is a chronic granulomatous bacterial infection with a global occurrence. And over the last decade, especially with respect to TB diagnosis, there have been multiple advances in the form of especially molecular tests and immunological methods. So these molecular tests, they're often referred to as nucleic acid amplification tests. And these rely on the amplification of a particular targeted genetic region of the MTB complex, typically by PCR. So these NATs can detect TB as well as they can perform drug susceptibility testing for key drugs such as rifampicin and isoniazid more quickly than the conventional culture. And these can be available at various levels of healthcare. So molecular biology detection on clinical samples in the past, it was done by open PCR, but now it is being done by real-time PCR, which is a closed system, and predominantly Cepheid systems are used. So certain advantages are that the system is closed. The sample processing is much simpler. The bacteria are made inactivated, so there's no chance of infection. The results are much rapid, that within 2 hours you get results, and the detection of MTB and rifampicin resistance, which is a surrogate marker for MTB, can be done. Also, extensive field testing has been carried out in different parts of the world. So just something in short about GeneXpert, which is, so it is a WHO endorsed cartridge-based closed RT-PCR system, which is used for the detection of MTB and rifampicin resistance. It contains quality controls for both sample processing and probe check, and it amplifies a 192 base pair region of the MTB RPOP gene. So this is what a GeneXpert report typically looks like. So MTB DNA is detected as, MTB DNA is given as detected or not detected. Quantitation is done on the basis of CT value as high, medium, low, and very low. And rifampicin resistance is given as present or absent. As per the Cepheid submission to US FDA, the smear sensitivity is 30%. Culture sensitivity, which is culture is gold standard, and it has 100% sensitivity. However, it has a much longer TAT of around 6 weeks compared to GeneXpert, which has a TAT of 2 hours, and it has a sensitivity and specificity of both 99%. So as per the 2013 policy update of WHO, GeneXpert is recommended rather than conventional microscopy and culture as the initial diagnostic test in all adults and children with signs and symptoms of TB. Today, compared to GeneXpert, we have a further advance, which is the GeneXpert Ultra. This is what its cartridge looks like. So basically, this GeneXpert Ultra, when it was compared with both expert and culture samples, it detected a much larger number of TB patients. Also, in children, as per this mini review, it had increased analytical sensitivity when compared to the older GeneXpert assays, and this was supported by 6 clinical studies. So just a short comparison between the GeneXpert and GeneXpert Ultra. As compared to GeneXpert Ultra, it detects multiple copy targets. Also, it has a much larger reaction volume, that is 50 microliters, so more amount of DNA can be detected. It has a much lesser TAT of around 65 to 87 minutes as compared to 112 minutes of GeneXpert. Also, it has, the limit of detection is much lower, so much smaller number of MTB can be detected by GeneXpert Ultra compared to GeneXpert. Also, it has a special advantage that in paucibacillary samples from pediatric patients, such as extrapulmonary TB and CSF, lymph nodes, tissues, and fluids can be better detected with GeneXpert Ultra. Now coming to the immunological tests of TB. The main immunological test of TB, which is used very widely, is the tuberculin sensitivity test. However, it is being phased out in many cases. And today, what we mainly use are the interferon gamma release assays, that is the TB Gold. So basically what we have in this is that the T cell release of interferon gamma followed by stimulation by antigens specific to the MTB complex is used. And these antigens include the early secreted antigenic target 6, that is ESAT6, and culture filtrate protein 10. However, in this, the T cells stimulated are only CD4. However, both TST and the TB Gold have a certain disadvantages. They cannot distinguish between latent TB and active TB. They cannot distinguish reactivation from reinfection, and they cannot resolve the various stages within the spectrum of MTB infection. Also, they have reduced sensitivity in immunocompromised patients and a low predictive value for progression to active TB. So today we have a further advance in this. It is called as Quantiferon TB Gold Plus or TB Sure. So the main advantage of this test is that it provides indirect evidence of infection, and it can detect latent TB as well as recent exposure and active infection. It can be used for the monitoring of response to treatment. It is not affected by HIV status. So what is different in this TB short? Basically, as we saw previously over there, just CD4 cells were used. Here we are using both CD4 and CD8 cells. And it is said that in active TB, predominantly CD8 cells are involved. So when we see the delta between these two tubes, where just CD4 and CD4 plus CD8 are used, it is said that when the difference between the two tubes is more, it is predominantly due to progression to active TB. However, a negative TB short test or lack of CD8 response does not rule out TB disease, subclinical disease, or TB that may progress. However, the presence and strength of CD8 response may help clinical assessment of patient with risk of disease, new infection, and progression to TB. So the algorithm goes like this: when you're getting a particular sample, first we should assess whether it could contain Mycobacterium tuberculosis. So if we have sputum, we can probably go in for gene export or culture. However, if we don't have a sample which will probably contain MTB, we would prefer the immunological test, such as TB Gold or TB Gold Plus. This is what the report of TB Gold Plus looks like. So basically, the difference between this TB1 and TB2 is calculated, which is the delta value, and this gives the evidence of exposure or active tuberculosis. Also, the American Academy of Pediatrics in 2018 has recommended that compared to the tuberculin skin test, the immunological tests such as IgRA should be preferred in children. So I'll move to the last part of my talk, that is advanced prenatal diagnostics. Prenatal tests are classified into two types: the screening test and the diagnostic test. The screening tests are predominantly used to estimate the risk of trisomies, monosomies, and neural tube defects. And they would include the double marker, the quadruple marker, the triple markers, and the NIPS. Diagnostic tests are confirmatory, and they're usually done after the screening test. And they would include amniocentesis and CVS, which is followed by a cytogenetic test such as FISH. So tests used for prenatal screening is the first one most commonly used is double marker, in which we measure free beta HCG and pregnancy-associated plasma protein A. It can be performed at 9 to 13.6 weeks with a sensitivity of 85%. Quadruple marker uses alpha-fetoprotein, HCG, unconjugated estriol, and inhibin A. It can be used from 14 to 21.6 weeks with a sensitivity of 81%. And then we have what is called as the NIPT or NIPS. It can be used anytime after 10 weeks, and it has a sensitivity of greater than 99% for the trisomies and of around 95% for the anomalies in the sex chromosomes and the autosomal anomalies. So today I'll discuss NIPS in detail. What is NIPS? It is non-invasive prenatal screening. It is the most sensitive and specific non-invasive prenatal screening test that is available. It predominantly uses NGS, that is next-gen sequencing, to detect free fetal DNA in the maternal blood, and it screens for the trisomies, that is trisomy 21, 13, and 18 with greater than 95%, greater than 99% accuracy, and the other chromosomes with around 95% accuracy. So who should be screened with NIPS? Ideally, all patients should be screened. However, if certain risk factors are present, then one must strongly consider having this test. It includes an age of 35 or older, any family history of birth defects, and any other screening test which shows an enhanced risk, such as double or quadruple marker, any previous child born with a birth defect, and history of type 1 diabetes in previous pregnancy. So the importance of screening all pregnant women for NIPS is that 55% of all Down syndrome births occur in women of less than 35 years of age. So basically that is the importance of screening everyone with respect to NIPS. NIPS can be done starting as early as 10 weeks of pregnancy. And basically because of NIPS, we can avoid a number of invasive procedures done directly, such as chorionic villus sampling or amniocentesis. Also, what is done in this test is that the cell-free fetal DNA is purified from the maternal blood. Then DNA library is prepared and whole genome sequencing is performed. 6 to 10 million sequencing reads are performed, and the reads are aligned and analyzed as per the bioinformatics pipeline. The following detection rates are based on recent meta-analysis done by the ACOG. For trisomy 21, it has greater than 99% detection rate, 98% detection rate for trisomy 18, and a 99% detection rate for trisomy 13. And the false positive rate is extremely low, that is just 0.13%. However, it does have certain limitations. It is a screening test, not diagnostic. It does not detect all genetic abnormalities. Some do get left out, and it does not detect neural tube defects. Also, it is not validated for use in pregnancies with more than 2 fetuses. And if there's a demise twin, mosaicism, partial chromosome aneuploidy, translocation, maternal aneuploidy in cases of transplants and malignancies. So this is how the report looks like. So basically chromosome 21, 18, 13 trisomies are detected here. Then the sex chromosomal anomalies are detected and all the autosomes are detected here. And whether there's a low risk or high risk is given in the report. So just to summarize, the high accuracy and low false positive rate of NIPS compared to the traditional screening methods minimizes anxiety and the need for invasive procedures. However, we must keep in mind that it is not a diagnostic test and results should be considered with other clinical criteria and communicated in a setting that would include appropriate counseling. Thank you.
Any questions? Madam, cost of NIPS.
Basically, the comprehensive NIPS, which includes all the 3 trisomies, the sex chromosomes, and all the autosomes, that's the comprehensive NIPS panels, and that costs 15,000.
Thank you, madam. Thank you for excellent talk on advances in modern pathology. I know this is a very vast topic. You have tried to cover it in a short time. Now I request our President, Dr. B.L. Deshmukh sir, to felicitate Dr. Sharwari madam.
Yes, sir.
Now we move on to the second talk, which is on post-COVID hypercoagulability. To present this, we have another young, dynamic, enthusiastic, and very hardworking pathologist, Dr. Anam Fatima Siddiqui. She is a lab head of Pathkind Diagnostic Private Limited, Lucknow. She has come all the way from Lucknow. Welcome, ma'am. She has done her MBBS and pathology studies from Aligarh Muslim University, and she has passed all the exams with first division. She has a vast teaching experience also. She is a teacher at PDM group of institutes. She is working as a associate professor there. She has been efficiently working in various laboratories in the field of clinical pathology, histopathology, cytopathology, and immunohistochemistry, and immunofluorescence, and blood bank using state-of-art latest equipments. She has many poster presentations in many of the conferences, and she has delivered lectures in many important conferences and CMAs. With this short introduction, I welcome Dr. Anam Fatima Siddiqui to deliver her talk.
So good morning, everyone. Thank you for the kind introduction. And I would like to take this opportunity to thank IMA Pune for giving me an opportunity to speak at such a platform, and also giving me a chance to visit your beautiful city for the first time. So thank you so much for this opportunity. With this, I would like to start my brief presentation through thick and thin, a state and an overview of hypercoagulability in COVID-19 patients, since this is a burning topic for the past 2 years, forced us into lockdown and challenged us as clinicians and as diagnosticians. So let's start this topic, hypercoagulability in COVID-19 patients. So in very brief, SARS-CoV-19 or coronavirus disease 2019 is a contagious disease, like we all know, caused by severe acute respiratory syndrome coronavirus 2. And the first case, as we all are aware, was detected in China in the city of Wuhan in December 2019. The disease has since spread worldwide. First cases in India were reported in late 2019, early 2020, and has since forced us into a state of pandemic, has changed our lives forever, and even changed how we conduct these CMEs now. So as of now, as of last week when I was making this presentation, as per the WHO site, the situation update is as such. In India, where we were thinking that 100 cases were a lot, today we have reached this grim figure. And in the world, we have so many confirmed cases with around a lot of deaths that are still occurring. And even if I go in any gathering, or even if you're visiting any gathering, the first question that we are asked is, okay, when is the next wave coming? So of course, we don't have any answer for that. And what answer I give, and I think a lot of our colleagues give, is let's just hope we are better prepared for the next wave. That's all we can hope for. And let's hope that these numbers at least get some stability now. This is the situation report as of 9th March in India. It's active. India's active caseload at that time was around 46,000 cases. This has been going down. That is a positive sign for us. Active recovery rate is currently at 98%. And as of 9th March, there were only 4,575 new cases, which has gone down as per the recent stats to around 2,000 cases that we are detecting per day now. As the active case trajectory graph goes, this is what is being projected as the second wave, the terrible wave that we faced last year, where we were challenged immensely, our patients, our skills, our capabilities. And this is, of course, the wave that we faced together during late of last year and beginning of this year, that has steadily gone down. So let's talk a little about the nuisance, the coronavirus, the structure. So of course, the major structural proteins, as we're all aware, first and foremost is the spike glycoprotein, which is what a lot of vaccine makers have targeted, which we use for the detection of spike antibodies or neutralizing antibodies for the detection of immunity. Then, of course, we have membrane protein. That is the most abundant viral protein, the most abundant structural protein of coronavirus. The envelope glycoprotein, that has the characteristic of being the smallest among the major structural proteins. The nucleocapsid protein, as well as the genetic material, which is a single-stranded positive sense RNA strand. This is all encased in a lipid bilayer. So now coming on to the most important, that is the COVID-19 pathogenesis. This has been discussed extensively. We are all very well aware of what happens when the virus enters the body. So it enters the epithelial cells either via endocytosis or by membrane fusion, usually by the ACE2 receptor that are abundantly present in the body, more so in the lungs and the pneumocyte. The viral RNA uses the machinery of the cell in order to replicate, and it replicates its RNA and its major proteins. So it's proteins that are the major proteins that we had just discussed, the spike protein, the envelope protein, the M protein. They assemble in the rough endoplasmic reticulum of the host cell of the viral pneumocyte, of the host pneumocyte, and they assemble in the rough endoplasmic reticulum. The viral proteins as well as the nucleocapsid, then they assemble in the rough endoplasmic reticulum as well as Golgi apparatus to form something known as the EGRIC complex, which is then released. So when this is released, it leads to activation of a lot of the immune responses and a lot of the inflammatory cells, such as the macrophages, the monocytes, the dendritic cell, as well as other epithelial cells. This leads to release of a lot of chemical substances or cytokines, which are in turn responsible for the activation of a lot of the immune responses. So there is an activation of a lot of the immune cells, the CD4 cells, the CD8 T cells, the B cells, which then are converted to memory cells and plasma cells, which are then responsible for the formation of antibodies, which are protective, somewhat protective against this disease. So we look at the effect of all these inflammatory cytokines and the cells further. So after presentation by the antigenic presenting cells, there is release of and activation of a vast majority of inflammatory cells. Like I had shown in the previous slide, B cells mature into the plasma cells, and they are responsible for the formation of antibodies against SARS-CoV-2. And these antibodies are responsible for a lot of effects ranging from viral neutralization, antibody-dependent cellular cytotoxicity, cellular phagocytosis, as well as complement activation. T helper cells interact with the B cells to enhance survival and provide cell health for antibody production. CD8 cytotoxic T cells release granzymes, perforin, interferon gamma, TNF alpha, and fast ligand expression. They are somewhat responsible for killing of virally infected cells. Studies are still going on all of this. CD4T1 helper cells again are responsible for the production of cytokines such as interleukin-2, interferon gamma, and TNF alpha. These are responsible for helping CD8 T cells and carrying out their inflammatory processes and killing of virally infected cells. CD4 T helper 2 cells again are responsible for secretion of interleukin-4, interleukin-5, interleukin-13. They help the B cells in the induction of antibodies as well as class switching of antibodies. CD4 T helper 17 cells again release a myriad of inflammatory cytokines. They promote inflammation via neutrophil recruitment and activation and innate cell immunity activation. CD4 regulatory T cells again are responsible for suppression of the inflammation and other T cells that is caused by cytokines. What are the common symptoms? Symptoms seem to change with every wave. In the last wave, I think we were talking about a lot of dermatological symptoms, but common symptoms have always included fever, loss of appetite, fatigue, loss of smell, which was talked about a lot, shortness of breath, cough, coughing up of sputum, muscle aches and pain. In severe disease, patients reported difficulty in walking, confusion, bluish face or lips, coughing up of blood, persistent chest pain, etc. So all of this was symptoms that were related to the respiratory system, but coronavirus didn't really remain limited to the respiratory system. It migrated or it took over other organs of the body, and it led to complications in all the other organs. So some of the commonly associated extrapulmonary manifestations or complications of COVID-19 range from the neurological symptoms to the thromboembolic systems. So in the central nervous system or the neurological system, whenever it was affected, the manifestations, of course, included anosmia, stroke, ageusia, encephalopathy, GB syndrome, acute transverse myelitis. Whenever it was affecting the renal system, acute kidney injury, hematuria, proteinuria, myocarditis, coronary artery disease was some of the manifestations whenever the CVS was affected. GI symptoms included nausea, vomiting, diarrhea, anorexia. Endocrine symptoms included the occurrence of hyperglycemia followed by DKA. Dermatological symptoms, which were reported in a few cases, include urticaria, erythematous rash, petechiae, and purpura. And of course, thromboembolic complications, which I'll be taking up in brief, included deep vein thrombosis, pulmonary embolism, catheter-related thrombosis, and others. So now we move on to the main topic of my talk, that is coagulopathy post-COVID-19. So I would like to begin this topic by talking a little about Virchow's triad. which is the triad that signifies what all can go wrong whenever we are expecting thrombosis in a patient. So since it's a triad, we have 3 factors or 3 states where things can go wrong in order for the patient to develop localized or even generalized hypercoagulability, thrombosis, sorry. So hypercoagulability, vascular damage, and circulatory stasis. So I've also enumerated the various causes that can lead to these 3 states. Hypercoagulability, like we all know, is a consequence of major surgery, major trauma, in certain malignant tumors, in pregnancy, post-pregnancy, infection, sepsis, etc. Vascular damage or endothelial damage can be a result of thrombophlebitis, cellulitis, atherosclerosis, the presence of indwelling catheters for a long time, or the presence of heart valves. Circulatory stasis can be a result of prolonged immobility, venous obstruction, as is seen in the case of obesity, the presence of tumors, the presence of pregnancy, the presence of varicose veins, etc. So if you go through these causes, you'll find that some of these are common risk factors that were responsible for making patients a little high risk for the development of complications, especially thromboembolic complications in COVID-19 patients. So all of the components were somehow affected in patients of COVID-19. Something could go wrong in either of the 3 factors, or they could go wrong in all of the 3 factors. So either it was endothelial injury, it could affect stasis, and it could also cause a hypercoagulable state. So in terms of endothelial injury, there was direct invasion. There could be direct invasion of the endothelial cells by SARS-CoV-2 via the ACE2 receptors, which are also expressed on the endothelial cells. There could be release of inflammatory cytokines like interleukin-6, which somehow affect the endothelial and endothelium and cause injury to the endothelium. Like IL-6, there are other acute phase reactants which can have a similar effect. Then, of course, the presence of indwelling or intravascular catheters for a long time does cause significant endothelial injury. Alternate and lectin complement pathway through the activation of C5b, 9, MAC complex, C4d can cause endothelial injury. Immobilization, prolonged immobilization in patients who are hospitalized or even admitted to the ICU can cause disbalance of Virchow's triad. Again, hypercoagulable state is signified by the presence of elevated von Willebrand factor and factor 8, increased level of D-dimer, elevated fibrinogen, the neutrophil extracellular traps, and prothrombotic microparticles and anionic phospholipids. So we'll cover these things in a short while in detail. So this is a small hypothesis that is still going on, because of course we're studying the disease as every day progresses, about the hypercoagulability that comes that is associated with COVID-19. So it's said that the hypercoagulability is not only associated because of the presence of coagulant or highly coagulant systems, but it is also a result of the direct inflammatory cytokines that are released in this process. So like we've been talking, especially at the start of my talk, that there was a lot of inflammatory cytokines that have been released due to the direct interaction of SARS-CoV virus with the respiratory epithelium or even the epithelium of other organs. So there is release of certain cytokines such as interleukin-1, interleukin-6, interleukin-8. These inflammatory cytokines are responsible for the activation of certain inflammatory cells such as monocytes, neutrophils, other macrophages. This also leads ultimately to the generation of or activation of tissue factor and other procoagulant and cascade, which leads to activation of a protein known as thrombin. What thrombin activation does is it plays a bidirectional role. First of all, of course, it helps in the formation, or it aids in the formation of fibrin clots, but it also activates something known as neutrophil extracellular traps. That is again responsible for aiding in the process of inflammation. And thrombin also is responsible through the PAR pathway for the activation of complement protein C5a. C5a again leads to activation of monocytes, and monocytes again release inflammatory cytokines. So this is a sort of cycle that goes on, and it is an interplay of both the thrombotic pathway as well as the inflammatory pathway. Upon autopsy, most patients suffering from COVID-19 coagulopathy showed micro and microvascular thrombosis. Gross examination of the lungs showed small and firm thrombi in peripheral parenchyma, not only of the lungs, this was seen in a lot of other organs. Microscopic findings of these thrombi demonstrated post-inflammatory capillary injury, capillary congestion with luminal fibrin deposition, as well as angiogenesis. The pathological hallmark of COVID-19 when it comes to hypercoagulability is diffuse small vessel platelet fibrin thrombi and intravascular megakaryocytes in all major organs, including the heart, the lungs, the kidneys, liver, and the mesenteric fat. So now we'll come on to the various individual factors that can contribute to the state of hypercoagulability. So first of all, we'll touch upon localized intravascular coagulopathy. So there was clear evidence of overt clinical DIC in COVID-19 that is still lacking, but there were some laboratory features that pointed to the existence of DIC. However, there was no clinical evidence that DIC is taking place in this patient. So it is possible that laboratory abnormalities noted are a reflection of a localized effect, a localized type of DIC or a localized coagulopathy in the pulmonary vasculature, resulting from severe alveolar inflammation. Progression of this process to the systemic circulation may explain microthrombotic complications and ensuing multi-organ failure. So there was a study which proposed to label this entire pathophysiology as microvascular COVID lung vessel obstructive thromboinflammatory syndrome or microclots. So it wasn't DIC, it was localized intravascular coagulopathy taking place in the lungs, and this was called as microclots. So what exactly happens in microclots? That there is initial viral damage that occurs in the alveoli, which generates inflammation and local microvascular pulmonary thrombosis. When this happens, this is followed by a more generalized endothelial dysfunction in major organs of the body and thromboinflammation in the microvasculature of the brain, the kidneys, and other organs, leading to a hypercoagulable state and multiple organ failure. Then, of course, the release of inflammatory cytokines, excessive cytokine release is postulated to cause a severe illness that is noted in younger patients without pre-existing conditions. Higher serum levels of several inflammatory cytokines and chemokines have been associated with severe illness and death in multiple studies. Then, of course, there is endothelial activation and dysfunction that can occur through multiple mechanisms, which has been proposed. So these mechanisms include inflammatory cytokines that are generated in pulmonary interstitium and the activation of complement components in the blood, or it can be a direct result of the virus directly infecting the endothelial cells through the ACE2 receptor. And when this happens, it leads to endothelitis, which is in turn a major forerunner to thrombosis. The observation that male sex, obesity, hypertension, and diabetes are poor prognostic factors for severe disease with COVID-19 further supports this theory that there is endothelial dysregulation at baseline in these patients. Mononuclear phagocytes such as monocytes and macrophages are theorized to play a crucial role in the inflammation, and they lead to a cycle of inflammation and thrombosis, like I just explained, seen in COVID-19. Activated monocytes not only release inflammatory cytokines, but also upregulate the expression of tissue factor. Then, of course, talking about netosis, which is a fairly recent concept, or neutrophil extracellular traps. So like we all know, neutrophilia was a prominent feature, and neutrophil lymphocyte ratio as a marker got a lot of prominence during COVID-19. But there was also the presence of neutrophil extracellular traps that were more specific to the development of inflammation and to the development of thrombosis in COVID-19. These are the major differential diagnosis of hypercoagulability seen in COVID-19, in which first and foremost, of course, we have DIC. Then you have hemophagocytic syndrome, antiphospholipid syndrome, thrombotic microangiopathy, or atypical hemolytic uremic syndrome. So these are the various laboratory abnormalities that are seen in these diseases. And even though it's not clearly cut off in these abnormalities, this can serve as a rough guide in helping you make a diagnosis as to why a hypercoagulable state is occurring in this patient. The major differential diagnosis is, of course, acute DIC or acute disseminated intravascular coagulation. And these are the major laboratory findings that can help us in distinguishing between the two. The clinical manifestations of this hypercoagulable state can include mainly venous thrombosis and venous thromboembolism, and to a small extent, arterial thrombosis and arterial thromboembolism. So venous thrombosis expresses itself as VTE, or the presence of pulmonary embolism or deep vein thrombosis. Even if you're using prophylactic anticoagulation, this is sometimes seen in patients who are specially admitted in the intensive care. Arterial thrombosis is seen in a few patients, and it manifests in the form of myocardial infarction, stroke, or the occurrence of microvascular thrombosis. Investigations that patients can be ordered, of course, apart from the routine investigations that we do, that is COVID RT-PCR for the diagnosis. After that, all patients admitted to the hospital with COVID-19 should get a complete blood count, CBC. They should get prothrombin time, activated partial thromboplastin time, fibrinogen, and D-dimer levels at least. High D-dimer and fibrinogen levels, normal or mildly prolonged PT and APTT, mild thrombocytopenia or thrombocytosis, or normal platelet count. These are the findings that are typically seen in patients admitted to the ICU with a hypercoagulable state. Patients with atypical findings such as severe thrombocytopenia or a markedly prolonged PT-APTT require further investigations. Now, talking about one of the investigations that has gained a lot of popularity since the COVID-19 pandemic is, of course, D-dimer, which has shown to be directly proportional to the severity of disease in various studies. So in a study by Kui et al. In 2020, it was showed that a cutoff value of 1.5 micrograms per ml was used to predict VTE. The sensitivity was 85%, specificity was 88.5%, and negative predictive value was 94.7%. According to the American Society of Hematology, a normal D-dimer level may be enough to rule out possibility of pulmonary embolism in most stable COVID-19 patients. And although Yao et al. In their study did not specifically study the correlation between various D-dimer levels and VTE, they showed that D-dimer at a cutoff value of 0.5 micrograms per milliliter was present in more than 70% of patients with COVID-19, and an increase in D-dimer levels correlated significantly with disease severity. But as many COVID-19 patients may present with high levels of D-dimer due to inflammation itself, it is difficult to rule out the occurrence or possibility of VTE based on D-dimer alone. So in that case, additional testing, including ultrasonography of the extremities or computed tomography angiography, that is CTA of the chest, are recommended and should be used readily depending on clinical presentation. Coming on to the other parameter that shows a lot of variation, that is platelet counts. There was a lot of talk initially of COVID-19 presenting with thrombocytopenia, but now various studies confirm that it is not associated with significant thrombocytopenia. In fact, there are higher or normal platelet counts that are seen. That was unusual, and it likely points towards liver activation and thrombopoietin release. Another reason that can contribute to platelet counts being normal or even higher is because platelets can also be, to an extent, considered as an acute phase reactant, such as ferritin, fibrinogen, or C-reactive protein. And since the level of these acute phase reactants are increasing in COVID-19, maybe that is the reason platelet counts also do not go down. The lung-specific entry of SARS-CoV-2 virus also suggests that these platelets are one of the first lines of defense. So that is why there is sometimes the presence of megakaryocytes on autopsy in the lungs on these patients. Now, sometimes we do see lower platelet counts, but a reason cannot be determined as of now. Some authors have suggested the suppression of bone marrow as a possible cause of thrombocytopenia, but this has not been supported by a lower hemoglobin level or a lower white cell count, apart from lymphopenia. A more plausible reason, apart from bone marrow suppression, can be the consumption of platelets to form platelet thrombi, especially in the pulmonary vasculature. Pulmonary microthrombi occur when multiple efforts, including that of the platelets, to stop the infection have not succeeded, and they block the viral invasion. So the microthrombi use up the platelets in order to form the clots in the lung vasculature. So this is the International Society of Thrombosis and Hemostasis guidelines for the treatment, for the management of patients who present with a hypercoagulable state, depending upon the derangements in the investigations. Of course, these guidelines are not set solid. All institutes have their own guidelines. And of course, these guidelines are changing by the day. Our take-home message is very simple. The role of coagulopathy in severe NCP remains to be clarified. We're making strides every day. We're understanding the disease every day. Abnormal coagulation results are associated with poor prognosis. VTE is common in critically ill patients with COVID-19. Workup includes routine testing with CBC, PT, APTT, fibrinogen, and D-dimer. Close monitoring for clinical signs of thrombosis or bleeding is recommended in all patients. And further trials on anticoagulation doses and treatment protocols in patients with COVID-19 are warranted. And we do have a lot of trials that are still going on in various countries for this. So this was all. Thank you for your attention.
Any questions for madam? Yes.
First thing is the viral structure and pathogenesis. In India, which institute studies done?
Sir, right now, we on the study of the structure, we're not allowing private organizations to do it. We just have ICMR that was speaking about the structure because it was mainly responsible for the genomic sequencing. And of course, here we have the National Institute of Virology in Pune that was probably responsible for determining the structure. Yeah, most probably, or where they're having genome sequencing. Like in Lucknow, we had genome sequencing in KGMC. So this is where they could have studied the structure of the virus.
The other thing is regarding myocarditis and cardiomyopathy. What was the incidence and how is the long-term follow-up?
So the incidence of arterial events is not very high in terms of hypercoagulability. It is mainly in the venous thromboembolism and PE. The incidence has ranged. It has a lot of different ranges in different countries. Cardiomyopathy, no, it was MI. It wasn't myocarditis or cardiomyopathy. No, not cardiomyopathy.
There's a question from delegates. How do you diagnose Omicron in laboratory?
Yes, that's a good question. So we do not diagnose Omicron as such. We diagnose SARS-CoV-19, that yes, you are COVID-19 positive. After we report to the authorities that yes, this patient has come out to be SARS-CoV-19 positive, we get a call from the testing authorities that you have to send these samples to genome sequencing labs. In Lucknow, we have KGMC. I think here you send it to National Institute of Virology. You can send it directly to NCDC in Delhi. These are the only institutes that have permission right now to perform genome sequencing. They do not tell us ki ye Omicron nikla, that this was Omicron. They just release their own database, I think. We do not know whether the patient is suffering from Omicron as such.
Yeah.
Yes, sir.
What I've seen, maximum cases of AVN I'm seeing bilateral.
Sorry, sir?
No AVN, avascular necrosis.
Yes, sir.
It is not indicated anywhere in the thing. Somebody may produce a papers very soon.
Yes, sir.
Bilateral young people with both the hip joints, AVN, so many cases I'm seeing.
Yes, sir. Ischemia of the limbs is one of the manifestations that people are seeing. That is AVN of the hip can be related to that. The presence of microthrombi or localized coagulopathy.
Yes, because they give the history of COVID positive infection. Then after a few months, they start getting this particular.
Yes, sir.
Very common.
So this was because of the localized coagulopathy. It's not generalized. It is occurring at some points in the arterial or the venous system.
Very sad, you know.
Yes, sir.
To see them.
Omicron by dropping off the S gene or something, they say.
Yes, sir. Ma'am, we can do
So
that.
approximately you can say it could be that.
It could be. It
You know,
could be.
instead of, because every person cannot be sent for
yes,
the
ma'am.
genome sequence.
Every
So
person.
that way you don't say that the gene, S gene is dropped or something. You report in that or you report only
Ma'am, it
positive.
depends on the kits that we are
You know,
using.
S and N,
Yes,
both
ma'am.
this thing. So you just write one is positive, one is negative, you write?
Usually,
In the report?
out of 3 genes that we test in any COVID, 2 of them have to come out positive.
Okay.
And depending on the kits that we are using, some test the N gene, some test the ORF1 gene, some test the S gene, some test the E gene. So depending on what kit we are using, not a lot of labs in India are using kits that determine the S gene. So, and it is just a probable diagnosis, even if you are using, yes, those can be, yes. But I think all, yes, sir.
अभी the last slide आपने Dr. Fatima बताया ना आपने, the last slide that this particular pattern is changing day by day and every day. So I made a small share on that.
Irshad, sir. Irshad.
2 बरस गए कोविड का सवाल का जवाब ढूंढने में, जब जवाब मिलने लगा तो उसने सवाल ही बदल डाले.
Good one, sir. There's another question from delegates. In young, there is RT-PCR positive, but patient is asymptomatic. So the question is, later on, can they develop some complications? Anybody who has experience?
I think sir shares. I think sir has said the share. You said it very well. No problem, sir.
I got a lot of ortho practice. So what has happened is that whatever cases we have got it, because in the ortho OPD, I'm very frank. So in that we have seen anybody is positive and asymptomatic, not a single person has developed, you see, any complication after the thing is negative, you see. But in a mind, this remains for some time and they come up with something or other, but that is not in related to it.
Post-COVID vaccination, do you have any experience if there were complications? What was the pathology?
I haven't had any experience in complications following post-COVID-19, except for the mild symptoms that patients have after vaccination, the presence of fever, high-grade fever. That's all. I haven't seen any complications post-vaccination.
Thank you, ma'am.
Yes, ma'am. Ma'am, that is again variants are coming up. We're not targeting.
Hello. Yes.
Post-COVID vaccination, post-COVID vaccination, post-COVID vaccination, post-COVID vaccination,
Post-COVID vaccination, something like what we just now heard. It is going on. 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 It is going on.
म्यूट करा.
नाही माझा तर बंदच आहे, फोनच बंद आहे पण त्याच्यावर मी सांगते जॉइन. बंद कर दो. बंद केलं पण माझाही बंद आहे.
Sorry for the disturbance. Okay, now is it all set? Okay, ma'am, you can ask your question.
Again, it was answered by sir also that it is coincidental. And if patients do turn up to be positive, even after vaccination, even after precaution dose, we are getting patients who turn out to be positive. But we have seen that their rate of developing complications, the chance of getting hospitalized has reduced after vaccination. So still encouragement towards vaccination should be done for patients. So at least if you're developing COVID-19, at least you're not going to develop a complicated disease or you're not going to require hospitalization.
Thank you, madam. Thank you for a very lucid presentation on this topic. Now I request Treasurer Trust Board IMA Pune, Dr. Iyer madam to felicitate Dr. Anam.
Come in the center.
Yes, thank you. Thank you. Anam. Our next topic is on embolism, a comprehensive overview by renowned physician, Dr. Abhijit Joshi. Dr. Abhijit Joshi is internal medicine consultant at Joshi Hospital, Ratna Memorial Hospital, and Pune Hospital. He's been trained in echocardiography. He is DNB in general medicine. He has worked as in charge coronary care unit and consulting physician at Joshi Hospital between 2012 to 2018. And he has also worked as a consulting physician at Joshi Nursing Home. And he has worked as ETU in charge and registrar of ICU and as a panel consultant at Pune Hospital and Research Center. Dr. Joshi has leadership qualities and he has managed many ICUs and trauma units in the city of Pune. He has many research and paper presentations in many conferences. He is a life member of IMA as well as IAP. With this short introduction, I request Dr. Abhijit Joshi to present his talk. Thank you.
Thank you for the kind introduction. Good morning, everybody. Today, I'll be discussing about embolism and its comprehensive overview. If you have any doubts or inputs, please you can just get up and tell me that. So the basic question is, why don't you bleed to death from a minor injury? And in order to prevent that, there is a complex process called as hemostasis, which takes care of itself. So the objective of today's presentation would be to understand what is hemostasis, what is thrombosis, and what is embolism. So hemostasis. So by definition, if you see, hemo is blood and stasis is to stop. So stopping of the blood or stopping of bleeding rather is the process which is called as hemostasis. Hemostasis is predominantly of two types. One is primary and another secondary. Primary consists of platelet plug formation, and secondary hemostasis consists of a coagulation cascade after the primary platelet formation has happened, which further coagulation cascade is divided into extrinsic and intrinsic. We all have learned in our physiology, and which finally leads to our common pathway. So this is a typical pathway of coagulation or a clotting cascade. Whenever there is a wound, there is a secretion of tissue factor. Now, once this tissue factor comes in contact with factor 7A, here the factors of coagulation are been denoted as numericals, as Roman letters, and the alphabet, small alphabet, consists of activated form. So factor 7A along with tissue factor, it basically causes the formation of activated factor 10A. So this is one aspect of it. Another, what tissue factor does is to the extrinsic pathway, it activates factor 9A, This factor 9A along with factor 8A again causes formation of factor 10A. Now, after formation of factor 10A, it along with factor 5A. Now, 10A and 5A are very important factors in coagulation cascade, which causes conversion of prothrombin into an active form called as thrombin. Now, what this thrombin does is it also activates a third pathway, which is more so important in amplifying the hemostatic response in severe hemostatic crisis. This again activates factor 9A. So in terms, there are these three pathways which takes the final conclusion to the thrombin, from conversion of prothrombin to thrombin, and this thrombin helps in converting fibrinogen to fibrin. So that's how the coagulation cascade works, and fibrin causes clot dissolution. So hemostasis, successful hemostasis depends upon four factors. As we all will agree, it is first is the vessel wall and the lining inside the vessel wall. Second is the platelets. Third is the coagulation system. And then after the coagulation has happened, after the clot is formed, there is also fibrolytic system which is responsible for cleaning up the clot in order to ensure that the vessel is open. So what are the phases? Clotting factor, as we all know, is a dynamic, highly interwoven array of multiple processes. To begin with, there are 5 factors which are responsible for this hemostatic process. First and foremost is the vascular spasm, that is vasospasm, vasoconstriction, constriction of the arteries and arterioles which happens in response to the injury. Second is endothelial injury and formation of the platelet plug. Third is propagation of the clotting process by this coagulation cascade. So clotting happens with the help of fibrin, as we all know how the fibrin is formed. Fourth is the termination of the clotting by antithrombotic control mechanisms. And the fifth and the last one is the removal of the clot by the process called as fibrinolysis. So all these steps are important, which happens one after another. So something about platelet plug. Now, how it is formed? So platelets are activated once there is an injury. So on that particular side, the platelets are activated to form a platelet plug that provides the initial and the first foremost response for hemostatic response to stop the bleeding. So functional response of these activated platelets causes further adhesion, aggregation, secretion, and also the proagulant activity. So what happens in adhesion typically is there is deposition of platelets on the subendothelial matrix. The second, what happens is once there is a activated platelets at the vascular site, it attracts more and more platelets. So there is platelet-platelet cohesion which happens. Third is there is release of platelet granule proteins, and also there is enhancement of thrombin generation. So in order to, once there is clot which is formed there, so in order to resolve the patency from following the hemostasis, the clot must be organized and it must be retracted from the by the process of proteolytic enzymes called as plasmin. So it usually causes wound healing and further tissue remodeling which happens in response to the plasmin. So plasmin is basically a plasminogen, that is the precursor molecule to the plasmin, and it binds to the fibrin and tissue plasminogen activator. We'll come to know the more about the TPA later on. So the tissue plasminogen activator, or this is a molecule which is predominantly an endothelial cell enzyme, and it is released by various variety of substances which include thrombin, serotonin, and bradykinins, and various other cytokinins as well. So what happens to the blood vessel? They causes constriction. They constrict. There is vasospasm or vasoconstriction, which will restrict the limit the blood loss, which includes arteries, veins, and capillaries. Now platelets, as we have already discussed, it adheres to the damaged vessel wall. They come. There is platelet cohesion which happens, leading to formation of a platelet plug, and then platelet release reactions which happens. There is a formation of adenosine diphosphate. This is basically encompasses the platelet reaction release reaction. Then adenosine diphosphate, thromboxane A2, they cause platelet to aggregate, and also there is activation of platelet factor 3, which is also important in this platelet release action. Platelet factor 3 is also forms an important part in coagulation cascade, and they coalesce to form an aggregate. So basically prothrombin is converted into thrombin, and which is important molecule for formation of fibrin from fibrinogen. So basically, even 1 ml of blood can generate enough thrombin to convert all the fibrinogen in the body to fibrin. It is that potent, and so tight regulation is of absolute importance. And balance of procoagulant and anticoagulant forces eventually leads to an effective clotting mechanism. So how does this coagulation is controlled? There are various factors. Thrombin, it destroys the factor 5 and factor 8. There are thrombin inhibitors, which are natural thrombin inhibitors, which are found are antithrombin 3, alpha 1 antitrypsin, alpha 2 macroglobulin, and protein C and protein S. So we know that these are the causes of inherent coagulant deficiency, which can lead to thrombosis. In the process of fibrinolysis, there is breakdown of the fibrin, that is fibrin clot. And plasminogen along with the help of plasminogen activators causes release of plasmin, which is important in causing fibrinolysis. So fibrinolytic therapy widely used, as we all know, are streptokinase and recombinant tissue plasminogen activator. Endothelium per se causes very important role in coagulation cascade. It has got antithrombotic activators like plasminogen activators, prostacyclin, nitric oxide, and thrombomodulin. Now let's come to thrombosis. So what is thrombosis? Thrombosis by definition is a formation of a solid mass of blood within the circulatory system, within the vasculature. So why does it happen? It happens because of the abnormality, either pathological abnormality or developmental abnormality of the vessel wall. The degenerative or the development or the injury to the vessel by endothelial dysfunction causes formation of atheroma. And also because of direct injury, one of the factors is direct injury, and second is chronic inflammation, which is seen to be causing thrombosis because it disrupts the layer of endothelium. So as we all know that the abnormalities of blood flow either because of stagnation or the turbulence, and abnormalities of the blood component, like sometimes in smokers, in postpartum period, in post-operative period, there is a risk of formation of thrombosis. So these are general appearance of a thrombi. Arterial and venous thrombi look a little different. In arterial, it is usually pale, it is granular, lines of Zahn are seen, of course, microscopically, and it has got lower cell content as compared to the venous thrombi. Now, venous is usually a soft, it is a gelatinous material, looks deep red, and it has got higher cell content. Outcomes of the thrombosis are of two types. One is lysed, it is dissolved, and if it doesn't get dissolved, then it causes propagation, that it further goes and get dislodged and affects the other vasculature. In lysis, there is complete lysis is basically a breakdown. It's complete breakdown of the thrombus, which happens. Fibrinolytic system is active in this case. Blood flow is re-established, and most likely when the thrombi are small, it can go for autolysis. If doesn't get lysed, and if the burden of the thrombi is little bigger as compared in size, then there is a progressive spread of thrombosis. And usually it happens distal to the where the formation of thrombi has happened, that is distal in the vessels. And it predominantly happens proximally in the vein. So outcomes of thrombosis, as we have discussed, organization and recanalization. Organization, it's a reparative process. It is a ingrowth of the fibroblasts and capillaries, similar to what we see in an injury where there is granulation tissue which happens. Lumen remains obstructed whenever there is an organization of the thrombi. And recanalization when blood flow is reestablished, but usually incompletely. There is a partial recanalization which happens, and one or more channels formed through the organizing thrombus. So embolism is when the thrombi, when it breaks, or the part of the thrombus breaks off and it travels through the bloodstream, and it gets lodged distant from where the thrombus is from the thrombus form, that is called as embolism. So emboli is usually a part of thrombi which has broken down. So what are the effects? The effects are on the arterial as well on the venous side. Arterial, it causes ischemia. It can cause, if the ischemia remains further untreated, it can lead to infarction. And the ultimate result depends upon the site of the occlusion and whether there is acuteness or subacute, because in subacute cases there could be formation of collateral, but in acute cases the infarction might set in. In venous, we can find there is congestion, there is edema. Later on, it could lead further to venous infarction or followed by a long phase of ischemia. So by definition, embolism is a blockage of a blood vessel by solid, liquid or gas at a distant site from its origin. More than 90% of these emboli are usually thromboembolic in nature. So we all know what is virtuous triad. There are three factors which are responsible for any kind of clot to happen or thrombosis to happen. So this is the major theory relating the pathogenesis of venous thromboembolism, often called as virtuous triad. And basically what it proposes is that you require three things. One is stasis, that is there has to be some alteration in the blood flow. Second is there has to be some vascular endothelial injury. And third, any of the alteration in the constituents of the blood, either inherited or acquired. We all know inherited deficiencies are protein C, protein S deficiencies, antithrombin 3 deficiency, alpha-1 antitrypsin deficiency. And about the acquired states are prolonged immobilization, especially in females who are on oral contraceptive pills. Then there is some infection which can lead to bedbound state, which can lead to, again, recent surgery is one of the things, recent orthopedic procedures is another such acquired hypercoagulable state. So other types are air, embolism are air, amniotic fluid, medical equipments causing embolism, and tumor cells or active cancer. From thromboemboli, from the systemic veins, it passes to the lungs to cause pulmonary emboli. So in each and every case of pulmonary embolization, there is usually a distal or a proximal DVT which is usually seen. It is very unlikely that directly, if there is no source which is found, either it is very rare not to find any source in case of pulmonary embolism. So from the heart, it passes via the aorta to the renal, mesenteric, and other femoral arteries. From the atheromatous carotid arteries passes to the brain, where there is a carotid plaque which gets dislodged and get lodged into either MCA or ACA territory, which causes infarcts. And from atheromatous abdominal aortic aorta, it passes to the arteries or to the legs, or distal limb ischemia, which can happen because of atheromatous abdominal aorta. So in case of deep venous thrombosis, there are certain predisposing factors, and which are commonly immobility, prolonged immobility, or bed rest in patients who have got who are in a post-operative state where there is not much mobilization which is happening, in pregnancy and postpartum period, in patients who are on oral contraceptive pills, in cases of severe burns, in patients who had cardiac failure, and in patients who have disseminated cancer or active malignancy. So venous thromboembolism, it remains a major health problem. Why? Because apart from causing sudden death, the 30%, almost 30% of the survivors develop recurrent VT within 10 years, which is a high number. 28% of survivors develop venous stasis syndrome within 20 years. So this comes with not just short-term, but also long-term repercussions. So the primary objective of anticoagulation in prevention of further thrombosis and of early and late complications, it can certainly, if we can preemptively avoid causing causing embolism, it would be of great help, because not just because of the avoidance of acute complication, but as we just discussed, also it helps in reducing the long-term complications. So what are the early complications? From clot extension, early anticoagulation can reduce the chances of further clot extension. Acute pulmonary embolism is avoidable, and major bleeding from anticoagulation and death. Late complications, recurrent clot, post-thrombotic or post-phlebitic syndrome, and chronic thromboembolic pulmonary hypertension. So can DVT be prevented? Yes, in high-risk patients must be identified and they should be offered anticoagulation prophylaxis. It can be provided both by by pharmacological and non-pharmacological means. Pharmacological means by giving them heparin subcutaneously, and non-pharmacological, most common what we use is leg compressions and DVT stockings, or nowadays cuff pump as well. So can DVT be prevented? Again, by intravenous heparin and pharmacologically by giving, offering them anticoagulation. So patients at risk of extension from proximal veins. So patients who have distal DVTs, distal DVT is distal venous venous thrombosis. Those patients who are at risk of extension to the proximal side is patients who have an unprovoked DVT, that is, who have no provoking situation or provoking condition which has led to DVT. D-dimer, which is done, which is more than 500. Extensive thrombosis involving the multiple veins, that should be more than 5 centimeters in length and more than 7 mm in diameter. Thrombosis close to the proximal veins. The next is persistent irreversible risk factors such as active cancer. Prior DVT or in P, there is always the risk of extension, prolonged immobility, inpatient status, and COVID-19. Again, the treatment, the primary objective of the treatment of DVT is to prevent and treat the clot extension and prevention of developing acute pulmonary embolism. It is also important in reducing the risk of recurrent thrombosis. The treatment of massive iliofemoral thrombosis with acute limb ischemia or venous gangrene, which is called as phlegmasia cerulean indolens, which is a severe case of digital ischemia caused because of massive iliofemoral thrombosis, limiting the development of late complications such as we discussed earlier, post-phlebitic syndrome, chronic venous insufficiency, and chronic thromboembolic pulmonary hypertension, which is quite catastrophic and disabling, basically, more than catastrophic. Anticoagulant therapy is indicated for symptomatic proximal DVT. Since pulmonary embolism, maximum times it happens because of proximal DVTs as compared to distal DVTs. Almost in 50% of patients who are untreated, and most within days or weeks of the event. So how do we select an agent? So, and what are the options available in front of us as far as anticoagulation is concerned? The most common what we use is subcutaneous insulin or low molecular weight subcutaneous insulin. There is fondoxaperoneus is a direct or is a basically factor XA inhibitor, which is found in the form of fondoxaperonox. The advantage of low molecular weights versus fondoxaperonox is the once a day dosing with fondoxy. Fondoxaperonox can be given once a day. The other oral factor XA inhibitors, factor 10A inhibitors, are rivaroxaban and apixaban, and unfractionated heparin. And also old and gold standard, which is warfarin. And now the decision between these agents is usually made on the basis of the patient profile, which is what is the risk of bleeding, what are the patient's associated comorbidities, what is the preference of the patient after giving him the option, along with the cost and the convenience. So this is the treatment of, I don't think it's a very clear slide, but I'll just go through it. The treatment of proximal deep venous thrombosis of lower extremity, how to go about it. It's a simple flow chart. The proximal deep venous thrombosis, once it is detected, is there any evidence of risk for early limb ischemia? That's what we need to see by clinical examination. If there is none, then if there is no contraindication to anticoagulation, the patient should be offered anticoagulation. Now, patients who are not, there is a contraindication or there is a recent surgery, intracranial bleed, in those patients you cannot give, unfortunately, any kind of anticoagulation. In those patients who have got proximal DVT, we have an option of giving them of IVC filter. So inferior vena cava filter, it's a device which can be fitted in the femoral vein, which is a mechanical means of filtering the thrombi which comes from the lower limb. Unfortunately, you can't do about already where the thromboembolism has happened. If the P has already happened, you can't do much, but the further flow of thrombi can be arrested by using a IVC filter. Only those patients where there is contraindication for anticoagulation. And also, if there is no contraindication for anticoagulation, then anticoagulation therapy for 3 months should be offered in patients who have got provoked DVT. Now, if there is evidence of limb ischemia, his early limb ischemia is there, the patient limb looks in jeopardy, then there is, and if there is no contraindication, then what the therapy should be offered is a thrombolysis. But explaining them that there could be high risk of bleeding in the case of thrombolysis. There are two types of thrombolytic therapies which can be offered. One is whenever there is a high risk, in case we are anticipating high risk of a thrombolysis, the gold standard is catheter directed, where there 1/10 of the dose is required, almost very negligible dose is required as compared to systemic thrombolysis. So it's basically a little challenging thing because you have to organize a cath lab. It should be done by a knowledgeable operator who has got experience. So it's catheter directed therapy of thrombolysis, where a thrombus which can be located and directly with the help of endovascular device, it can be delivered there at the site of clot or a thrombus, which is called a catheter directed thrombolytic therapy. And if not, then the surgical thrombectomy followed by IVC filter placement. So if those patients where you can't give them anticoagulation, at the same time the thromboembolism has happened in the pulmonary vasculature, and by putting a IVC filter, you can further down reduce the chances of further thrombi, but existent thrombi cannot be dealt with. In those patients, surgical thrombectomy can be offered. And of course, this catheter-directed therapy should be followed by 3 months of anticoagulation. So this is where the factors that influence the agents, which agents to be chosen in which conditions. So this is briefly in patients who have got active malignancy, low molecular weight is preferred over any kind of other anticoagulant. In patients where the parenteral therapy is to be avoided or contraindicated, where their direct thrombin inhibitors like rivaroxaban can be used. Once daily, if somebody wants one single daily dose, they don't want a complication of managing the monitoring the INR, or they are living at a distant place where the laboratory facilities are not available. And also there should be a significant linear kind of anticoagulation effect. Then once a day option is only rivaroxaban and also vitamin K antagonist. If the patient has got underlying hepatic dysfunction or hepatocellular or chronic liver disease, or he has got tendency for any kind of coagulopathy, then low molecular weight heparin should be used. Because in those patients, direct oral anticoagulants are contraindicated because INR is raised. And vitamin K antagonists are difficult to control INR because INR, one thing about vitamin K antagonists is you have to adjust the dose so that the INR is maintained between 2 and 2.5. But in hepatic dysfunction patients, anyways, because of vitamin K deficiency, they have INR which is deranged at the baseline. And this is about hepatic dysfunction. Also in renal dysfunction, usually low molecular weights are contraindicated. Low molecular weight heparin is contraindicated. Vitamin K antagonist can be given. You can still give low molecular weight heparin if the creatinine clearance is more than 45, but less than 45 up to 30 and less than 30, it is usually contraindicated. In coronary artery disease, again, we can use vitamin K antagonist, rivaroxaban, and apixaban. In patients who have got dyspepsia or history of GI bleeding, again, the choice is between vitamin K antagonists because you can monitor them, and also there is antidote which is available. And again, it's a very difficult category where the patient's compliance is poor. I don't think we are comfortable using either of the agents, but what literature says is vitamin K antagonist, because INR monitoring can help to detect the problems, whether he is taking regularly or not, as compared to in patients who are on these newer direct oral anticoagulants. You cannot gauge whether the patient is taking regularly the medication offered to him or not. So that is one. And pregnancy, again, low molecular weight heparin is the only thing which we can, which is indicated. So inferior vena cava is recommended when there is a contraindication to or failure of anticoagulant therapy, where the anticoagulant therapy has been offered, but because of some genetic predisposition, you are not in a position to offer him good results with oral anticoagulant therapy, or or in an individual where there is a high risk for proximal vein thrombosis or pulmonary embolism. So it is also recommended in patients with recurrent thromboembolism despite adequate anticoagulation, and for chronic recurrent embolism with pulmonary hypertension. Because we all know that small emboli can go and dislodge into the pulmonary vasculature, causing long-term chronic thromboembolic pulmonary hypertension, where the only treatment possible is pulmonary thromboendarterectomy, which is quite a morbid procedure to do. So this is a device which is like a pronged structure, and once this goes here inside, this can be inflated. Endovascular device for DVT prophylaxis. Again, oral anticoagulation with warfarin should prolong the INR to a target of between 2 and 3. If oral anticoagulants are contraindicated or inconvenient, long-term therapy can be undertaken with either the adjusted dose unfractionated or low molecular weight heparin or fondoxypirinox. And once anticoagulation has been started, patient symptoms are under control. Early ambulation is what is advisable. Now coming to pulmonary embolism. The pulmonary embolism refers to obstruction of pulmonary vasculature artery of its branches by material which could be thrombus, which can be air, tumor, or fat that can be originated in anywhere in the body, elsewhere in the body rather. It is further divided into massive or submassive. Massive pulmonary embolism is where the patient is obviously having four things. One is he is severely breathless enough to cause hypoxemia. Second is there is hemodynamic compromise which has happened. He is in hypotension. So hypotension and hypoxemia patients are categorized into massive P and they require urgent attention. The rest of the categories are submassive, which further includes acute, subacute, and chronic. Acute, where the patient develops symptoms and signs immediately after obstruction of pulmonary vessels. Subacute within days or weeks following the initial event. And chronic, where patient remains slowly develop the symptoms of pulmonary hypertension over many years, that is chronic thromboembolic pulmonary hypertension. So massive P, more than 60% of reduction in the blood flow, rapidly fatal. Major P, medium-sized vessels are blocked. Patient short of breath, they have cough, and sometimes there is also hemostasis, which is noted. In minor P, small peripheral pulmonary arteries are blocked, asymptomatic, or they present with exertional breathlessness or minor shortness of breath issues. And recurrent minor P's lead to pulmonary hypertension. So what is the pathophysiological response to P? First and foremost is infarction. So 10% of the patients with small thrombi, they can lodge distal into the segmental and subsegmental pulmonary arteries, pulmonary vasculature in the pulmonary, causing pulmonary infarction. Now, typically it causes pleuritic chest pain and hemoptysis. There is also hypoxemia, which ensues because of abnormal gas exchange in case of pulmonary embolism. And third is the cardiovascular compromise, that is hypotension can ensue because of a massive pulmonary embolism, which usually involves the main pulmonary artery and two of its branches, either the left or the right or the left, main pulmonary artery. Predominantly hypotension is due to the diminished stroke volume and cardiac output. So this is where the whenever there is a clinical suspicion of pulmonary embolism, we have to categorize them into low or moderate or high risk. Now, there are a few criteria which we can use in order to ascertain whether the patient has low or moderate risk factors or whether they have high risk factors. If there is low or moderate risk, where the pretest probability is very less. So we know that patient who have never had a history of DVT or who is not immobilized or who is relatively young or who has no other comorbidities, they fall into low or a moderate grade criteria, where if there is basis on the suspicion of pulmonary embolism, you offer them a test which is called a D-dimer. Now, if the D-dimer is normal, there is no treatment as negative, because we all know and we will all agree that D-dimer is a test which has got good negative diagnostic value, where if the negative test virtually rules out pulmonary embolism. But if it is positive, it might be or might not be pulmonary embolism. So in the clinical context, we have to further investigate that. But if it is negative, and I think 2 tests repeated few hours apart, they give us a good result where you can virtually rule out pulmonary embolism. If the ELISA or D-dimer is negative, is abnormal, then further we go for chest radiography. If it is normal, then what do we do? And still, if we are suspicious that the patient has pulmonary embolism, 2D echo is one of the bedside investigations which we use to check whether the patient has got any dilatation of the right side of the RA or the RV, along with any RV dysfunction which is there. Also, you can see in massive or submassive P, there is in IVC, that is inferior vena cava, which is distended and non-collapsible, which is a bedside investigation which can tell us at least there is some stain on the right ventricle. Again, then VQ scan can be advised. If it is again normal, there is nothing to be done. If it is high probability of pulmonary embolism on VQ scan, the treatment should be offered. And if it is non-diagnostic, then additional testing should be done, like a chest CT arteriography. Now, what we see on chest CT is pulmonary embolism is absent on chest CT. High clinical suspicion, again, additional testing should be done. But if it is pulmonary embolism which is seen, pulmonary vasculature usually shows that there is a thrombus in either of the right or left pulmonary artery, they should be offered treatment with anticoagulation. Now, this is a Wells criteria or a score which suggests this is a clinical probability score. What it suggests is it takes into consideration these 7 factors. One is signs and symptoms, and points are being given. That is, for signs and symptoms of deep venous thrombosis, there are 3 points which are awarded. If the heart rate is more than 100 at rest, that is resting tachycardia, again you have 1.5 points. There is a recent immobilization of surgery, which is less than 4 weeks, again 1.5 is accorded. Previous history of deep venous thrombosis or pulmonary embolism, hemostasis, whether the patient has active malignancy or who has taken the treatment for malignancy recently, and pulmonary embolism more likely than the alternative diagnosis. So all these factors needs to be considered while calculating the clinical probability score. If the score is less than 2 or intermediate, that is 2 to 6, then D-dimer assay should be done, which is highly sensitive. If it is negative, do not treat. We don't need to treat these patients. If it is a high risk, these points are more than 6. So if, for example, if the patient has signs and symptoms of deep venous thrombosis, the patient is having tachycardia, and if he has a history of recent immobilization, and also either one of them, whether they have some hemostasis or high chances of pulmonary embolism, then they should be offered HRCT with CT pulmonary angio. No pulmonary embolism seen, again, do not treat. This is a gold standard investigation. If doesn't detect anything on like pulmonary embolism, we don't have to treat. And if the pulmonary embolism is detected, of course, we have to treat. Again, this is the similar chart where it is once it is diagnosed, what to do. Once it is diagnosed, anticoagulation is contraindicated. We have to consider inferior vena cava filter and anticoagulation when safe. The second is anticoagulation if it is not contraindicated. Now we have to check whether the patient has got hemodynamic instability or not. If there is hemodynamic instability, if there is no instability, we should check right ventricular dysfunction. If there is no RV dysfunction, we can straight away continue with anticoagulation only. If there is RV dysfunction, consider thrombolytic therapy, because these are the patients who might go into shock later on. If there is hemodynamic instability to begin with, then fluid administration to improve the preload, and SOS if required, vasopressors, and to offer them thrombolytic therapy if not contraindicated. If it is contraindicated, then the surgical embolectomy is the only thing which we can do. So again, P versus chronic, massive versus submassive. So classification of saddle P is a P that lodges at the bifurcation of the main pulmonary artery, as we can see it here. At the bifurcation, this is the saddle pulmonary artery. Most saddle are submassive, and only 2 of the patients with saddle P had hypotension. This is just a so P is associated with mortality rate of approximately 30%, which is quite high without treatment and primarily due to recurrent embolism. However, accurate diagnosis followed by effective anticoagulant therapy decreases the mortality from 30% to almost 2%. So, which is also a significant leap. So, what are the poor prognostic markers of pulmonary embolism? If you see these patients are having elevated brain natriuretic peptide, you understand the patient already had a RV strain, which is caused which is causing elevated brain natriuretic peptide. Whether the patient has right ventricular dysfunction on 2D echocardiography, patient has hypotension, RV thrombus if it can be seen, and elevated tropi, whether the pulmonary infarction has already happened. So these are all poor prognostic markers. P2 pathophysiology, most P arises from thrombi in the deep venous system of the lower extremity. However, they may originate in the right heart or the pelvic, renal, and upper extremity also, but although they are rare. Iliofemoral are the commonest source. Estimated that 50 to 80% of iliac, femoral, and popliteal vein thrombi originate below the popliteal vein, that is distal, that is calf vein thrombi, and they propagate proximally. The remainder arises from the proximal vein. Fortunately, the most calf vein resolves spontaneously, and only 20 to 30% of distal thrombi end up causing proximal vein occlusion. So after traveling to the lung, the thrombi may get lodged in the bifurcation of main pulmonary vasculature or one of its lower branches, causing hemodynamic compromise. And smaller can continue traveling distally and more likely to cause pleuritic chest pain. And presumably by initiating the inflammatory response adjacent to the parietal pleura. So only 10% of these emboli causes pulmonary infarction actually. So usually in the patients with pre-existing cardiopulmonary diseases, and most emboli are multiple with lower lobe being involved in the majority of the cases. Impaired gas exchange, that is hypoxia due to PE, cannot be explained solely on the basis of mechanical obstruction, because also there is alteration in the ventilation perfusion ratio. The gas exchange abnormalities are related to the release of various inflammatory mediators, cytokinins, resulting in surfactant dysfunction. There is atelectasis and functional intrapulmonary shunting. So it's basically PE is a common complication which can happen in patients with DVT, occurring in more than 50% of patients with phlebographically confirmed DVT. This suggests that the factors that promote the development of DVT also increases or entails the risk of pulmonary embolism. Again, additional risk factors in women: obesity, BMI more than 29, heavy cigarette smoking, and hypertension, along with the traditional factors. So this is one case which we'll discuss. A 22-year-old thin female student on oral contraceptive pill presents to clinic with painless right calf swelling. She has elevated her leg 2 days due to right ankle sprain during the soccer game. No prior medical history, no recent surgery or weight change. She does not smoke or drink and drinks rarely. On exam, her calf is 1.5 centimeter larger than the left. So obviously there is swelling. She has three risk factors, which are they? She's on OC pills. Second, there is history of trauma, and third, there is immobilization. So her well scores gives her a moderate risk score, which is between 2 and 6 for DVT. So D-dimer test was advised. She has a positive quantitative ELISA. So an imaging study was done. So imaging wise, available imaging and ancillary test: compression ultrasound, first line with high sensitivity and specificity. Venogram is gold standard if possible. MRI apparently lower quality evidence only at present. So compressive ultrasound was done, and which was negative. There wasn't any evidence of DVT. Options include what to do if you still suspect. Then venography, CT venography is one of the options. Serial compression ultrasound. Now single ultrasound done at 5 to 7 days reliably excludes calf vein DVT, because if it has to progress, it will progress within 2 to 7 days. And follow clinically for resolution of symptoms. Riskier no data supporting safety data, because you want to see whether the swelling is subsiding and symptomatically she is getting better. But apparently the patient elected to be followed clinically. She returned to the clinic 3 days later with persistent. She was treated the following week, but instead you are called to the ER 10 days later after she presented with acute onset dyspnea and pleuritic chest pain. So what has happened? Findings: alert while anxious. She has got obviously temperature of 101 with tachycardia. Right lower limb edema and redness was there. Lungs was clear on auscultation. ABG showed mild respiratory alkalosis and no hypoxia. Chest X-ray showed mild atelectasis, and D-dimer positive as before, and troponin were normal. The CT which was done showed embolus, segmental embolus, and therapy with enoxaparin in the dose of 1 milligram per kg every 12 hourly. Subcutaneous was started for 5 days. Warfarin was started from day 1 because you require overlap with normal pivot, because the PT INR with or the INR which needs to be maintained is between 2 and 3, which doesn't happen overnight because it takes some time to build that INR. Till that time, low molecular weight should be continued. And anticoagulant treatment is basically same for DVT and P, as we have already discussed. Compression stockings prevent post-phlebotomic syndrome, so it should be advocated for patients who had got significant swelling to use compression class 2 stockings. And thrombolysis gives benefit, uncertain clinical outcome, generally not improved. So it is only indicated and reserved for patients who has got massive pulmonary embolism where there is shock and hypoxemia, not for otherwise. And Venous filter, limited evidence and modest benefit, especially for those who have got contraindication for anticoagulation and thrombolytic therapy. And in few patients who developed recurrent DVT in spite of adequate anticoagulation. Thank you.
Thank you, sir, for excellent presentation of pathophysiology as well as the medical line of treatment part of pulmonary embolism and embolism, a comprehensive overview. Any questions? Yes, sir.
It depends upon 2 factors, whether the inciting events, whether it is a provoked DVT or not. In cases there is a provoked DVT, which is immobilization caused by some medical illness, or there is a history of trauma, or whether the patient was taking certain drug which predisposed, then the duration is 3 months. 3 months of anticoagulation is sufficient. If there is history of, or patient has undergone recent arthroscopy or some embolization happened because of surgically. Otherwise, the data is mixed, whether it's a first presentation of DVT, where there is any permanent risk factors like active malignancy, or if the first DVT is there, then 6 to 9 months of anticoagulation is usually what is suggested. And if there is a second DVT episode, and if there are permanent risk factors, then probably, and if there is a low bleeding risk, then with discussing with the patient itself, it should be offered for lifelong. But otherwise, for provoked DVT, 3 months is sufficient.
Doctors who are practicing in the clinic for the post-DVT patients? What will be your protocol? What you must see and when we should refer to you?
For patients who have undergone DVT, suppose proximal DVT and the patient is on anticoagulation, 2 things needs to be seen, whether the significant swelling which was there at the presentation, whether it is gradually subsiding or not. And the second is whether they are developing any kind of compartment syndrome, or whether they are developing any limb ischemia even after anticoagulation. So those are the patients where surgical embolectomy or something apart from anticoagulation needs to be done. And whether clinical resolution signs, whether there is redness which has gone down, whether there is swelling and tenderness of a particular limb which is going down, that needs to be seen.
Second question. Now, whenever
last thing is, if the patient is on warfarin, so whether the INR which is maintained between 2 and 2.5, because otherwise patients can keep taking warfarin, and if it is not in the therapeutic range, then the effect is only modest. There is a chance that even in spite of being on warfarin, if the INR is not maintained in the therapeutic range, they can still have recurrent embolism.
second is, what is the role of low molecular heparin or just aspirin in this? Sorry, aspirin.
Aspirin has no role in anticoagulation. Aspirin is an antiplatelet. So it doesn't have any role in anticoagulation.
What happens is that when we put a plaster above knee or below knee, all right, we always have that pincher in the mind. When patient says after 3 days, amala खूप गच्च वाटतं, then we always have palpitations.
But that is also about 2 factors. If there is immobilization and there is no content, if you think that that plaster is going to remain for a long time, and also it is just below knee, then the active calf movements can be done in spite he being in the plaster. So that should be encouraged, number one. And number two, if the patient is obese and if he has got other risk factors to develop a DVT, then the consideration should be given for prophylactic anticoagulation for at least a duration of plaster. Of course, it has to be seen in clinical context whether the particular patient has other risk factors for developing the distal DVT.
So this oral Xarelto stops suddenly or gradually after 3 months?
It can be stopped suddenly.
And the case you showed, the color Doppler was negative for thrombosis, correct?
First color Doppler was negative.
And
Hence the second CT was done.
second,
CT was done.
so there was no second color Doppler.
Second, color Dopplers might not see, especially in obese people. Again, you might not be able to see the vasculature very, very clearly. So there are certain certain limitations of peripheral color Doppler also. So in those patients, whenever you are in doubt, you should get an CT peripheral venous angio done.
Okay.
Especially in the patient who had got provoking situation, D-dimer positive and ultrasound not showing anything.
Okay. So when in doubt, get D-dimer also done along with color Doppler.
Yes.
Silent DVTs, which are in general population.
They
I operate a case of hernia or vascular. What is your
So there is a huge number of patients who have developed silent DVTs, and we only come to know about their earlier histories of DVT when we see their pulmonary hypertension. So in routine echoes, when we see the patient as having exertional dyspnea and there is no other cause is found, only the patient has got moderate TR and severe PH. And otherwise, they never had any history of DVT, where there are smaller embolism which causes from the peripheral veins and go and get dislodged in the pulmonary vasculature, causing chronic thromboembolic pulmonary hypertension. So in this patient, there is no documented DVT which has happened. But eventually, what is the culmination of so many years of recurrent small embolism is small thrombi is chronic thromboembolic pulmonary hypertension. So that itself is a very disabling condition. Unfortunately, we don't have any evidence to how to reduce that incidence of chronic CTPH. Unless and until somebody has one index event, nobody will have any suspicion. Yes. So these are silent thrombosis where we are not found any clinical evidence, but if after 10 years down the line, they develop thromboembolic pulmonary hypertension. Thank you everybody.
Now I request President Dr. B.L. Deshmukh sir to felicitate Dr. Abhijit Joshi. Thank you, sir. Friends, since morning, we have been learning about the advances in modern pathology, about the post-COVID hypercoagulability and embolism. Now, we have a little different topic to come up. The next topic is current medico-legal scenarios. And to present this very important current topic, we have none other than our medico-legal expert, Fatima of IMA Pune, and senior pediatrician, Dr. Jayant Naurange sir.
साईज मध्ये बरंच फरक आहे. डॉक्टर देशमुखांचं आज लास्ट CME आहे त्यांच्या पिरियड मधला ॲज अ प्रेसिडेंट, आणि मे आय रिक्वेस्ट डॉक्टर देशमुख to preside over the function as a chairman, because I don't see any chairman over there, and I request our beloved Executive Trustee Dr. Sanjay Patil to be the co-chairperson, because everything is arranged as a moment's notice. And this and this talk is also organized half an hour before and has been completely modified 7 minutes before. So it will be everything new. So thank you very much. Thank you, the organizers, and thanks chairpersons to honor my request to be the chairperson and co-chairperson, because everything has to have a control, because I can go on talking for hours and then it should not obstruct or come in the way of the main diary release program at 12 o'clock. And important guests are also coming. So please keep a time restriction on me. So we will be talking about current medical scenario was the topic I told our secretary, but then last minute I said that I had covered this topic in, I think, 27th of February. So it is better to change the track and go to another situation which IMA Pune has worked for over a period of, I think from 1992 till 2022, almost 30 years now, and has the richest experience amongst all the Indian workers in this field. And the main person who started this medical legal cell, namely Surgeon Dr. Bere, is also coming in a short time. He also doesn't know that I'm going to speak right now. So with all due respects to all those who are present in the audience and also offline, I am starting my talk on handling the medical legal cases, which we had tackled over a period of last 30 years. And what we call as Navneet. Navneet is you take out the most important things after thorough experience, knowledge, and working and studying the problem. And then to the next people listening to you, you are asking them that we are giving the ready-made solutions. You go ahead of this. So that is what I call it as the most important pick points from the experience we have gathered over the last 30 years. So this is a unique combination that both of these are our alma maters. One is BJ Medical College, from where we graduate, and this is the law college. And not a very happy situation, but then many of our colleagues, like Dr. Meenakshi Deshpande, who is the incoming president, Dr. Jape, who is the secretary of this branch, Dr. Raju Doshi, so many are feeling that they should be doing law for medical legal purpose. I'm not saying that they're doing law for family matters or for matrimonial matters or for company matters and all those, nothing like that, just to help the medical legal cause. And we have to know both of these. One of the favorite sentences, one of my close friends and a very intelligent person and a physician, Dr. Mahesh Trupad, used to say that not only you have to be medically correct, you have to be legally correct. At least you should be able to prove that you are legally correct. So two things: medically we have to be sound. I mean, there is no shortcut to that. That's why you have to attend all these conferences, all these CMEs, and I fully endorse the views of Maharashtra Medical Council that you ought to have certain points to again get the renewal of your license, practicing license. That is basic, fundamental. But the current scenario is that you require additional qualifications, not qualification, I'm saying MD, MS, etc. Additional qualifications in your behavior, your understanding, your way of practice, that you have to be legally sound. So medical legal forums commonly sought by the patients, and I have put it oblique. Okay. By the patients, this is one aspect, but today it is also NGOs. NGOs can sue you. They are not direct party to the case. They are not suffered. But for various reasons, NGOs are now allowed, particularly with the advent of consumer commissions. See, certain subtle changes I will explain when we are talking about this issue while answering these litigations or how to handle a medical legal situation. So some of the new points which have come in 2019 July, which got the assent of the President of India in the month of September, that certain major changes have occurred in the Consumer Act itself, which was promulgated in 1986 and then doctors fraternity, medical fraternity came under its purview in 1995. But then radical changes have occurred and which are fairly detrimental, except one, which I will mention, to the doctors or the medical practice. And one of these, of course, this was there right in the beginning, that NGOs are allowed to put a case, though they are not directly affected, against the doctor. Of course, it has to be a registered NGO working in the field of consumerism, etc. So this continues. So NGOs can put a case against us. आपण असं म्हणू शकत नाही तुमचा काय संबंध. They are, for example, ग्राहक पेठ आपल्या स्टेक रोडलाच आहे. Luckily, they know that we are there, and therefore they don't take doctors' cases now. But initially, they had shown their teeth. So consumer, now this used to be called as forum. Now it is called as commission. So this is one small change. I would say just a cosmetic change. Second is patients would approach the criminal. That means the police machinery. So they would put a case against us, or at least a complaint against. They can't put a case, but then complaint against us to the police. So that is the criminal machinery. They can go to, if the police are not happy or they are not registering the case, the patients can go to the magistrates. So also we can also go to the magistrates. I will tell you some cases that will elaborate. Right now, there was a harassment of an ophthalmic surgeon. Somewhere in your area, Viman Nagar or Nagar area, Nagar Road area, where the doctor was unnecessarily getting troubled. A case was of juvenile diabetes. At the age of 34, she had terrible retina. One eye vision had already gone, and the second had a very advanced retinopathy. And anything you do, even if you do laser treatment, the doctor had taken in writing that vision may not be spared. So everything best possible was done. He's himself a retina specialist. And then the harassment started, because she became almost blind in both the eyes. Practically no vision change in the another eye. One eye was already lost. Now, what is the fault of the doctor? What is the negligence of the doctor? But they went on threatening. And then we asked the doctor to go to the magistrate. And that has solved the problem. So it is here whom to approach, when to approach, what to say. These all things are, so even before the patient has gone to the police, we go against the patient that he is unnecessarily troubling me, giving a lot of mental torture, and so on and so forth. And the problem gets very much mitigated. So, of course, these are some of the rare examples. Usually the patients go, the doctors just go on suffering. They don't come to us, they don't come to the association. And when it goes beyond certain limit and the doctor feels that he is getting arrested, likely to be getting arrested, then they approach us. So one should come in time. That's another message. Third harassment today is medical councils. Why I'm saying harassment? Medical councils are our councils, but they are quasi-judicial bodies. So they will not be able to take the side of a doctor. It is not expected also. They are supposed to take the side, both sides into consideration, and then they take a proper decision. Now, medical councils are formed out of you and me from the doctors, and they are quasi-judicial. Quasi means semi. Just like medical personnel, legal teaching is also studied with, the definitions are studied with Latin and Greek. So both these branches are fond of using unnecessarily complicated jargon. So this is quasi-judicial means semi-judicial body. They have all the rights of a civil court, and they can have a limited punishment. But that punishment today we understand as students, I never realized till 1999, we never realized that they have real teeth, that they have the power. They don't give the compensation. They don't award in money terms, but then they can suspend your registration. And suspension of registration as good as professional death. You can't practice. Now, I know of certain radiologists who were unnecessarily caught under PCP NDT, and they have been given a modified sentence that they will practice everything but radiology. Now, you tell me, an MD radiologist, and then the person becomes a clerk in the medical hospitals, major hospitals. So this is the real story. So ultimately, your profession cannot be continued. Anyway, medical councils is a part of civil, but they have the power of temporarily or permanently suspending your registration for the same complaint. Fourth is administrative regulatory bodies, which we are finding more often, like the Pune Municipal Corporation, state governments. They can go on complaining everywhere. Panchayats, Epidemic Act is right now applicable. Disaster Act is also there. So here they can complain that I was not attended to, or the amount should be, the bill should be reduced, or the hospital's license should be cancelled. The next is MTP, PCP, and maternal death, etc. They are specific laws have to be followed not only to the spirit but to the letter also. There are certain laws which have to be followed not only with the spirit of the law but also to the words of the law. एक्झॅक्टली सांगायचं म्हणजे तंतोतंत पाळायला पाहिजे. इथे टिंब पाहिजे म्हणजे इथे टिंब पाहिजे, इथे कॉमा पाहिजे म्हणजे इथे कॉमा पाहिजे. त्याला आर्ग्युमेंटच नाहीये. सो दीज आर सर्टन स्टॅच्युटरी लॉज where there is not much scope for argument. Next is RTI, right to information, human rights, media publicity. आणि ह्याच्या विरुद्ध जवळजवळ आपल्याला या मीडिया बद्दल काही करता येत नाही. परंतु जर तुमच्या विरुद्ध काही abnormal मॅटर टाकलं गेलं ऑन गुगल, on WhatsApp, you can ask them to pull it down, or we will proceed, and usually they are pulled down, Facebook in particular. So this can be done, but by and large the damage is done. 10 te 20 मिनिटांमध्ये you get phone from USA that there is something printed, published against you on the WhatsApp or on the Facebook before you come to know by reading yourself. This has happened time and again in Pune also. So damage is done, but at least further damage may be to some extent. आपल्याला थोडंसं समाधानात्मक की त्यांनी ते खाली आणलं. The wrong post has been pulled down. So that is a little solace. But RTI, it's not, please remember, आपल्याला ना थोड्या गोष्टी माहिती पाहिजे. तो माझ्या आजचा पॉइंट टॉकचा उद्देश आहे. I will be giving you the clues which you should know so that you don't remain under tension unnecessarily. Right to information is not applicable to private practice. So if you receive a notice, throw it in a dustbin. Okay? And if they send you a second reminder, come to me. Nothing is going to happen. Human rights is not going to affect. The Pune activists, now घेऊन सांगतो, अनंत फडके, अरुण गद्रे, या लोकांनी, they tried to pressurize the Human Rights Commission, and they also yielded, saying that private hospitals should come also under privy. The hearing was held at Tata Fundamental Institute of Research at Trombay, and it was ultimately argued very well by doctors, advocates, and the commission had to accept that it does. Initially they had given an opinion that it will be applicable to the private sector also, but they had to go back and said that it is not applicable to the private, though our recommendation is there. The recommendation has remained there for last 10 years. So don't worry, these things don't answer them, throw in the dustbin. Same way, I told you that you should go ahead proactively to the police. So sir, medical councils, don't get frightened. Medical council, nowadays, two things, two changes, Consumer Commission and Medical Council. They are accepting the online complaints. That has created menace. There is a flooding of cases. When you and me have to answer, you have to answer on a stamp paper and in a notarized form. Whereas the complaints which we are seeing last, I talked to the MMC members also, that people are writing on a notebook paper, which has turned yellow. Very dirty language, very foul English, and the person is signing, and you are entertaining these complaints. And for a doctor, you have to put it on 100 rupees, typed letter, this, that, and answer. But then the problem is, because there is no stamp duty, consumer and medical councils, they have to entertain the complaints. They will send you a notice, reply within time, and don't get too much frightened. Take your own time, meet us, draft a proper reply, and then send the answer. Because once you send once, then it just cannot become, I mean, you can't go on modifying it. Usually, now the case comes to us. Usually a lawyer or an NGO or a person sends you a notice of his grievance and claim. This should be taken as forewarning. This should be taken as forewarning. Don't neglect it. It is not at all legally mandatory to answer each and every notice. It is not legally required that you must answer the notice. But then, we and most of the, this I'm again saying we means all of us here working in IMA Pune, feel that we should take a cognizance of it and answer it appropriately, to the point, minimally, not offensive, but at the same time preserving all your rights. Why? Because the courts later on say that the lawyer had sent you a notice and you did not take a cognizance of it. Though it is not mandatory, I'm again mentioning this is a correct legal position that it need not be answered. But it is better. You can say it's a nonsense notice. It is based on wrong assumptions. but give them a reply. There comes the ego matter, because the lawyer feels that even the notice is remaining unanswered, so something wrong must be done by the doctor. So it's a forewarning. Number two, very important point. Whatever is demanded in that notice, 10 lakh rupees diya, 5 lakh rupees diya. Then when they put a case in the court, they cannot exceed that. That is important. They will not be entertained. Ata mala 1 koti diya. No. Once they have put it themselves, ki 10 lakh diya, we are going to fight the case. But in the court, when it goes, they cannot say, now you give me 1 crore rupees. That is not allowed. So keep that notice, preserve it very well. While coming to us, send us, give us the Xerox copy. Don't bring the original, because don't lose that original one. And you preserve that along with the envelope for the date purpose. And who is the sender? The name and contact details. So this is important. Preserve that envelope also. You should answer it to the point. You means you have to take a help. Unless you are a lawyer, don't give any more information that what is really claimed by them, what is asked by them. Answer in a paragraph wise, 1, 2, 3, 4. Wherever first sentence is opening remark is so and so patient had come to you on such and such date. Generally it is correct. So we say, yes, this point is agreed. Finished. Point number 2. You were treating them for so long, agreed. Number 3, like that you have to answer. But the point of negligence, whatever they are saying, that you have to fight. But don't fight here. Give very non-committal, vague answers. Give very non-committal, vague answers and deny everything. And about the compensation, you have to mention that because there is no negligence, the claim of compensation is totally denied. Next paragraph should be, and this is our innovation, that we are ready to take out the, all the doubts or complaints by mutual and open discussion in presence of the lawyers and doctors of their choice at a neutral forum like IMA. Okay, that is important. Last threatening paragraph is very important. 50% of the complaints die down there. Not 50, but 40% die down there. If you are right, if you are upright, your treatment is correct. Wrong result is not negligence. But if you are right, on technical grounds, on medical grounds, we have no hesitation in putting this threatening clause, saying that we preserve the right of counterclaim at the appropriate legal forum. That solves the matter in majority. Next comes is never hand over. Don't volunteer your case papers. Patient ni paper magitle ami deun takle. Don't do that way. Don't do that. Let medical council say, some of the things I'm going overboard, going against the medical council also because I'm going legally. The medical council says hand over your paper in 3 days. Court does not say that way. Court says in reasonable time. See, 3 days cannot be a reasonable time for a 2-year-old case. It cannot be. So that is, you take your own time to find out the suitable records. Whatever was missing, check that why it was missing. You can prepare another note. You can append extra paper, show it to us, show it to the lawyer. Don't hide anything and then submit it. Then once we say, yes, you can submit now, then submit it. Information to the insurer, inform your insurance company immediately on sensing that something they're having a mind to ask for compensation. Inform your insurance company that such and such person is aggrieved and likely a case may come, and take an acknowledgement and preserve in your bank locker. Keep that acknowledgement and preserve it in a bank locker. To defend the case well, we should know that what is meant by medical negligence. This slide you will find always in any of my talks, because this is fundamental. This is the basic, that majority of the cases are of medical negligence pursued by the patient. It is not negligence. It is not proved. What is that? Number 1, there are 3 components of the definition. Unless 3 components are complete, this definition is not mentioned in any law books. There is no such term as medical negligence. It is only derived through several judgments from 1956 onwards. So this has usually come from UK, and that is followed all over the world. then from Australia, from USA, and this is the current position. What is this? That when you call it something as a medical negligence, three components are there. Number one, established doctor-patient relationship. What is meant by established doctor-patient relationship? That means the patient has to come to you voluntarily by reading your name, your board, or your fame, by mouth publicity. Or somebody is recommending. There is no force of law that you must go to this doctor. Now, where is this force? The force of law is there when you go for your insurance checkup, when you go for pre-employment checkup. The company says you have to get it done from him only. Insurance says you have to go to this doctor only. This is not doctor-patient relationship. Or I'm telling you one step further, no judgment has come so far, but I'm expecting. I will fight for them. What is that? A case of road traffic accident, RTA, needs to be treated by the nearby doctor or the hospital to the extent facilities are available. And nobody can deny. It is free of charge. Now, this is forced on the doctors by one Supreme Court judgment that RTA patient must get treatment from the homeopathic. Chalo, at least rush to the, call the ambulance and rush to the hospital. If it is a BMS doctor, they will say, refer it to a proper surgeon. If he is a MBBS doctor having limited facility, iodine bedding, kuch to first aid lagao, chalo, they have to attend. Now there is a compulsion by court, compulsion by law that you must attend a RTA case. Is he your patient? Has he come to you voluntarily? No. Then the definition does not stand. First part is not there. No evidence, no case of medical negligence, but there is a judgment where the court has punished. So I had told, given in writing email, he's from Delhi, that you must put a case against this in the High Court because this is the definition of negligence is not complete. Why? Because it is a forced relation of doctor and patient and not a voluntary relation. Second is gross negligence. So negligence like this, wrong identification of a person, operating on cataract on the right side when left was planned, gross negligence. A patient of glaucoma is operated for a cataract and cataract for a glaucoma, gross negligence. Amputating a wrong rim, using certain anesthesia gases without Boyle's apparatus. These are gross negligence. Not taking a consent, not doing a blood sugar. These are gross negligences. Or from medical side, using first generation beta blockers for an asthmatic patient. Contraindicated, isn't it? You can't use beta blockers first degree, propranolol for a diabetic person or for an asthmatic patient. They will get precipitated. So these are or a primipara undergoing vaginal delivery, full term, and you are not advising cesarean section. Gross negligence. But apart from that, it also puts into omission and commission. When a patient of breast lump is subjected to total mastectomy, radical mastectomy, without doing a frozen section, without doing a biopsy, what will you say today in 2022? It is negligence. So here, act of commission has occurred that radical mastectomy was done without doing a biopsy. So the omission was of the biopsy, commission was of doing the radical mastectomy. They are two sides of the same coin. So either it is gross negligence or utter disregard for life, or it is an act of omission or commission, which are two sides of the same coin. You can view it from both sides. So this is first part, established doctor-patient relationship, then the facts of the case. And third thing is, has negligence झाला है. These are elements of negligence. But is there any damage to the patient? Is there any damage to the patient? All of us sitting in the audience and those who are attending online also, we must admit that we commit mistakes. We commit errors. There could be errors of judgment, and there could be these elements. There are always these elements in private practice. But then everything is not negligence because the patient doesn't suffer. Patient doesn't suffer. What is required by law is not cure. What is required is care. So every case try to individualize, evaluate, establish doctor-patient relationship, gross or subtle negligence and resulting damage. The damage can be, previously it used to be only life or injury. Now it is life, money, reputation, psychological money. Any grievance against a doctor can be labeled as damage, injury. But then are there these two other elements? And most of the cases escape on the second point, omission, commission. So they are very important. Leaving swab in the abdomen, gross negligence. Leaving foreign body anywhere during surgery, gross negligence. So always remember, what are the defenses for a doctor? Difference of opinion, error of judgment is not negligence. Bad outcome despite due diligence. Diligence is exactly opposite word of negligence. And you are going on a particular track. For example, PO. You are treating as a typhoid, then you are treating as a tuberculosis, and go on. All investigations are done, multiple opinions are taken. You are not coming to diagnosis. Ultimately, after 2 years, it turns out to be malignancy. It is not negligence. Bad outcome despite treatment. Charges is not a point of negligence at all. So charges is your individual. Recently, there is another second time Supreme Court judgment that charges cannot come under the ambit of any law. So that is individualistic between you and the patient. Liberal investigations is my advice to you today. I mentioned it on 27 February also, that don't hesitate to do more investigations. Forget about our old teaching that you must come to a diagnosis and give the best possible treatment in the least possible investigations. Forget about that. Those days are gone. Known or accidental complications, mishaps treated adequately, and misadventure. So accidents are also known during surgery. So that can occur. Extra precautions. For example, even in medicine, you go to the ICU, they put a line into the internal jugular vein, and then there can be hematoma. It can compress even the trachea. This happened to my mother, and it may require even a tracheostomy. But that is not negligence. This is an accident known. Whether it is detected in time and treated adequately is important. And particularly with the anticoagulants going on, they can really cause a big havoc. So that is not negligence. Extra precautions taken in good faith is not negligence. Following one school of treatment, for example, take a case of esophageal varices, and there are 2 or 3 standard ways of treatment. One is Sangstaken's tube, age old. You do it with a compression. Second is you give sclerotherapy. And lastly would be radical in case requires splenectomy and renal shunts, etc. You follow one line of treatment at a particular point of time, and something goes wrong, patient succumbs. That is not negligence. Accepted way of treatment. Appendicectomy. Whether you want to go in immediately after diagnosis of acute appendicitis, or you want to do this during interval appendicectomy, both ways are accepted. So that does not mean that negligence has occurred, even if the result may be either way. So following one school of are not negligences. So there are many cases to substantiate that. Now coming to the point of defense. While this is what we have derived for last 30 years, and after helping more than 2,300 cases, and of course taking opinions of senior lawyers, even judges, judiciary, and the competent people, that while answering, give an open offer of direct, I already mentioned, direct dialogue on his and his experts' presence, along with even third-party genuine experts or associations, as per the choice of both. Both means doctor, hospital on one side and the patient on the other side. And we are ready to explain the doubts, misconceptions, wrong information, etc. Mention your right to counterclaim for vexatious complaint under Section 27. That was old Consumer Act. Old means 1986. For damages, defamation, unnecessary patient is harassing me. So that provision was there. I am saying Bhutkalatla was there. This unfortunately has been removed in 2019 new law, that there is no punishment to the patient, even if it is fallacious, purposefully wrong complaint done. For you and me, we have to go to a criminal court, or we have to go to the police, or we have to go to the civil court, where the decision may come when you die and the benefits will be reaped by your grandchildren. or grandchildren. So this provision I just wanted to make a note of, that this is one change which is not in good taste. We are going to fight against this. Dialogue, arbitration, mediation are etc. are okay, but what I find is it is better to straightway fight in the court rather than going through this. All CPA cases in district only. This is a good point for only one good point in the new law is that all cases against doctors will be at the district level. Now what I'm saying is that doctors' bills are never to the extent of 50 lakhs. This is new change again from 27 February. So they have made one more amendment. So till now it was 1 crore. On 27 February, I said 1 crore. Now it is 50 lakhs is the limit of district forums. So I'm trying to update you to the point of 12 o'clock right now. So all CPA cases will be fought, because how many bills of a doctor or hospital are more than 50 lakhs? I don't think any. Practically no. So whenever the bill is less than 50 lakhs, it has to be fought at the district level. But very negative point, and that we are just discussed, that we need to challenge in the High Court, that the case can be, see, the standard law applicable is Civil Procedure Code, which mentions, madam, this will be useful to you, that CPC says under section 9 that cases are to be put in the following order. Number 1, where the facts occurred. So facts occurred at the place of hospital. Number 2, at the, if not possible, at the place of defendant. That means you and me. Doctors are defendants, respondents. And lastly, at the convenience of the complainant. Here they have removed this clause and said that first sentence is it can be put at a complainant's convenience. And supposing particularly super specialists like Abhijit, where patients can come from anywhere. You might be getting patients from Assam, Delhi, Meghalaya, or from Kerala for that particular specialty. The case can be put by patient at his convenience and residence. And then you have to fight. Now, the take-home lesson is you have to register with a company for your insurance, which has Omni India presence, because they will fight on your behalf at the local level. Okay. So this is one change which I wanted to bring to your notice. Check your papers, put them in order, chronological, legible, all reports, start collecting the references to substantiate your management. Management means medical management. Consult your trusted colleagues like IMA or medical legal experts, and medical legal experts. Do not withhold any information from them. Be very truthful. Do not rush to the lawyers directly. Please. This I tell even from law college's podium where 400 students are sitting. Because if 5% of doctors are bad, 5% are in between, borderline, 90% are good. The exactly opposite is true about lawyers. And this I tell in front of all the lawyers and judges. So I am not afraid of this because it's a fact. They also smile. Don't get scary, but be composed, and don't get increase of your blood pressure. Don't lose your focus. Don't lose your attention to the family and practice. Remain composed. Is easier said than done. Be cautious, vigilant, careful in talking, because other party may be just recording the things. And so I told you this is about notice from the lawyer. This is about notice from the court that you have to answer. I mean, legally, it is absolutely necessary that you answer within stipulated time of 30 days. Reply is called, in technical language, written submission, written statement. Get your documents checked through again. I'm saying the same way we have to follow. Take the help of the medical legal experts. Demand from the complainant an expert opinion. This is one thing which we need to understand, that who is to prove the case? Where is the proof of burden? Proof of burden is 10 minutes more. Okay. So demand from the complainant an expert opinion, what he is calling negligent. Just wrong result, this fact, they are usually wild and vague allegations. So we have to check that whether this stands the test of medicine. So they have to have an expert opinion. Check the legal loopholes, like what is the period of limitation? How many years afterwards he is putting a complaint? It's a 2-year period for consumer. 3 years for civil. For police complaint, there is no time limit. If in service, if you are working as a doctor in service with some hospital, then there cannot be a civil case against you. This also we have solved several problems. I mean, several cases that we ask, are you employed? Is it a part of your employment? If there is a contract, if there is a pay slip, we just say that this notice is wrongly directed to me. It should be against the director of that hospital. Okay. Then I also mentioned, inform the insurance company immediately, ask who is to defend, keep the acknowledgement preserved, answer to the point paragraph wise, that is all your self. Good afternoon, sir. Collect the references from the textbooks, then journals, internet, note down the editions, etc. Then volume edition, especially ready at trial, highlight the important points. See to it that whatever you are giving them as expert opinion does not have the points which are contradicting your statement. That is very important. Sometimes we say, ek ke baad ek reference lagate hai, and it itself mentions that that is where you have gone wrong. This has happened in that Sukumar's case, where the child had a tumor in the vertebral, what is that? Spinal, it was a thoracic spinal tumor. The patient landed him in quadriplegia, and they had given references, and this tumor had eroded the rib, and the references they submitted had mentioned that whenever there is a rib erosion, it has to be followed by CT scan, which was not done in a government institute and a research institute. And they said that you have submitted this and you did not do this. And that was the point where the person was, at that time it was the highest compensation, awarded 1 crore rupees. So doctor has to deny all the allegations while answering, submit evidence that he took all the care, and despite that, this unfortunate result has occurred. Burden of proof is on the plaintiff, that is the complainant. During the proceedings, always be present yourself. Don't rely totally on the lawyer. You should be present physically. Be gentle, mannerly, and calm. Never get intimidated. Insist on expert opinion from complainant side, and cross-examine the patient's witnesses if they are there. Next point is obtain the rejoinder evidence, including the expert evidence of complainant through court if not submitted by the complainant. It's your right. And prepare your interrogatories. Apल्याला काय directly consumer मध्ये many times they don't allow direct cross examination. You have to go on submitting the question answers like that. That is called as interrogatory. Now another point is, many times they put a complaint because it is almost free and they don't remain present. One time it is okay. Second time you have to point out to the judge and the registrar over there that this particular complainant is remaining absent. He is not interested. So please take a note of this. And third time it should be dismissed. And ask them to give me compensation because I lost 1 or 2 hours of practice. You have to insist this. If that is there, third time they don't come, 99% the judge will take a note of this. And fourth time he will give a judgment in your favor. So this is important, that whether the complainant is, this is a measure, many cases are like this, that they don't come at all. Appeal in time. This is another thing. If the judgment has gone against us, appeal in time. Time limit is 30 days. From the lower forum, lower commission to the upper commission, the appeal period is 30 days. But now, this is a terrible provision which has come now in 2019, that whatever the compensation is awarded against you by the lower court, lower commission, 50% of that has to be deposited. Then you can appeal. Supposing there is an award of 50 lakhs against you, you have to put 25 lakhs over there. $25 lakhs have to be deposited there. And is the insurance company going to give this deposit? Answer is no. From where to give this money? So here is another writ petition point that IMA needs to put in. So we have prepared this. We are preparing this writ petition by next 5 days, and it will be there. We need all your support with all your might, because these are terrible points, not there in other laws. Do not volunteer your documents, which I already mentioned. Your response during the hearing to any question should be slow. तुम्हाला असं विचारणार हो का नाही उत्तर द्या. Yes or no. You say, I keep quiet. I keep shut. Medical answers cannot be given yes or no. There is always an elaborate explanation. So you would just tell quietly, calmly, sir, I can't answer this yes or no. This is not mathematics. I will remain shut till the time the question is not modified. Okay. And then opposite lawyer will also has to come down. So quoting case law is very important. During the cross-examination, if answer is expected to be yes or no, you can always say no. And don't, you should object to the hypothetical question. Hey, operation केलं नसतं तर काय झालं असतं? Don't ask me hypothetical questions. They have given me a consent. It was required. He would have died also. Or he would have survived. That is not. Hypothetical question should not be allowed. You have to point out to the judge. They won't take an objection of themselves. We have to take an objection. Answering medical counsel, I think I have to hurry up now. I will finish up the matter because just 2 minutes are remaining. Practically same as like Consumer Act cases. Appeal not worth practically because NMC, now MC has gone, NMC is there. And practically NMC will never give the opinion in your favor. It is, see, from State Medical Council, if something has gone against you, you have two options. Approach that state's High Court or approach the NMC. My sincere, honest, learned, and I've considered opinion is you must approach the High Court. Don't go to the NMC. In short, media, very difficult, but then we have to complain to the press council, which we have done. It does act. Facebook, Twitter, they will pull down the abnormal. 1 minute. Then notices from the regulators and labor law, Shop Act, etc., they can be tackled easily. Criminal law, 99% of the police will not arrest you. Please take away that fear. Don't go for anticipatory bail because that will be rejected. I think tackling violence is a big topic. Acronym of prevention is A for attention and additional opinion, B for behavior and bills, C for consent and communication and compassion, D for documents, E for expertise, efficiency and empathy, F and G for good faith and a family doctor. I stands for indemnity insurance, and one thing is missing over here is identity of the person. Adverse media publicity cannot be prevented by and large at this stage. My last request to all of you is unite and fight, preferably through associations with PIL, etc. Join with all your might, force and resources, as these are very costly affairs. About criminal matters, probably the best method is to approach the top authorities like ACP, DCP, etc. and then involve the local chowkis from top to bottom rather than going from bottom to top. That acts better. And about informing police, inform by email also. All the commissioners have their emails published on the website. You have to inform, lodge your complaint through email. That is a better modality because later on they can say no. Thank you very much. And I wish that you have peaceful medical career throughout your life and don't have to face more than one case. If you don't have a single case, you have less practice. Thank you so much. Thank you, sir.
Thank you very much, Naurange sir, for a very elaborate and a nice speech on medical legal topic. We know he has given this talk with a preparation of only 7 minutes. We can hear to him for the whole day.
One thing is, what is reasonable care for me might be reasonable different for the other person, but different to opinion.
Absolutely.
One thing, and second, whatever medical people attend, they say do not over-investigate. And you are saying that the investigation should be liberal.
Yeah. Do not over-investigate. Busy medical teachers. Over-investigate, the courts have taught us now. So we go with the course because punishment is given by courts, not by busy medical college. That is one thing. About reasonable care, that is where the point of discussions come, point of defense comes, and you have to put your side very strongly with the help of evidences from textbook, journals, other affidavits from practicing local experts. So that can be done. So what is reasonable is contemporary. During that period, for example, 2022, you are expected to have something which is prevalent in 2022, not what's going to come in 2040. So that is what I mean by reasonable. Thank you, sir. Who has got the right to reject? No. It has to be a No, are you asking about hospital? Madam, if you are saying cases against hospitals by the medical council, private hospital, that's what I'm saying.
The CMO just gives the first aid treatment of the private hospital and say, now we are not doing the MLCs, go to other institutions like some hospital or any other big hospitals. So is it that correct on the part of the private hospital?
Madam, you have to give first aid.
They just give the first aid, but they don't do the police information and doing the
No,
MLCs.
they should be doing it.
They are not doing. So what the patient has to go against them?
See, police information in a case of a road traffic accident is
So
just on telephone.
Yes, but they don't do it, private hospitals. Like I say in
Then it's a
Bibewadi,
mistake. The hospitals ought to do it. Hospitals ought to do it.
they have to do it, and if they don't do it, then what the patient has to do?
What the patient?
Has to do if the hospital CMO doesn't do it, MLC informing the police.
Then the patients can register the complaint to the police. See, primary
The patient has to go to the police now.
If I
That
can,
means,
if I understood.
apart from his
Yeah,
treatment,
madam,
the patient
time
has
is
to go
short.
to
I
the
will
police.
just take 1 minute
Okay, okay.
because the next speaker, I mean, the next function is there. I will answer your question in short. The primary responsibility of police information regarding roadside accident is on the person driving the vehicle or the pillion rider. It is mentioned clearly, or the pillion rider or the passerby, and they never inform, and therefore the responsibility comes on the doctor. But even if they don't inform, it's not a crime. It's not a crime, but it is preferable that they should be informing. Yeah. And if they don't inform, patient can do it because he's the victim.
But patient is not in a condition to go to the police or inform.
Then
Patient
it can be
injured.
Madam, the patient can be shifted to the tertiary care and they will do it. Somebody has to do it.
Yes, madam. If anyone has any questions, they can discuss with sir during the lunch hours. Now we are moving forward for a very important financial diary release program. Just give us 2 to 3 minutes to arrange the dais.
Good afternoon, everybody. I'm Dr. Gitanjali Sharma, Joint Secretary of IMA Pune. IMA Pune is starting an online certificate course on evidence-based management of diabetes. It's one of its kind, and it is beautifully designed by an expert, Dr. Arti Shade Madam, and many national and international repute faculty would be there. It's a 12-module program on every Saturday starting from 9th of April till 18th of June, between 2 and 5 p.m. in the afternoon. So from the comfort of your own home, you can join for this course. On 19th of June, there will be a physical program or a hybrid program on diabetic foot. So I request all of you who are interested to join for this program. You can join by writing to us on imaofpune@gmail.com or even from the DigiShield app. It's open for all allopathic doctors, juniors, seniors, whoever wants. My second invite is for 3rd of April. We have installation ceremony of the new president and the new team of IMA Pune 22-23. Dr. Meenakshi Deshpande would be installed as president on 3rd of April. The chief guest for this program is Padma Vibhushan, Dr. K.H. Sancheti sir, and it will be held here itself in the Sancheti Auditorium. And our guest of honor is the Municipal Commissioner of PMC, Mr. Vikram Kumar. On this occasion, we have again a CME on cardiology, nephrology, and endocrinology with 2 MMC credit points. So I request all of you to join for these 2 activities of IMA Pune. Thank you very much.
Good afternoon and a very warm welcome to all the delegates, the chief guest, Dr. Deepak Maisekar, sir. I invite Diary Chairman Dr. Danesh Kamerkar, sir. I think he is on the way. Yes, he has arrived. I also invite all the past presidents, trustees, and IMA members for this very important financial year diary release program. Friends, since last 34 years, IMA Pune comes up with a financial diary which is very informative and full of medical information. This year also, our team headed by the diary chairman, Dr. Danesh Kamerkar, sir, diary co-chairman, Dr. Sanjay Patil, diary secretary, Dr. Raju Varyani, they have worked very hard to bring up an excellent financial diary for 2022-23. And today we are here for the release of that diary. Now I request our president, Dr. B.L. Deshmukh, sir, to escort our chief guest, Dr. Deepak Maisekar, sir, on dais. I request Diary Secretary Dr. Raju Varyani to escort Diary Chairman Dr. Danesh Kamerkar on dais. I also request IMA Trust Board Chairman Dr. Avinash Budkar, sir, to come on dais. I also request Diary Co-Chairman Dr. Sanjay Patil and our Secretary Dr. Alkashir Sagar and Dr. Jayant Naurange, sir, to come on dais. Sir, we are conducting this diary release program this year with a limited physical attendance, but about 250 doctors are attending it online. I request our President, Dr. B.L. Deshmukh, sir, to give a floral welcome and felicitation of our chief guest, Dr. Deepak Maisekar, sir. I also request President Dr. B.L. Deshmukh, sir, to felicitate our diary chairman, Dr. Danesh Kamerkar. I request sir to felicitate the co-chairman of this year's diary, Dr. Sanjay Patil. I also request President Sir to felicitate our dynamic, very hardworking Diary Secretary, Dr. Raju Variani. Yes. Yes, he's the key person of this year's diary. I welcome all the dignitaries of the dais also, and request all the dignitaries on the dais to join us for lamp lighting. Thank you, everybody. Now I request IMA Pune President Dr. B.L. Deshmukh sir for his address.
Good morning. Today's Chief Guest, Dr. Deepak Mehsekar sir, Diary Chairman, Dr. Dhanesh Kamirkar sir, Dr. Butkar sir, Dr. Sanjay Patil sir, आमचे सर्वा Dr. Naurange sir, dignitaries on the dais, all the past president, MC members and friends. I welcome you all for this prestigious IMA Financial Diary function release. IMA Financial Diary is a gem of its project. Year after year, we IMA life members eagerly waiting to see and collect the financial diary. It was a pleasure to work and hand over this 34th IMA Financial Diary 2022-23. This is a very important fundraising project which involves much interaction and social networking. The live members of the IMA and advertisers for the diary are backbone of the association who help us to strengthen our bonds. I congratulated all previous diary chairman, co-chairman, and diary secretaries contribute their hard work, untiring efforts to contribute funds for the IMA. I congratulate Diary Secretary Dr. Raju Varyani for putting mammoth effort to make this project a grand success. I was observing since first day of diary meeting, he used to come to IMA after finishing his OPD at 3 p.m. and phone calls to advertisers. After his phone call, he used to sit with our dynamic past president, IMA trustee and co-chairman of Sanjay Patil for finishing touch. Hats off to all these two diary chairmen and secretary. It's my diary duty to congratulate Dr. Danesh Kamerkar, sir, in spite of his busy schedule and some financial problems. He attended few meetings. Thank you, sir. And above all, it proves feasible, fruitful, even in the difficult times of like a COVID. The timely and wholehearted support by diary chairman, Dr. Kamerkar, sir, was instrumental. I thank immediate past president, Dr. Arti Nemkar, Dr. Padma Iyer, and all IMA diary committee members for their great cooperation. We all highly obliged to our advertisers for their contributed support year after year. They have given us a rock support. It would not have possible to come out with this project without their support. We congratulate our printer, Mr. Prathamesh Divakar and his team, that is Messrs. Positive Enterprises, for making this elegant diary and timely delivery. My personal greetings to whole active team of making this project successful. I wish you all happy and wealthy financial year 22-23 ahead. ही डायरी फक्त आर्थिक नोंदी ठेवण्यापुरती किंवा पेशंट रेफरन्ससाठी नसावी. एखादा सुविचार सुद्धा आपण या डायरीत लिहू शकता. दिसामाजी काहीतरी ते लिहावे, प्रसंगी अखंडित वाचित जावे. आपल्या आर्थिक प्रगतीबद्दल वैचारिक प्रगती सुद्धा महत्वाची आहे. धन्यवाद.
Thank you, sir. Now I request our diary secretary, Dr. Raju Varyani, to tell us about the efforts that the diary committee has taken to bring up such a fantastic diary, and he will be speaking about the diary also. Raju Varyani, sir.
Thank you, Dr. Sunil Ingade. A very good afternoon to all of you. Once you become a vice president of IMA Pune, the duty, the responsibility of diary secretary is automatically on your shoulders. So this is the peculiarity of IMA Pune. There are many firsts of IMA Pune. Like it was the first IMA branch of India. Similarly, this unique about financial diary, it is the great innovative idea of leaders and stalwarts of IMA Pune branch who initiated this concept of IMA Pune diary. This is the 34th year of diary. Many other branches have started to follow this. It is not only a fundraising, but also it is like a socializing we form a social network. It gives us opportunity to communicate with our members. So there is a social network like with the help of diary. For the diary, which is a financial one from 1st April to 31st March. When we start the financial diary project, we have with us the diary committee chairman, co-chairman. This year we approached Dr. Kamerkar sir. He readily agreed to be the chairman of this diary project. We were relieved because we were sure now there will be no obstruction or occlusion when Dr. Kamerkar sir is our chairman. Also, the theme of the diary is managing vascular diseases strategies in this era. This theme was suggested by Dr. Kamerkar sir. Also, sir has written excellent articles based on this theme in the diary. These articles will be very useful to all the members. In spite of busy schedule, sir has supported us a lot. Innovative ideas by Dr. Kamerkar sir were very useful. Then the diary co-chairman is also a must. I was very lucky to have Dr. Sanjay Patil as the diary co-chairman. He was always encouraging. It was a nice experience learning from him. He was like a Google map for me. He was directing me the ways. Finally, I got the message from him, you have reached your destination. Also, we had nice articles which are written every year by Dr. Avinash Bhutkar sir, Dr. Navrange sir, on all about IMA, why to become a IMA member. Very nice articles by Bhutkar sir and Dr. Navrange sir. Then we have a social security scheme article by Dr. Shyam Damle. We have hospital board issues by Dr. Sanjay Patil. Then we have medical legal cases by Dr. Meenakshi Deshpande. So there are very nice articles you can go through. Apart from that, on every Sunday page, there is a one-liner that was contributed by Dr. Hilary Rodriguez. Then we have medical days are there, birthday wishes are there. There are about 106 advertisements. But it is the IMA. Because of IMA, most of the work is done automatically. The secretary doesn't have to do much because it is an IMA diary. About half the advertisements are automatically there every year. So the name IMA itself is enough to get the half of the advertisements. Rest of the half, we have to convince and remind them. So this year also we had most of the same. Only there are some changes. Some hospitals change their timings. They change their services. We have to modify. Like some doctors have reduced their timings. So we had to modify. Only that takes a bit of time. But we have tried to give the best, to make the minimum mistakes. There should be no mistakes because the number of advertisements are there. Like there was one advertisement, the address was written as behind Palod Sari Center. That Sari spelling was SADI. He told, I don't want SADI, I want SARE. So that I conveyed to Prathamesh, then Prathamesh, this changing the Sari took 15 days. So it was very nice working in the diary committee. It was very nice interacting with the members. That is the main positive advantage I liked about working in this committee is communication with the members. Now I will request our Executive Trust Board, Dr. Avinash Bhutkar sir, to say a few words. Sorry. Chairman Trust Board, Dr. Avinash Budkar, sir.
Good noon to all of you. Today, I'm really happy to come and attend this particular diary release function. And just now we heard Dr. Raju Varyani telling us about his efforts to raise funds and all. What I find here is, see, while working for IMA, many members avoid coming here. And some of them feel encouraged that they should join managing committee or whatever work needs to be done by IMA, they will share the work. Most important thing is they should feel encouraged and happy that they get an opportunity to work. And that is what has happened this year. Just now he described how happy he was. Like getting advertisements is not very difficult thing because almost all the advertisements come from our own members. They have got their hospital setups, then other business schedules and all. So they give advertisements. The thing is you have to represent IMA and appeal to them. And usually they respond. And this year, I think that he has created a new record of collecting huge sum for this particular diary. And this diary was basically started, as he said, about 34 years back by some stalwarts like Dr. S.N. Deshpande, who then became the president of IMA also. It was his brainchild, you know, and basic idea was like collecting advertisements that will raise funds because IMA needs funds. If you go through our income expenditure, you will realize that we need to spend so much money in managing all the affairs of IMA that we have to find resources. I mean, this building is one of the example that we created this building to have these resources, like we can rent it out and get the funds. So somehow we have to do it. And this year, as every year, we get good people to represent as chairperson. This year, we had Dr. Kamerkar, who has helped us tremendously by using his own influence on the advertisers. And Dr. Sanjay Patil, I don't have to speak about him anything. He has been working with me for so many years now, and I know him very thoroughly. So wherever, I mean, he takes a position, he will see to it that he does justice to that, and that he has shown again. So I'm really happy. President Dr. Deshmukh sir, he is also a devoted and committed worker for IMA. So he has also done work for this diary, and the secretaries, and additionally Dr. Naurange sir and all. So I'm really happy that this particular diary has come up nicely. You will see the diary itself, and you will be really happy to see the diary, all the birthday wishes and whatever. So thank you for inviting me for this particular program, and my best wishes for the diary function.
Thank you very much, sir. Now I request Dr. Jain Naurange sir to say a few words.
गुड आफ्टरनून एव्हरीवन. मातृभाषेत बोलतो. माननीय प्रमुख पाहुणे डॉक्टर म्हैसेकर, माननीय अध्यक्ष डॉक्टर देशमुख सर, चेअरमन डायरी कमिटी डॉक्टर कामेरकर, डॉक्टर संजय पाटील, इंगळे सर, आणि डायरीचा को चेअर नाही सेक्रेटरी सॉरी डॉक्टर राजू वर्यानी, सेक्रेटरी, आणि डॉक्टर भूतकर सर, आणि सगळे आपण बसलेले उपस्थित लोक, डॉक्टर शाडे इथे आहेत, संचेती आहे, डॉक्टर बेरे आहेत, आणि हळबे सर आहेत, सारडा सर आहेत, डॉक्टर मीनाक्षी इज ऑल्सो देअर, आणि आपण सगळे. तर काही लोकांचा उल्लेख झाला नसला तरी हरकत नाही, तुम्ही सगळे याचे पार्ट अँड पार्सल आहात. कधी ना कधी तुम्ही सगळं काम केलेलं आहे. आणि आपल्याकडे जसं राजूने म्हटलं की व्हाईस प्रेसिडेंट झाला की त्याला ऑटोमॅटिकली प्रेसिडेंट इलेक्ट व्हायच्या आधी डायरीची जबाबदारी घ्यावीच लागते. आणि ही खासियत मला असं वाटतं की आपल्याकडे सेट झालेली आहे की 9 वर्ष इथे 9 महिन्याचा गर्भावास असतो, इथे 9 वर्षाचा आहे. म्हणजे असं की त्या आमच्याकडे आलेल्या ज्युनियर मोस्ट सेक्रेटरीने 9 वर्ष निर्णय स्टेजमधनं काम केल्याशिवाय तो प्रेसिडेंटला एलिजिबलच नाही. अशी परिस्थिती कुठल्याही दुसऱ्या आयएमएत नाही, कारण ही मोठी ब्रँच आहे. त्याच्यामुळे आपल्याला एवढे लोक मिळू शकतात, आपण थांबू शकतो. हा एक भाग झाला. दुसरं म्हणजे डायरीची उत्तरोत्तर प्रगती होत गेली आणि खूप चांगल्या पद्धतीच्या डायरीच्या ऍडव्हर्टाइजमेंट्स आणि त्याच्याबरोबर लेखमाला एकेका विषयाला वाहिलेल्या, हे आपण जे सुरू केलं 15 वर्ष तरी झाली असतील, की डायबिटीस बद्दल झालं, डायबेसिटी ओबेसिटी बद्दल झालं, ब्लड प्रेशर बद्दल झालं, कार्डियक डिसीजेस बद्दल झालं, एन्व्हायरमेंटल कंडिशन्स बद्दल झालं, प्रत्येक पल्मनरी कंडिशन्स बद्दल झालं, मेडिको लिगल बद्दल झालं. तसं यावेळेचं व्हॅस्क्युलर डिसीजेस बद्दलच्या एक लेखमाला म्हणजे 12 लेख त्याच्यामध्ये असतील. खूप लोक आवर्जून ती आर्टिकल्स वाचून आपल्याकडे संग्रही ठेवतात. म्हणजे फुल डायरी तर ठेवतातच, पण कित्येक वेळ ती 12 पानं काढून सुद्धा बाजूला ठेवतात. ही त्याची खरी युटिलिटी मेडिकली आहे आणि मला खूप आनंद होतो. नाव दिस इज द टाइम वी हॅव टेकन द बॅक सीट. पुढची आमची जनरेशन इतकी उत्तम तयार झालेली आहे की बाप से बेटा सवाई. आणि त्याचा खरा आनंद आम्हाला होतो की मी असेन, भूतकर असेन, आमच्या आधी डॉक्टर बेरे होते, डॉक्टर साडा आमच्या बरोबरचेच आहेत, मोहन जोशी आहे, रॉड्रिक्स आहे, त्याच्या बरोबरीने त्यांना पुढे जाणून ओलांडून पुढचं आणखी नवीन सगळी आव्हानं पेलत. कालच माझं डॉक्टर बेरेंचे बोलणं चालू होतं, इतकं चांगलं काम करतायत. डॉक्टर पाटील आहेत, डॉक्टर इंगळे आहेत, राजू तर आहे. तर ह्याचा खूप जास्त आनंद होतो की आता पुढच्या लोकांनी संपूर्ण जबाबदारी सर्वार्थाने पेलायला समर्थपणे घेतलेली आहे आणि आता आपल्याला याच्यामध्ये लक्ष घालण्याची जरूर नाही. आणि बॅकसीट घेतलेली आणि हळूहळू बॅक बेंचर झालेलं खूप आवडेल आणि त्याचा आनंद सर्वात जास्त आहे. डायरीला पुन्हा एकदा शुभेच्छा. तुझे काम केलेले सिंगल हँडेडली सगळ्यांनी सपोर्ट केला आहे, बरोबर आहे, पण अल्टिमेटली जबाबदारी त्याच्यावरती असते की जो रोजच्या रोज तिथे खपत असतो. आणि मला याचा खूप आनंद झाला बघून. हे तुम्ही जर म्हटलं की डेस्टिनेशन हॅज कम, माझ्या मते द जर्नी टू द डेस्टिनेशन वॉज वर्थ ऑब्झर्विंग. एवढं बोलून मी माझे 4 शब्द थांबवतो. थँक्यू.
Thank you very much, sir. Now we will listen to the words of Diary Co-Chairman Dr. Sanjay Patil, who is the Executive Trustee of IMA Pune, Honorary Joint Secretary IMA CGP HQ, Director IMA Hospital Board of India HQ, past President of IMA Pune, and past Vice President of IMA Maharashtra. Dr. Sanjay Patil, sir.
नमस्ते. आजचे माननीय चीफ गेस्ट डॉक्टर दीपक म्हैसेकर सर, CMचे ते ॲडवायझर आहेत आणि कन्व्हेनर ऑफ कोविड टास्क फोर्स महाराष्ट्र स्टेट. IMA पुणेचे अध्यक्ष डॉक्टर देशमुख सर, IMAचे चेअरमन ट्रस्ट बोर्ड डॉक्टर बुतकर सर, एक्झिक्युटिव्ह ट्रस्टी डॉक्टर जयंत नवरंगे सर. There are two executive trustees. Myself is executive trustee, but you are executive trustee. Our diary chairman, Dr. Dhanesh Kamerkar, diary secretary, Dr. Raju Variani, and both the secretaries, Dr. Sunil Inge and Dr. Alka Kshirsagar, incoming president, Dr. Meenakshi Deshpande, and galaxy of our past presidents. There are nearly 9 to 10 past presidents sitting in audience and my friends. सगळ्यात महत्वाचं म्हणजे नवरंगे सर म्हणले त्याप्रमाणे पुढची टीम नक्कीच काम करायला पुढे तयार झालेली आहे आणि हे एक प्रकारचं रिफ्लेक्शन आहे. म्हणजे मित्रांनो, आपल्याला कुठलीही वस्तू, म्हणजे मी ऑप्थॅल्मॉलॉजिस्ट आहे, तर आपल्याला जेव्हा आपण काम करत असतो किंवा एखादी वस्तू आपण जेव्हा बघत असतो, त्याच्यावरती जेव्हा त्या वस्तूवरती सूर्यप्रकाश किंवा एक एनर्जी पडल्याशिवाय ती वस्तू आपल्याला दिसत नाही. आपलं काम चालू आहे, आपल्याकडे एनर्जी आहे, आपण सगळे पाहतोय एनर्जी IMA मध्ये आहे. आजचा प्रोग्राम हे एक रिफ्लेक्शन आहे. आज आपल्याला हे पाल्पेट होत आहे की या पद्धतीने आपण काम करतो आणि आजचा एक सोहळा आपण घडवून आणतो. म्हणून हे एक IMAच्या कामाचं एक प्रकारचं आपल्या पुढे एक रिफ्लेक्शन आहे. सर, ह्या गोष्टीमध्ये जे चेअरमन आहेत आपले डॉक्टर धनेश कामेरकर, जेव्हा आम्ही त्यांना भेटायला गेलो तेव्हा त्यांनी ही जी गोष्ट आहे ही लगेच ऍक्सेप्ट केली, आपली एक रिक्वेस्ट, आणि त्यांनी पूर्णपणे ह्या प्रोजेक्टमध्ये झोकून दिलं. त्यांनी खूप चांगले इनपुट्स दिले. मीटिंगला नेहमी ते त्यांचे इनपुट्स व्यवस्थित कसे पूर्ण होतील अशा पद्धतीने त्यांनी बघितलं, गायडन्स दिला आणि सरांबद्दल तर आपल्याला सगळ्यांना माहिती, ही इज अ वेल नोन व्हॅस्क्युलर सर्जन फ्रॉम पुणे सिटी. आणि त्यांचे मित्र त्यांना तलैवा म्हणतात, म्हणजे तमिळमध्ये तलैवा म्हणजे ही इज अ हेड, ही इज अ लीडर, ही इज अ बॉस. तर डायरी कमिटीमध्ये ही वॉज अवर लीडर. ॲट द सेम टाइम प्रेसिडेंट सरांनी सुद्धा इतकं चांगलं आपल्याला कोऑपरेशन केलं आणि सरांनी खूप मनपूर्वक लक्ष घातलं या प्रोजेक्टमध्ये. म्हणजे मला आठवतं मी प्रेसिडेंट असताना डायरी प्रोजेक्टमध्ये लक्ष मी पण जेवढं घातलं नसेल तेवढं त्याच्यापेक्षा जास्त लक्ष देशमुख सरांनी ह्या प्रोजेक्टमध्ये घातलेलं आहे. त्याचबरोबर आपल्याला डायरी कमिटी पण एकदम ऍक्टिव्ह होती या सगळ्या याच्यामध्ये. ऍडव्हर्टायझर्सचं तर बोलायलाच नको, आपल्याला ऍडव्हर्टायझर दरवर्षी मिळतात आणि ऍडव्हर्टायझर्सचं पण कॉन्ट्रीब्युशन इमेन्स आहे. त्याचबरोबर आपल्या मेंबर्सचं पण कॉन्ट्रीब्युशन खूप चांगलं आहे. आणि त्याचबरोबर स्टाफ, प्रथमेश हे सगळे आहेत. हे सगळे घटक जेव्हा एकत्र आले त्यानंतर सगळ्यात महत्वाच्या 2 गोष्टी राहिल्या, त्या म्हणजे एक म्हणजे IMA ची लिगसी, इतक्या वर्षाची जी परंपरा आहे 34 वर्षाची, त्याचमुळं ही डायरी आज सक्सेसफुल होतीये. गेले 34 वर्ष ज्या लोकांनी मेहनत केली त्याचंच हे प्रतीक या ठिकाणी आपल्या समोर आहे. आणि शेवटची गोष्ट की डायरी रिलीज होत असताना आपल्याबरोबर काही मास्टर्स आहेत जे आजचे चीफ गेस्ट आहेत, डॉक्टर दीपक म्हैसेकर. तर प्रेझेन्स ऑफ मास्टर असणं सुद्धा खूप महत्वाचं आहे. म्हणून आजच्या डायरीच्या या फंक्शनला अतिशय महत्व प्राप्त झालेलं आहे. आपलं IMAचं जे काम चालू आहे सर, म्हैसेकर सर, मी थोडक्यात सांगतो. IMA मोठी ब्रांच आहे आणि हे सगळं झालेलं आहे. पण IMAचे 3 उद्दिष्ट आहेत, मेन उद्दिष्ट आहेत 3. पहिलं उद्दिष्ट आहे की आपल्या मेंबर्सचं एज्युकेशन करणे, अपलिफ्टमेंट ऑफ नॉलेज. दुसरं उद्दिष्ट आहे पब्लिक एज्युकेशन. आणि तिसरं उद्दिष्ट आहे की आपल्या मेंबर्सचं हित पाहणे. तर ह्या गोष्टी तर आम्ही करतच असतो आणि आम्हाला याच्यामधनं खूप मेंबर्स मिळतात, खूप काम होतं आमच्या मार्फत. शेवटचं जो आहे की मेंबर्सचं हित जपणं, याच्यामध्ये खूप चॅलेंजेस उभे राहिलेले आहेत. सर, आपण बघताय की आम्ही सगळे खुश आहे, आज आम्ही एवढी डायरी आहे, एकमेकाबद्दल सगळे व्यवस्थित सगळं जो तो आपापला रोल केलेला आहे. पण आम्ही सुखी नाही आहे, आम्ही दुःखी आहे आतनं. तर आम्ही 3 गोष्टींसाठी मेनली दुःखी आहे. पहिली गोष्ट म्हणजे होणारा व्हायलन्स. हॉस्पिटल्समध्ये, क्लिनिक्समध्ये होणारा व्हायलन्स. आम्हाला सेफ आणि सिक्युअर ॲटमॉस्फिअर मिळत नाहीये. हे एक दुःख आहे आमच्या पुढं. दुसरं दुःख असं आहे की ओव्हर रेग्युलेशन बाय द ऑथॉरिटीज. म्हणजे आपण एवढे मोठ्या पदावरती आहात, आपण CM साहेबांचे ॲडवायझर आहात. आम्ही रोजच बघतोय की गेले 10 वर्षातले बदल आहेत की एका डॉक्टरला मेडिकल कॉलेजमधनं पास आउट झालेला आहे, तो क्वालिफाईड आहे आणि त्याला गव्हर्नमेंटच्या ऑथॉरिटीजकडून ओव्हर रेग्युलेशनचा त्रास होतोय. ते आम्हाला रोजच फाईट करावं लागतं. आणि तिसरा जो आहे तो लेटेस्ट चॅलेंज आहे आमच्या पुढं की कोविड व्हॅक्सिन्स जे आहेत ते बरेचसे स्टॉकमध्ये आहेत आमच्या मेंबर्सच्या आणि ते आता एक्सपायर होऊन ते वेस्टेज होत आहे. या बाबतीमध्ये आपण तर CM साहेबांचे ॲडवायझर आहे. मी तर म्हणेल की आपण त्या ठिकाणी आमच्या वतीने काही म्हणणं मांडावं. कारण सेंट्रल मिनिस्ट्रीने एक आपल्याला हे दिलेली आहे की तुम्ही एक्सचेंज करा, व्हॅक्सिन एक्सचेंज करा. एका हॉस्पिटलचं तर 8 कोटी रुपयाचं नुकसान होत आहे. त्याच्यामुळं माझी आपल्याला एक रिक्वेस्ट राहील या माध्यमातून की आपण ह्या ज्या कोविड व्हॅक्सिनचा प्रश्न आहे आपण सोडवला तर आम्ही अतिशय आपले आभारी राहू. आणि एवढंच IMA बद्दल मी बोलतो आणि पुन्हा एकदा मला एक संधी दिली, तुम्ही को-चेअरमन काम करण्याची संधी दिली, त्याबद्दल मी IMA पुणेचे धन्यवाद म्हणतो आणि या ठिकाणी थांबतो. थँक्यू.
Thank you, sir. Now we will listen to Diary Chairman Dr. Dhanesh Kamirkar, sir. Dr. Dhanesh Kamirkar is Head Department of Vascular and Endovascular Surgery, Rubiol Clinic. Over to you, sir. Sir had come many times for the meeting directly from the OT. Many times he had come directly from OT to IMA.
Thank you, Dr. Variani. Dr. Maisekar, dignitaries of IMA on the dais, of the dais, and friends. It was a wonderful opportunity and privilege for me to be a chairman of Diary this year. In fact, when Dr. Variani, Dr. Patil, Dr. Padma approached me in Rubiol, almost in August, I guess, I wasn't sure. I said, what am I supposed to do? Because with the busy vascular schedule and practice, and we have departmental activities for managing juniors as well. I was not sure, but then I said, let's take this challenge. I thought it was a good opportunity to increase the awareness also about vascular diseases through the medium of diary. And I told them yes. But as I realized, it was becoming a very tough task for me to take the time out from the busy schedule and attend the meetings. But I did attend most of the meetings, barring last month when I had a personal tragedy. But after a couple of meetings, I realized that everything is on autopilot. Dr. Varyani, the boss, Dr. Patil, literally took the entire kind of diary program in their hands, and hats off to both of them because they did a wonderful job meeting advertisers, calling advertisers. And then as a chairman, I didn't do much, just giving some inputs, some ideas, some suggestions, like having birthday wishes, or I requested Hillary to put some nice, interesting anecdotes every page, and meeting the industrial health doctors for them to attend these so that to the diary. So little few bits and pieces here and there. But other than that, the majority of work was done wonderfully by Dr. Varyani, Dr. Patil, and the entire team. And I really hats off to them. End of the day, without advertising people or without advertisers, this diary wouldn't come through. So thank you so much to them. And honestly speaking, it was a good interaction for me with the IMA people. We as a kind of super specialist or consultant literally sit at the periphery, and the main kind of medical work in the city, any city for that matter, is done by IMA. And there are stalwarts here sitting in the auditorium who basically work year in and year out towards the upliftment and development of Indian Medical Association in entire city and state. And through that, everybody basically knows everybody, and a lot of activities, educational, charity activities are being conducted. So we at the periphery, we don't realize how much work is put by IMA, and this year I saw it with a very close hand and close eyes. So hats off to you guys, and thank you.
Thank you very much, sir. Now I request our chief guest, Dr. Deepak Maisekar, sir, to release the diary. I request Dr. Geetanjali Sharma, madam, to please felicitate the advertisers who are in the auditorium. Dr. Praveen Swami from Royal Mudhol Hospital. So the new hospital is coming in Pune, Royal Mudal Hospital. Dr. Praveen Swami has come. Then Mr. Deepankar from Yashka Informatics. Dr. Ravindra Chhajed from Harsh Hospital. Dr. Padma Madam. Dr. Padma Madam has missed our gathering and for this program. Dr. Anil Dudbate. And few I may not be knowing. Or nahi, add nahi. Any more advertisers in the auditorium? I may not recognize a few. So, so we are very thankful to Mr. Prathamesh from Positive Enterprises for the printing of diary. I request Mr. Prathamesh to please come on the dais, and I request diary chairman Dr. Dhanesh Kamirkar to felicitate Mr. Prathamesh. So, among advertisers, Dr. Geetanjali Madam, Dr. Sunil Ingade.
Dr. Sachin Yadav.
Alit. Dr. Sachin Yadav, Chintamani Hospital. So because of this umbrella, Kedar Patil. Dr. Kedar Patil. No. We are very thankful to all the advertisers. We are very proud to have with us on this diary release function, Dr. Deepak Mahsekar as our chief guest. Dr. Deepak Mahsekar has done Bachelor of Veterinary Science and Animal Husbandry from Bombay Veterinary College in first class. Then he has done post-graduation in the same college with a gold medal. With the changing times, he has done diploma in computer science. Later on, he has done LLB first class from Nagpur University. He is well versed not only with Marathi, Hindi and English, but he also knows German and Russian. In government service, Sir has worked in different capacities. He was Municipal Commissioner of Nanded from 2006 to 2010. In 2010, he got the Indian Administrative Service. He got selected in Indian Administrative Service. Then he was Deputy Secretary Urban Development from 2010 to 2011. He was Chief Executive Officer Jilla Parishad Kolhapur from 2011 to 2013. He was Collector, District Collector Chandrapur from 2013 to 2016. He was Chairman Nagpur Improvement Trust and Metropolitan Commissioner Nagpur Metropolitan Region Development Authority from 2016 to 2018. He was Divisional Commissioner Pune from 2018 to 2020. He has been working as member and chairman for different government committees. Presently, he is working as advisor to the Chief Minister of Maharashtra. He is Chief Convener for Documentation of Covid-19 and Chairman State Expert Appraisal Committee. His dedication and hard work has earned him a number of awards. To name a few, as Municipal Commissioner Nanded, he got first prize at state level for solid waste management. He bagged 2 prizes for having stood at national level for solid state management and drinking water supply. He bagged first prize at national level for efforts to make city slum-free. He bagged first prize at state and national level in Yashwant Panchayat Raj Abhiyan for outstanding work while working as Chief Executive Officer, Jilla Parishad, Kolhapur. Over to you, sir.
नाही कोणत्याही भाषेतनं बोलायला काही प्रॉब्लेम नाही. मराठी, हिंदी, इंग्लिश. थोडा हिंदीचा फक्त प्रॉब्लेम असा आहे की ते बायकोसारखी आवडते पण तिच्यावर कंट्रोल नाही. बाकी मराठी इंग्लिशचा काही प्रॉब्लेम नाही. आजच्या या I'll be not restricting only to a particular language. It could be English or Marathi. On this occasion of Pune Financial Diary, which has been brought out by IMA, at the first onset, I thought this is because probably you have to maintain proper accounts for income tax, therefore you are bringing a financial diary. Then later on, he clarified that your tenure as IMA office bearers is from 1st April to 31st March. And therefore you are bringing this diary in financial year, that particular financial year. Dr. Deshmukh, Chairman of the IMA, Dr. Sanjay Patil, Dr. Kamerkar, who has brought out this diary, a wonderful diary. I was just going through it. Dr. Raju Varyani, Dr. Ingre, Dr. Alka Shirsagar, Dr. Bhutkar, Dr. Navrange, and all the doctors in the audience. I recollect, I was not recollecting date, but I was knowing that I had come to this venue 2 years back when COVID had started. Dr. Patil reminded me that it was 12th of March. When 9th of March, the first case came. And after that, we had an interaction with different doctors in this city. And I had an interaction with IMA people here. 2 years have passed over and still we are talking of controlling it. Or we are still talking of having likely a 3rd wave or 4th wave. In some countries, it is already 5th. For last fortnight, South Korea, Germany, Vietnam, these are the countries showing enormous number of cases. We would not be surprised. South Korea had more than 6 lakhs in a day, and the total population of the country is 5 crore. So almost more than 1.25% in a day. Fortunately for us, it's a B2 variant. We had in the third wave B1 initially. Later on, it was replaced by B2. And why I'm not using mask is I just had COVID a month back. So I think that I must have got some immunity out of it. After my booster, for last 2 years, I kept it away from me, but it got me somewhere in last week of January. And thereafterwards, it's creating havoc throughout the world. Probably after Spanish flu, after 100 years, we are having an epidemic of its own kind. More than almost 40 crore people affected, more than almost 70 lakhs already death all over the world. But fortunately for India, yesterday it was somewhere around 1700, and Maharashtra it was less than 100. But we never know if there could be any mutation, further mutation. B1, again, there is a variant B1.1 to 2.2. Omicron probably we may not have problem with. But unfortunately, Pi, the next name in Greek alphabet, if at all a variant comes, it should be named Pi. Unfortunately, if it comes, then probably we could have problems. How severe it could be, how dangerous it could be, how infectious it could be, we don't know. How the mutation goes. And mutation is a random process. Basically, I'm a genetics student, so I know I've worked in cytogenetics. Mutations don't happen selectively. It's a random process. And in my opinion, I may be wrong, you are the experts in the field. The last Omicron was inching towards self-limiting infection, what we call it as self-limiting infection. A virulent virus will kill its host and therefore may not propagate more. But that doesn't happen with a mild variant or a mild virus like Omicron, which propagated across the world. But fortunately, compared to Delta, we had very less mortality in it. But one thing is for sure, as long as we don't have maximum vaccination, because in the third wave we saw people who had vaccination, they did not have severe disease. They got infected. I would say they weren't infected. In fact, in my own case, after taking booster, after 15 days, I got infected. But it was like any common flu, had 102 to 103 degree temperature, continued for 2-3 days, and then it subsided on its own. Probably if the vaccine wouldn't have been there, I don't know what would have happened. So vaccination is going to be the key. And unfortunately, in third world countries, especially Africa, the vaccination percentage is very, very low. And that's the worrisome fact for the world. Because with the modes of communication, the way we travel, Spanish flu was controlled in 2 years, mainly because there were no modes of transport like as we have today. May it be planes, may it be ships, or for that matter, even train initial stages they had started. And therefore, Spanish flu could be controlled in a short no, I wouldn't say short span, but by second year end, it was mostly under control. We already have completed 2 years. If we count from China, it's more than 2.5. November, the first case was detected in China. In fact, first infected case detected in December latter. But if we go by that, it's more than already 2.5 years. And we don't know when it is likely to end. WHO says it could last long for a quite long time. In fact, yesterday's WHO statement is worrisome. We are in the mid of it. If it's in the mid of it, then another 2 years. But my own gut feeling is by this year end, it should be under control. And that's what we are looking for. And that's what we are hoping for. Because there had been a lot of problems with economy, lot of problems that we had to face. Because I recollect those days 2 years back, he was the chairman then IMA. The problem that doctors had faced, in fact, they were the first who had to burn the major brunt they had to face because they were treating the. I know it very well because I lost my own brother-in-law who was a psychiatrist in UK to COVID. And therefore, I know the problems of the doctors. Fortunately, in my family, or as it was to be, except me, everybody is doctor. They are all doctors, including my brother, my both sisters, and in different branch of specialization, someone in gynecology, someone in ophthalmology. My brother is in pulmonology. So they are in different specialties. I had chosen a separate path and I went to a veterinary science and then thereafter into administration. But I know the problems of doctor which you have mentioned, especially the attacks on doctors, the over-regulation that you were talking of, maybe because of PCP and DT or some other problems. As I was discussing with you, I'm trying to come out with a new software which will be not helping the doctors alone, but the government as well. Not only monitoring patients, but your day-to-day affairs. That is the way we are trying to develop it. And that software, say for example, differential diagnosis, we already have so many softwares in the market. X symptoms, then X minus Y symptoms, what is the probable disease that it could be? There are softwares available. In fact, in Harari's book, he mentions about it, Infotech and Biotech. Infotech and Biotech, if they come together, what can happen? We don't know origin of COVID or coronavirus SARS-2, whether it's a man-made virus or whether it's a natural virus. We don't know. But if at all it was a man-made virus, or if it was a natural virus, we can't say that there would be any future virus which would not be a man-made virus. Because when Infotech and Biotech come together, we are thinking of artificial intelligence. If they two come together, we don't know what is going to happen. Bill Gates talks of most of the profession getting redundant because of AI, artificial intelligence. Because you may not require human brain. The computer itself will tell, "Arey, isko to ye ho gaya hai, usko ye dawa bhi de do." And then we know already people have started, they Google it and they come to the doctor. And then they ask doctor, "Sir, I think this should have been prescribed." That's happening right now. And that could happen more in future. So I think CME is the best way to continue ahead the continuing medical education. Earlier, MCI had prescribed it. Now, National Medical Commission is there in place of MCI. They are doing it, or they are controlling medical education. But I think we will have to be prepared for our future challenges, especially in health sector. What are going to be the future challenges? Different disasters. He had just mentioned about me being the chairman of expert appraisal committee, that is for environment. The ecological destructions that we are having, we are finding probably in last 4 years, I am finding this summer the most hot in Pune. I don't know, you must have stayed here for more years. Is it because of the ecological destruction? Is it because of changing environmental patterns? And if it is because of that, are there going to be changing disease patterns in years to come because of these environmental challenges? We are finding Russia-Ukraine war, wherein we are talking of WMD, weapons of mass destruction, biological warfare, even nuclear warfare. Unfortunately, if our country is to face such kind of situation, what are we going to do? And are we prepared for that? This pandemic was just a sample of things to come, how things could happen. I remember exactly 2 years back, maybe today is 20th, 23rd, after we had a lockdown. Had the lockdown been not there, probably would have been worse prepared. But based on our input from the Western world, may it be Italy or some other foreign country, China, we imposed lockdown and got ourselves prepared for the things to come. We never had PPE in large quantity. We never had N95 in large quantity. Ventilators were short. All was possible because of this 3-4 months lockdown, which gave us time to prepare. But we don't know the next disaster, how would it hit, and whether we would have time to prepare. So we need to be prepared from the beginning itself. We need to forecast what is going to be the future course of the medical profession, and accordingly, we need to be prepared for this. I think I have spoken a detail about all these issues, but one and foremost thing, which I time and again would like to mention, is the family doctor consent. When I was young, I recollect family doctor being there. And family doctor was not only a family advisor for health issues, but all the issues. He had a personal rapport with the family. Whatever issue comes up in the family, it could be matrimonial, it could be financial, it could be anything. But the doctor was there to advise. And there was a personal rapport between the doctor and the patient. And with destruction of that institute, I think we are the most losers. When my sister was working with NHS in UK, she tells me there is a concept of 2,000 families being allotted to a doctor. And she is the first contact. Anything happens in something like family doctor. Unfortunately, we don't have that kind of a system now. The moment something happens, we talk of approaching a specialist. And that is left to the wisdom of that particular individual, rather than a medical expert who would advise him whom to go. When COVID came, Guleria and Kang Madam and Laharia, they brought out Till We Win, the English version of on COVID details. I requested them, I was in touch with them for almost 2 months. I wanted it to be translated in Marathi so that everyone would be able to have it, access it. Unfortunately, not because of them, but because of their publishers, it couldn't materialize. So I had no other option than to write my own. So I came out with 3 books, which I'm sharing with you. One is in Hindi, one is in English, and one is in Marathi on COVID for a common man. And already 9,000 copies have been sold. Because what a common man needs to understand about COVID, that is there in this book. This is the first edition, revised edition with Omicron in it is coming out. So a common man must know how he prevents COVID. See, adult learning process is something different. We tell them, wash your hands with soap, wash this way, that way. Why? Why with soap and why that way only? How washing with soap helps? Such queries are there in common man's mind. How does vaccination help? Why a booster is required? So many FAQs, they are included in this book, apart from the progress of COVID. And this book, I brought it, in fact, I wanted to translate that till we win, because that is also an excellent book on COVID, written by the experts in the field. But since it couldn't materialize, I had to write on my own. Because unless the common man knows about COVID, it was very difficult for us to control it. No doctor would have been able to control it, because war for COVID was never fought in hospitals, but it was fought on roads. If people are coming together in thousands and maybe even more, no social distancing, or to precisely say physical distancing. Social has something other connotations. No physical distancing, then COVID would be there. And doctors, especially in the second wave, hardly they could do anything with the dropping of oxygen level. No clear-cut medication, may it be remdesivir, or different medicines were tried. Monoclonal antibodies came later on. For Omicron, we went with molnupiravir. Later on, it was said it's not advisable. So different issues had come up. There was no clear-cut guidance. So the best way was to prevent it. So if the prevention was to be there, the common man and the common people has to know what is COVID. And that's what I tried to do. I used to organize lectures in various universities and everywhere, webinars, no one-to-one contact. Fortunately, we have come out of that phase. And therefore, building up the health infrastructure and the health infrastructure related issues will have to have priority. And that's the way at least government of Maharashtra is thinking. And therefore, this year we have maximum financial outlay for health sector. And that would continue to be. Your problems, definitely we'll try to take it up. As far as violence is concerned, already there are some acts enforced. It's a question of enforcement of these acts and rules. We'll take it up at our level. Once again, I congratulate the editorial board of this diary and also thank the organizers for giving me an opportunity to have an interaction with you. Thank you. Jai Hind, Jai Maharashtra.
Thank you very much, sir. Now I request Dr. Alka Shirsagar Madam for vote of thanks.
थँक्यू डॉक्टर वरियारी सर. सर तुमचं जे आता कोरोनाचं जे आम्ही सगळं ऐकलं तर खरंच म्हणजे आम्हाला एक भाग्य आम्ही म्हटलं पाहिजे की यू आर ॲडवायझर टू CM महाराष्ट्र. सो आपल्या महाराष्ट्राचं जे काही हित आहे ते पाहण्यामध्ये सरांचं नेहमी लक्ष राहील याबद्दल आम्हाला खूपच धन्यता वाटते. केल्याने देशाटन पंडित मैत्री सभेत संचार शास्त्र ग्रंथ विलोकत मनुजा चातुर्य येत तसे फार. हे कविवर्य मोरोपंतांचे शब्द डॉक्टर दीपक म्हैसेकर या सोहळ्याचे जे प्रमुख पाहुणे आहेत त्यांच्या बाबतीत यथार्थ वाटतात. थँक्यू व्हेरी मच सर. आणि सर ही नुसती औपचारिकता नाहीये तर आम्हाला खरंच फ्रॉम बॉटम ऑफ आवर हार्ट वी आर थँकिंग यू फॉर युअर ग्रेशियस प्रेझेन्स इन स्पाइट ऑफ युअर बिझी शेड्यूल. IMA Pune thank Dr. Dhanesh Kambekar sir, Chairman Diary Project, for his valuable support time to time in spite of his tight schedule as a vascular surgeon. IMA Pune thanks Dr. Sanjay Patil, Co-Chairman Diary Project. He is always supportive and encouraging to us. Dr. Avinash Bhutkar sir, sir, we are thankful to you for your guidance and support. And Dr. Jayan Navrange, our Pitama of IMA, what to say, today morning only he has shown that he just within a hour, 15 minutes to 30 minutes, he arranged one lecture and he gave an excellent lecture on medical legal aspects. So thank you, sir. And I thank Dr. Raju Varyani, Diary Project Secretary, who is known for his sincerity. He used to come regularly to IMA all these days to make this diary excellent and fruitful. Thank you very much, sir. IMA Pune is thankful to Prathamesh, our printer. He has come with a very excellent diary. The outlook is very nice. And today is World Happiness Day. And the theme is keep calm, stay wise, and be kind. So this is all fit to our secretary, Dr. Raju Varyani. So today is his very happiness day, isn't it? So thank you, sir. So with this, I announce that you can have your lunch on the second floor in Kelkar Hall. There's a delicious lunch today, so you can have. And after 1 hour, around just up at 2 o'clock, we'll start our afternoon session. So thank you very much. Thank you all the dignitaries on the dais and off the dais. Thank you. Yes.
All the IMA members can collect a diary from 3rd floor from Kavita. Okay.
Yeah. Hello. For online members, you can join at 2 o'clock. Exactly 2 o'clock we'll start after our lunch session. So please be there. Thank you. Piyush?
हाँ अनिकेत कंटिन्यू करूया
हा चालू करायचंय. Good afternoon, all. Now we are starting afternoon session, and we have Dr. Nupur Bit Madam, Dr. Dhanesh Kamerkar sir, and Dr. C.N. Makle sir, who will be taking these lectures. So first lecture is Dr. Nupur Bit. So I'll be introducing Dr. Nupur Bit Madam. So she is Dr. Nupur Bit Sarkar. She is MBBS from CMC Vellore and MS General Surgery from CMC Vellore. She has done MCH vascular and endovascular surgery with gold medalist at Madras Medical College. She's got a fellowship in endovascular surgery from Austria, PGDM LE National Law School. Currently, she's a consultant at Ruby Hall Clinic, Jahangir Hospital, and Jupiter Hospital, and Aditya Birla Hospital. So she's got 10 years of vast experience. So over to Dr. Nupur Bit, madam. So welcome, madam.
Good afternoon, everyone. I'm Dr. Nupur, and I'll be talking about the management of venous ulcers. At the outset, I would like to thank IMA Pune for this opportunity to present on this topic. So venous ulcer is an open skin lesion of the leg or foot that occurs in an area affected by venous hypertension. Now, what is this concept of venous hypertension? If there is, so this is a normal flow of venous blood flow assisted by the valves, and when the valves becomes faulty or loose, then they start refluxing. This venous insufficiency is one of the main causes of venous hypertension. Or if there has been an episode of deep vein thrombosis which has damaged the valves, then that also or partially occluded veins, which after a long time also contribute to venous hypertension. Or in patients which have impaired muscle function due to muscle pump failure. So these are the contributing factors for venous hypertension. So persistent elevated ambulatory venous pressure, valvular incompetence, it could be the primary veins, the great saphenous vein or the deep saphenous or great saphenous vein or the short saphenous vein, or in the deep veins. Loss of reflex constriction of the precapillary arterioles. This is how the normal hemodynamics would be. In a heel raise test, this will be standing pressure, and as the heels are raised, the pressure drops and then comes back to normal. When there is a problem, the pathophysiology, this remains almost nearly at the same level and does not drop. So this persistent venous hypertension at the microphysiology level leads to increased pressure at the endothelial cells and leakage of fibrinogen through the capillary walls, which then deposits in the pericapillary tissues. This is known as the fibrin cuff theory for the venous hypertension. The other theory is the microvascular leukocyte trapping hypothesis, or WBC trapping hypothesis. So these contribute to increased expression of matrix metalloproteinases and proteolytic enzymes. Migration of erythrocytes then occurs from the vascular space into the tissues, which then release ferritin and ferric oxide, and this results in additional microvascular cascade and metalloproteinase activation. So the risk factors which contribute to large venous ulcers could be genetic, more common in females, especially due to hormonal changes or progesterone, estrogen. If there's replacement, they have higher risk of DVT also. Pregnancy itself is risk factor, age more than 50, taller people, people who have to stand or sit at one place for a long time, and obesity. So BMI more than 30 also contributes. These are examples of how venous ulcers are, and these could get very painful depending on how much surrounding hyperpigmentation, inflammation is happening. This leads to a lot of disability, and the patients have to do dressings day after day. It impairs their daily quality of life and their daily activities. So if you have one of these patients, the most important point is to get the history. Is there history suggestive of prolonged standing or sitting at work? If there is any history suggestive of a deep venous thrombotic event in the past, and other risk factors which might be contributing. It is important to differentiate venous ulcers from non-venous ulcers. Sometimes there could be a mixed pathology, sometimes there could be vasculitis. So detailed physical examination is also important, and it is important to look for signs of venous disease in the lower 1/3 of the leg. Also to check for pulses and the ankle mobility. Because of the lipodermatosclerosis which occurs, ankle mobility is often restricted, and therefore the calf muscle pump and the foot muscle pump do not work at the same efficacy. So the wounds are usually measured and documented so that you can document how improvement or prognosticate it. There is no evidence to support routine microbiology cultures if there is no clinical signs of infection. However, if despite all your treatment, 4 to 6 weeks have elapsed and the ulcer does not seem to be improving, it is important to do a tissue biopsy to rule out vasculitis or malignancy. A comprehensive venous Doppler ultrasound is the mainstay of diagnosis. Here we need the patient, it needs a detailed evaluation in standing and sitting position. Ideally, it should include GSV reflux, SSV, short saphenous vein reflux, deep venous reflux, any pathology in the deep veins, any residual thrombotic lesion, or if there's INE, sometimes can be seen if it's an experienced operator. Arterial system also, if by clinical evaluation you're not sure, could get an arterial Doppler or at least an ABI. Because in 15 to 25% of patients, they also have a concomitant arterial component. So now why perform any venous intervention? Over the years, decades, these are the interventions which have been done. So we have had superficial vein surgery, deep venous valve reconstructions, venous bypasses, venous stentings, and various compression therapies. The common aim for all of these has been to reduce the ambulatory venous pressure and therefore assist in the wound healing. One of the most common bandage or compression therapies that we now prescribe is the 4-layer bandage. So this is a high absorbent non-adherent dressing as 4 layers. There are many commercial variations of this, or we can do our own variation of it. So the first layer is the orthopedic soft wool. Second layer is a cotton crepe bandage. Third layer is an elastic extensible bandage. And the fourth layer is a cohesive bandage. These 4 layers together usually provide a compression of 25 to 30 millimeters mercury and a sustained pressure. This can be left for 3 to 4 days, sometimes even 5 days if it has not become too dirty. The example of how it should be placed requires a certain level of training. It's not every nurse can be left to do this on their own. You'll have to train the nurse or do it yourself. So this is the first layer. Then the second layer will come like this. Then the third layer. And then the fourth layer. So there have to be 4 layers. Now I'll quote 2 studies. One study was done by our student at Ruby Hall. He studied the management of venous ulcers due to superficial vein reflux with early intervention plus compression stockings versus compression stockings alone. It was a single center study done at Ruby Hall with 84 patients, and all venous ulcer patients due to only superficial venous reflux were studied. The primary objective was time to complete ulcer healing, and the secondary objectives were mainly the recurrence of the ulcer, the rate of ulcer healing, and the quality of life. So in the results, we found that in early intervention, where we have intervened early by endovenous ablation and along with the compression therapy, these ulcers healed with a median period of 1.29 months compared to 2.21 months. And the quality of life in these patients over 2 weeks, 1 month, 3 months, 6 months was much better in the early intervention period. In the olden days, for any venous ulcer, we used to prescribe the Visgard regime, which basically rest, elevate the legs, and continue compression. And we would wait for the venous ulcers to sort of heal, become cleaner before we would go in for open surgery. So nowadays, the evidence is showing that we can intervene much earlier, especially with the endovenous ablative techniques. The second study that I'm quoting is a thesis done in CMC Vellore. They have studied the role of 4-layer bandage in venous ulcer management, and they are assessing the time to healing and compliance rate in an outpatient setting. So time to heal, ulcer healing, and healing with adjunct treatment. So, and they've studied 4-layer bandages versus all other interventions. Okay, this is not showing that well, but out of 167 patients, almost this many were treated by 4-layer bandage alone, and by superficial venous ablation techniques, venous stenting, and combination of venous stenting plus compression. So basically they implied that 4-layer bandage alone will not heal all the subset of patients. You will require another intervention, either superficial venous ablation or perforator ablation or a deep venous intervention to complete management for the other patients. So now coming a little more detail about these techniques, we have the superficial vein ablation, perforator treatment, and deep vein treatment. So varicose veins like this, if not treated timely, will lead to venous ulcers at the gaiters area. So what options we have for these is intravenous ablation. Venocele injection is an option where we inject cyanoacrylate glue, or we could do a hook phlebectomy or foam sclerotherapy, or a combination of these. So endovenous radiofrequency ablation has been around for a while now, where we use the heating element which has a radiofrequency device. It ablates the vein in 7-centimeter fragments. Laser technique has been evolving over the last few decades. Now, initially it used to be the 970 nanometer, then it became the 1470. Now we have 1940 nanometer, which is becoming more and more specific. So as the laser, as more and more advances are happening, we're getting better and better results. For the perforators, we can either inject foam directly into the perforator, or we could use the laser fiber and directly ablate the perforator, which is especially the ones which are below the venous ulcer. Isolated perforator reflux is a controversial area. Some people believe that it should be treated. Some people believe that we should leave it alone. Now, deep venous interventions. We have had multiple studies reporting the presence of May-Thurner syndrome and similar lesions even on the right side. Now, the entire group together is known as non-thrombotic iliac lesions. And the main pioneer in this subset of diseases has been Dr. Sheshadri Raju. He has got multiple papers documenting that these conditions often go misdiagnosed, and they are a major source of venous reflux leading to chronic venous disease. He has a series of 528 patients where he has shown that this is a classical May-Thurner syndrome area. But however, even in the other side, there are 2 lesions or more where their arterial pulsation could be compressing on the veins. So together, these are known as a non-thrombotic iliac vein lesions. In his series, he has reported by stenting whichever segment has stenosis, they've achieved stent patency 94% at 5 years, freedom from swelling at 55% at 5 years, freedom from pain 78% at 5 years, freedom from ulceration almost 88%. Now, to show you a few images from venography, depending on what our target is, we could either put the patient prone or supine and approach through the popliteal vein or through the femoral vein. We need to take venograms in various obliques so that we can clearly see where the lesion is. Even then, in the 2D view, sometimes we miss the lesions, and some of it has been only it's by mentally trying to figure out where the lesion is. So if you take only one image, you will not be able to see the lesion. You will have to take different angles, and you will see collaterals, which suggests that there has to be a significant hemodynamic lesion. And depending on that, we can use an angioplasty balloon and see the waist and then put a stent. With the arrival of IVIS, that guesswork has become a little less, and we have a little more science behind it. We can see the lesion where the arteries are compressing the vein, and depending on from where to where, the length can be measured, and more accurate placement of stents can be done. Few more papers suggesting that 4-layer bandage has a role in the outpatient setting. We can train the technician and or your resident or student, and they can, under supervision, they can do a good job of 4-layer dressing, which helps. But in certain subset of patients where we find that the IVIS or the venogram is showing suggestion of a non-thrombotic lesion, iliac vein stenting will help. So in conclusion, compression therapies remains the mainstay of venous ulcers. A well-applied, well-maintained compression therapy will heal majority of the ulcers. Compliance is a problem because in the Indian summer condition, patients are often not compliant. They don't want it. Sometimes the expense also becomes a factor. 4-layer multi-component dressing reduces our ambulatory venous hypertension. And in certain subset of patients, we do have to consider further intervention, and treatment of superficial deep veins and perforators has become less and less invasive. Thank you.
Any questions? Yes.
Madam, the standard traditional procedure of mapping the perforators and surgical ligation by taking small incisions. Is it still done now or not done?
It is still done, sir. So we do it as a combination. We'll do it as laser or radio frequency. Along with, we'll get the preoperative marking, or even intraoperative, we will double mark the possidal perforator. Either we'll ligate it, or if it's sometimes above the shin where ligating or taking incision is a problem, then I'll put foam.
Yes, anyone wants to ask any question? Okay, thank you very much, madam. So, madam, wait. I will request our president, Dr. B.L. Deshmukh, to come on the dais to felicitate our madam, Dr. Nupur Sarkar. Thank you, thank you. Now, our next speaker is Dr. Dhanesh Kamerkar, sir. Sir, he's a head of the Department of Vascular and Endovascular Surgery, Ruby Hall Clinic. And he's a consultant vascular and endovascular surgeon at Jahangir Hospital and Medical Research Center, Pune. NM Wadia Institute of Cardiology, Pune, Pune Hospital and Research Center. He's a visiting vascular surgeon at Manipal Hospital, Goa. I think he has been already introduced by Dr. Raju Varyani. He's our diary committee chairman. So we have seen that very nice diary has been released today afternoon. So over to Dr. Dhanesh Kamerkar, sir.
Thank you, madam. So this is online also going on?
Yes, sir.
Okay.
Online also going
Correctly. असायला पाहिजे. टेक्निकल डिटेल मला माहिती नाही. सो काय मेल उघडू का?
हा, मेल
विषय जाणार नाही, रन नाही होणार. वायफाय काय?
MILP 908. आपलं तो हे आलेलं आहे लिंक, ती लिंक सरांना पाठवली सरांच्या मेलवरती, त्याच्यावरून तुम्ही जॉईन करून ते शेअर
मेल वर क्रोम वर जीमेल. पासवर्ड काय शाळेला निलेश हा मोबाईल कोणाकडे मोबाईल 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 कोणाकडे मोबाईल दिला मोबाईल
माझ्या मोबाईलवर आहे, काय करू का मोबाईल सर? हे लिंक देऊ का मी?
पासवर्ड
हे आता ह्याच्यावर नाही
मोबाईल आता मी कोणाकडे तरी दिला
सर. हे बघा, लिंक आहे, हे ओपन करता येतं नाही याच्यात येणार. Click here to join.
Launch
Okay. Open.
As a panelist, correct?
Recording in progress.
Share screen. Share screen.
हे व्हिडिओ ऑन करेल, हे ऑन करेल लागेल ना.
Minimize करो.
फुल स्क्रीन केलं नाही येते नाही दिसत
स्क्रीन दिसतंय तिकडे नाही दिसत
नाही नाही ऑनलाईन नाही दिसत आहे मी पुण्याच्या
स्क्रीन शेअर करते ऍपचं माहिती नसते ऍपलचं माहिती
सर हा हे काढून टाका हा काढून टाका आणि शेअर स्क्रीन करा तुमच्या याच्यावर व्हायला पाहिजे ना
स्क्रीन कसं करायचं ओपन केलं फुल स्क्रीन केलं मग टॅब कशी ओपन करायचं
सर ऍपलचं ना ऍपलचं आहे सर ऍपलच्या बाबतीत
तर ह्या मॅकबुक वरती स्क्रीन शेअर कसं करतो आपण एक सेकंड नंतर इकडे येऊ परमिशन देऊ ओके ऍडव्हान्स्ड डेस्कटॉप मध्ये आता मी एक काम केलं आता मी पूर्ण स्क्रीन केली
पण इथे फुल स्क्रीन दिसतंय गुड गुड येस
Okay, good afternoon, everybody. Sorry about those Apple glitches. High time, probably either I stopped using Apple or. So I'm going to speak on carotid endarterectomy versus carotid artery stent and when to offer which is a question today. And I've been giving talks on these kind of comparisons for many years. And I remember almost 15, 20 years ago, carotid artery stenting was just emerging and there are lots of issues regarding peri-procedural problems. But as the technology advanced, they came up with good protection devices, distal protection devices, good stents, tapered stents, closed cell stent and open cell stent. And over a period of time, it almost caught up with the carotid endarterectomy. But what's the situation today is what we are going to look at. So these are carotid plaques and they literally are like a loaded gun. So you can see basically plaque hemorrhage, and if this gets embolized into the cerebral circulation, one gets a major or a minor stroke. So what are the change scenarios for last at least 10 years in carotid? So role of carotid endarterectomy in stroke prevention has been proven for last almost 40, 50 years. Now, a lot of things depend on plaque morphology because if it's an ulcerated plaque, it's better to do surgery under proper control rather than stenting. But in today's day and age, carotid stenting has become a kind of a mainstay over endarterectomy. Is that really the truth? Is what we'll find out. There are lots of issues why it has done so. but I will not address those. So earlier carotid artery stenting was unprotected. Later on it became distal protected device protected. And there were lots of trials of carotid endarterectomy versus carotid artery stenting trials, and also against best medical treatment. So these were the basically Professor Frank With, a famous vascular surgeon from New York, mentioned. This is almost about 10 years ago, or maybe slightly more. Carotid artery stenting is emerging as best and safest when carotid intervention may not be needed at all. So is CEA, that is endarterectomy, now better after all, and will this change with better devices? Is what was the question raised then, almost 12 years ago, I guess. So you have a Doppler picture of carotids here, and you have an ulcerated plaque vis-a-vis against a smooth atherosclerotic plaque. Probably there's no calcium there, but it's a very smooth plaque. And this is what basically, so if you have an ulcerated plaque, they're more prone to rupture, form the hemorrhage or a clot, and they can get embolized and form a stroke. Against that, these are the smooth plaques which can remain asymptomatic for years and years unless there is no progression. Even if there's a progression, as long as the surface is smooth, they can remain asymptomatic. So what's the evidence-based medicine? So major plaque surface irregularities correlate with the neurological symptoms. So if the plaque is ulcerated, the rupture forms hemorrhage, embolize, and get a TIA or a minor or a major stroke. Symptomatic ipsilateral internal carotid artery stenosis, more than 70% would benefit by carotid endarterectomy. This was a NACET and ECST trials, and this goes back really almost 30 years ago. So carotid endarterectomy has been a gold standard for 5 decades. The randomized trial showed that the carotid endarterectomy is safer than carotid artery stenting in patients of symptomatic severe stenosis. So important, patients of symptomatic severe stenosis, endarterectomy has been shown to be safer than carotid artery stenting in randomized trials. So what is symptomatic? Patients with more than 70% stenosis with TIA, amaurosis fugax, like seeing black spots or black curtains in front of eyes, retinal blindness, or a stroke with good recovery. Sometimes one may see silent ipsilateral cerebral infarcts also if one does MRI. And sometimes with CABG, if you do carotid screening or Doppler examination of the neck, you may find a tight stenosis in carotid. Sometimes you have to do carotid and endarterectomy and CABG together. Again, we have a small subset of bilateral high-grade carotid stenosis where one side could be occluded. And still there's a big question about what we should do for more than 60% ulcerated asymptomatic stenosis. These are different randomized controlled trials comparing endarterectomy versus carotid artery stenting. Some of the trials were stopped from Leicester and Naylor 1998, EVA 3S, which was stopped because of poor outcomes following stenting, and these were unprotected carotid artery stentings. There were trials which were completed like Cavitas, Sapphire in 2004, and Space in 2006, Brussels. There are few trials which are still ongoing, CREST 2 and ICSS. And these are the trials, ACST2, which are planned, and now basically the results are out, where CA versus stenting versus medical treatment in asymptomatic patients. Space 2 results not out yet. So these were different trials, and these were the indications criteria for surgery, whether carotid stenting or best medical therapy is based on 5 groups of elements: evidence-based medicine of data and long-term results, regulation, ethics, patient's characteristics, symptoms, anatomy, and operator's experience. So these were the lessons we learned from randomized trials. There's a sound evidence for carotid artery endarterectomy indications, more than 70% ipsilateral symptomatic ICS stenosis, more than 75% asymptomatic stenosis, but advantage of asymptomatic is marginal because complication rate should be less than 3%. Some more lessons from trials. There was certainly evidence needed for role of endarterectomy in non-hemorrhagic symptoms and value of timing of CA in patients undergoing CABG prior or combined. Now, as far as the timing of endarterectomy is concerned in a fresh TI or a fresh stroke, generally now the time has come down from day 3 to day 14, and that's the best time to prevent any more further strokes, which was again earlier, which has 6 weeks. So from 6 weeks, the timing has come down to 3 days to 14 days. and value of search for high risk asymptomatic carotid stenosis depending on Doppler findings and CT findings. This is just a classical operative picture where you can see the shunt inside and you can see the plaque inside the carotid artery, and this is basically stenotic plaques. Here the plaque being dissected from adventitia and part of media, and this basically dissected completely 360 degrees, and here you can see the complete denudation of the plaque and artery basically is adventitia and part of media, shunt in situ, and this basically defect or arteriotomy of the carotid artery is closed with the patch, which is PTFE, can be vein. That's how the plaque when taken out looks like. There are certainly certain limitations for carotid endarterectomy, and which is where they are better for carotid artery stenting. For example, high intracranial internal carotid artery lesions at the C1 or C2 level. So surgical exposure becomes extremely difficult and challenging. Previous irradiation to neck, restenosis, or poor cardiovascular and respiratory reserve. So these are the four categories where one could consider offering carotid artery stenting or carotid endarterectomy. But there are also certain limitations for carotid artery stenting, which are again better for endarterectomy. So you have symptomatic carotid artery stenosis more than 70, but good cardiovascular reserves, tortuous arch vessels and iliacs with severe atherosclerotic plaques in the arch, which can get embolized while doing manipulation of wires and causing strokes. Ulcerated plaque in carotid or fresh thrombus, endarterectomy is better than stenting. Near total occlusion of carotid artery, again, wire may not go through for stenting, and it's a better option for carotid endarterectomy. Certainly, octogenarians, people who are more than 80 with carotid artery stenosis symptomatic, endarterectomy favors much better as compared to stenting. Now, one would argue or feel that stenting is less invasive, but no. Then all the trials have shown that the surgery shows a better results in people who are more than 80 with symptomatic high-grade stenosis. And again, heavily calcified carotid bifurcation or bulk, where you're not able to dilate this carotid stenosis because of the heavy calcium, and they're better go for surgery. The Sapphire trial, patients with high risk for endarterectomy, CAS is an equivalent option. Anatomical and medical high risk were considered. In Cavitas, carotid artery stenting advantage in high risk symptomatic in severe stenosis, but so these were kind of incomplete. So this was a CREST investigator, CAS associated with increased complication in octogenarians. This was a 30-day stroke and death rates in CREST lead. So people more than 80 symptomatic stenosis should go for surgery. So carotid artery stenting, what's the status now? 2021, it's a well-established modality, but certainly one must focus on two areas: endovascular access across arch and embolic protection. When you basically put a distal protection device and they grab this atheromatous porridge stuff when we are doing dilatation, and this is what can go northwards into cerebral circulation and cause a TIAs or a stroke, and which is why you have this what is called as an angioguard device. It's a retrievable basket or a distal protection device. So before doing angioplasty and stenting, this has to be there in the distal ICA. Sometimes these were the pictures. So when you do the stenting, atheromatous debris is bursting and embolizing. So particles are staying in place with danger of later embolization. So you can see stent being deployed, but some atheromatous plaque peeping inside the lumen of that, and this can get embolized easily. And to overcome this, the technology has come with a closed cell stents, which basically can avoid this or prevent this. Now, these are a couple of new data. This was in September 2021 Lancet, ACST2 asymptomatic carotid surgery trial. This was randomized comparison of stenting versus carotid endarterectomy, followed up for 1 month, 1 year, and 5 years. The interpretation of this, that serious complications are similarly uncommon after competent CAS and CEA. So, kind of no difference here whether to do stenting or endarterectomy in asymptomatic carotid artery surgery training, provided in competent hands. But long-term effects of both on fatal and disabling strokes are comparable as well. Now, this was in asymptomatic carotid surgery trial. Now, Cochrane database, which has come out in 2020, again comparing multiple trials, endarterectomy versus stenting. So written by Martin Brown et al. published in 2020. So objectives were to assess benefits and risk of carotid artery stenting compared with endarterectomy in people with symptomatic and asymptomatic carotid stenosis. Excuse me. Selection criteria were the randomized controlled trials comparing both in asymptomatic and symptomatic, and also RCTs comparing carotid artery stenting and BMT alone, best medical therapy alone. There were 22 trials involving 9,700 odd patients, and these were the results. In symptomatic stenosis, carotid artery stenosis had a higher risk of periprocedural death or stroke as compared to endarterectomy. CAS had a lower risk of MI, cranial palsy, access site hematoma, which is just obvious because it's a lesser invasive puncture-related procedure as compared to open surgery. But it definitely showed a higher risk of periprocedural death or stroke. These basically in symptomatic stenosis. During follow-up, carotid endarterectomy was favored as modality for periprocedural death and stroke. Rate of ipsilateral stroke after periprocedural period didn't differ between both modalities. So once the periprocedural period of 1 month goes away, then results are more or less same in each category. But in asymptomatic stenosis, there was non-significant increase in periprocedural death or stroke in stenting versus endarterectomy, and follow-up showed no difference. Again, importantly, there was a moderate or high-grade stenosis during follow-up, which was more after carotid artery stenting, understandably, because we don't basically dilate or for 100% complete dilation. What does it mean for plain people or plain language summary? So what is, are the stents better or surgery better for carotid stenosis? Standard treatment is remove stenosis by endarterectomy and we do a patch closure. Carotid artery stenting is alternative treatment. There are Assays randomized studies up to 2018 in the Cochrane database, 22 studies with 9,700 patients. The key conclusions were in symptomatic, carotid artery stenting caused more strokes or deaths in periprocedural than surgery. And especially true for people more than the age of 70. So from octogenarians, now we are moving down to 70 years plus above. Anybody with a symptomatic tight carotid stenosis without any other comorbid conditions, surgery is better than stenting. Follow-up period, both have equally effective in preventing stroke or death in a follow-up period. And asymptomatic stenosis, both similar risk, short and long term, but certainties of evidence in these are very moderate. So results should be interpreted with the caution. So in summary, NASET, more than 60% symptomatic stenosis need endarterectomy for a stroke prevention. Carotid artery stenting is alternative treatment. Specific indications for both. Sometimes they can be overlapped, which can be patient-centric, but as long as one sticks to the strict indications, either for stenting or surgery, that would do good. If good cardiovascular results, endarterectomy always is the first choice as plaque stenosis is removed. If the poor cardiovascular results and if contraindicated for surgery, as mentioned earlier, and carotid artery stenting is a good alternative. We still need more data to see if carotid artery stenting is superior or non-inferior than endarterectomy. Thank you. Let's have questions. Is it? I can't see it here.
Medical students at BJ in 1985, she had a stroke. She was, I think, second year MBBS, first year maybe. And all four arteries were found to be blocked, both vertebrals and carotids. So that time she went to Mumbai and got the vascular replacement done, and not the stenting or endarterectomy. And 36 years she's doing well.
So I think probably the pathology what you're describing, being young and all four vessels involved, must be Takayasu aortoarteritis. And generally there's no role of endarterectomy or stentings are just plain balloon angioplasty in those days was not there. But later now even plain balloon angioplasty is a good enough option to bail the time out. And sometimes even we have done replacements of carotids and subclavins in one of these, some of the Takayasus. I'm right. POBA is a good treatment now for Takayasus. Yeah. So they must have done a kind of replacement of carotid by vein graft. Yeah. Where do you see chat box? It's not here. Chat box. No, three questions about chat. We go to move next one. You want to have any comment, Dr. Makle, because he is in a big way into carotid stenting, and I'm here with surgery and sometimes stenting.
Basically, we are at two sides of the same coin. One does surgery and other does intervention. But there is always a neurologist in between who decides what will get benefit from it. But anyway, we conjointly do it, and in my presentation, I'll show you how the things are being done. So, and in the coming with the hybrid OT, my entire vascular team will be with you for every day.
Honestly speaking, stenting and endarterectomy have a very specific indications in today's day and age. If you follow those indications, you know whether patient goes for surgery or whether patient goes for stenting, not going into the commercial aspect of it. We go for the next one. Next. कुठे गेला मला गेला Swap displays? No. You go back now. Close करो. हाँ, कुठे? Text. This one. Hello? Yeah. I'm just going to continue before Dr. Makle takes over the last talk of the day. Acute and chronic or critical ischemic leg endovascular management. So why endovascular interventions? Anatomically or surgically difficult access lesions are better accessed by endovascular approaches. Many times patients are unfit medically for any open surgeries. There's a lesser hospital stay, the quicker recovery, and they can rejoin their jobs, especially if they're young, earlier, achieve good quality of life, undergoing less. And insurance companies are covering pre-existing disease now. What kind of procedures endovascularly for acute or chronic critical ischemia of the legs we're looking at? So you have a catheter-directed thrombolysis, arterial or venous, suction thrombectomy, mechanical, balloon angioplasty, stenting, stent graft insertions, embolizations, laser ablations. I will not add that. So these are typical examples of bilateral iliac stenosis, iliac lesions, aortoiliac bifurcation. We open it with a kissing balloon technique and put two kissing balloons so there is no plaque shift onto other side. and then 2 stents simultaneously into both iliac peeping into aorta. This was one case where there was a multiple segment SFA stenosis, and this was balloon and then stented here. The problem with the SFA, because SFA is a vessel is kind of which keeps on moving inside the thigh, and it has more atherosclerotic involvement in the mid thigh and adductor around adductor eyes. So there have been long-term patencies of these stents have not been good as compared to bypass, and there have been a lot of technology developments in these SFA lesions, and now we have what is called as a Supera stent, which is a vascular mimetic stent, which provides a natural movement for durable outcomes. Now, this is an innovative interwoven nitinol design, which creates an implant that supports rather than resists the vessels, resists kinking also, as well as fracture with minimal chronic outward force, and supports the natural movement of the vessel for high patency rates. And so, clinically, what it means is that maintains a round open lumen for normal healthy blood flow in challenging anatomy. You can see as basically if you bend the leg, how the SFA can be basically flexed like this, and these kinks can cause either fractures or kinking, and that's where the Supera stent, which is a vascular mimetic, have come into technology, and the long-term results of patencies are better. So here's an example. You have a long occlusion of superficial femoral artery, and which is dilated. So you need a pre-dilatation preparation of vessel bed with a bigger size balloon, and then you put a smaller. So if you dilate it with 5.5 size of balloon, you put a 5 mm of stent, and vice like that. If it's a larger balloon, still 6 mm balloon, you put in a 5.5 stent. So this is the kind of new technology which is available, which is giving a better long-term patencies as compared to earlier stents which were put in superficial femoral artery. I'm going to basically just show you 4 cases. This was Mr. T, who had acute pain and discoloration of forefoot amputation, amputated foot for 2 days, diabetic previous SFA stenting, TP trunk stenting 6 months ago for limb salvage, Doppler showed stent thrombosis. It was taken up for DSA and revascularization. Plan was to do mechanical thrombectomy and then do a balloon angioplasty, and we used the angiojet machine. So here you can see the pre-procedure, and there's a complete thrombus here in the SFA popliteal. Stent is thrombosed, no flow in the stent, some flow in the distal popliteal, but that, and then the distally antitibial artery is filling nicely. Here, so we tried to get a wire across into the stent. Is it moving? This thing. Yeah. So we tried to get a wire across into the stent, and this was the distal runoff, which was seen again. You could see a tight stenosis at the origin of the TP trunk stent. And you can see long thrombotic occlusion and stenosis going into distal popliteal and ATA. So this is an angiojet thrombectomy system machine, which is used, and you have a mechanical pulverizer catheter, and you put it over the guide wire, and then it pulverizes the thrombus as well as aspirates. And if required, you can also introduce thrombolytic drugs through this when you're doing a mechanical thrombectomy. So here the wire has gone across, and you can see this is the movement of the angiojet machine all across, all the way into antitibial artery from the stent through the stent. And here you can see up and down movements of angiojet catheter. And there's a fairly good clearance after using angiojet machine. You can see the vessel is nicely opacified all the way up to tibial thing. There's some stenosis there, okay, which was addressed. So another run of angiojet was done. Then we ballooned this, the entire stent. You can see the balloon being dilated. So balloon has given a good yield, completely dilating the stent. And that was a final picture of nicely opening up the stent of SFA popliteal and all the way down into dorsalis pedis. This is another picture patient who were presented with acutely ischemic left leg. Angio showed extensive femoropopliteal thrombosis, faint tibials. Basically, with the view of this picture, we took it for hybrid surgery, revascularization. So we did a surgical open transfemoral thrombectomy. And when we did an on-table angiography, the entire SFA popliteal was thrombosed. We couldn't clear the thrombus surgically. So we did a distal balloon dilatation of popliteal and TP trunk endovascularly. So here you have a picture. There's a still residual thrombus in SFA popliteal. We managed to get a wire across all the way down, then did a multiple dilatation. You can see the balloon being dilated. I think this is 3 millimeter balloon. Wire going all the way down into the posterior tibial. So these were the runoff vessel after doing early angioplasty. And here you can see another balloon being sent the entire length, right from area posterior tibial all the way down to popliteal being dilated. And these were the final pictures. Now this here we had to put in a drug-eluting stent because there was a residual stenosis in the TP trunk. You can see it here. So that's the residual stenosis in this segment. So this is the tibioperoneal trunk. So we had to put in a drug-eluting stent, which we, the same like what we use it for coronaries, and to keep it to have a long-term patency. And this is the final picture right from top. So we did a femoral thrombectomy and then distal angioplasty and then TPT trunk, which was probably the causative lesion to present as an acute ischemia, causing thrombosis. And that's a runoff going into the posterior tibial all the way into foot. This is another one, critical ischemia, gangrene left fifth toe, rest pain, 3 weeks old, diabetic, previous right leg tibial angioplasty 2 years ago, doing well. CT angio showed tibial disease, multiple stenotic segments and occlusions. It was taken for antegrade, femoral puncture and balloon angioplasty. This we just did about a week ago. So you can see the tight stenosis at the AT origin as well as this in peroneal as well, and multiple segment stenotic leg segments in tibials. So the distal tibials being filling here. And that is going into the foot. So you can see the wire being advanced into antitibial as well as peroneal. First we entered into antitibial artery. Can we appreciate that? I'm not sure. This one. That one. Yeah, so this is a 014 wire, 018 wire directed into the antitibial artery. And here it's crossing the entire occluded segment and going all the way into foot. You can see the wire now going into the crossing that occluded segment of antitibial into dorsalis pedis artery. That's a dorsalis pedis artery here. Then we did a balloon dilatation with a small balloon, 2 millimeter, and we have these long balloons almost to the length of 300 millimeters. So the advantage is that because single dilatation, there are very less chances of dissecting the artery. If you do multiple balloon dilatation at a shorter length, the chances of dissection are more. So these are again technology helping us with longer balloons. So this is the balloon dilatation with 2 millimeter and then followed by 2.5 millimeter. You can see the balloon here all the way into dorsalis pedis. And you can see the entire anteriotibial artery is completely opened up, dilated. That's an ATA artery. And then subsequently, we opened the peroneal artery. You can see the wire going into the peroneal artery. And coming all the way to the just above the ankle. That's where it basically gives collaterals to both ATA and PTA. And again, did a balloon dilatation of the peroneal artery. That's going into the foot. So nice runoff into the foot. So this is the fourth one, the last one. He presented with critical ischemia and ischemic ulcer and rest pain of the third toe. Diabetic, ejection fraction was 25 to 30%, creatinine 1.5. He had a previous tibial angioplasty on other leg 4 years ago, and the leg is doing good. CT angiography showed a complete occlusion of SFA and tibial. The antegrade femoral puncture, and you can see there's a big calcium there in distal SFA, which is actually difficult to pass or open up. That's a tibial is going down. So this was the segment. You can see the big blob of calcium here, and that's where we had a lot of difficulty in traversing that. Somehow we managed to get a wire across the balloon dilatation with a small balloon, 3 millimeter. Couldn't give a good yield. The recoil again. The tibials were not too bad. Posterior tibial was okay, but the ATA, PTA both had small, I would say, moderate stenosis. So this is dilatation of SFA here. And post dilatation, these were the results. Then with the long sheath, we came down into below the knee and they dilated tibial arteries. You can see the tibial being dilated. That's a posterior tibial dilatation. Another dilatation of TP trunk. And here it was quite tight, so we had to put in a drug-eluting stent here. That's the stent being deployed. Again, a coronary drug-eluting stent. That's a stent being opened up. And then coming out, we had to open the SFA, and we used a 5 millimeter balloon which burst. And then we put a 6 millimeter stent and then post-dilated again with the 6 millimeter. That's a picture. So this is a stent deployment. Here the stent is being deployed and then post-dilatation with the balloon. Another post-dilatation. That's the final picture. So his rest pain got relieved, and because of his EF, which was low, we had to play it gingerly, not pushing too many fluids, and even the contrast with a lot of dilution. So in conclusion, majority, at least 80 to 85% patients of acute and critical ischemia can be managed endovascularly. They are ideally in unfit patients for open surgery. A lot of these patients are diabetic, have a chronic kidney disease, previous MI with reduced ejection fraction, etc. The new devices like Supera stent, atherectomy devices, mechanical thrombectomy devices or thromboaspiration devices, long balloons and stents. And now we also have a technology, what is called as intravascular lithotripsy. So how you have lithotripsy for kidney stones, likewise for a huge chunk of calcium, we have an intravascular lithotripsy, which breaks the calcium in the artery and opens up the artery for us. So these technologies are available. Patients' acceptance is better for less invasive endovascular options. Again, insurance companies are covering it. And above all, what's really the important thing, the presence of hybrid OR, where we can do open and endovascular surgery together at the same time, is a big boon for our patients in Pune. In fact, Ruby is the first hybrid OT in the city. Dr. Makle will take us through what is hybrid operation theater, why do we need it, what is its role in today's day and age, and what all things, what all procedures we can do effectively, giving best benefit to the patients, reducing the cost as well. Thank you. Questions we take now or later? There it is.
Thank you very much, sir, for both these lectures you have taken together and about carotid artery disease and acute and chronic critical ischemia of leg. So they were very wonderful. So just to see all the time you are putting that wire and it is going, it is looking very easy, but it must be a very drastic job for you, and you are really a pioneer of that. So I really appreciate your surgery. So thank you very much. Now I will request our President, Dr. B.L. Deshmukh sir, and our Vice President, Dr. Raju Varyani sir, to come here to felicitate our sir, Dr. Dhanesh Kamerkar. Yes, thank you very much, sir. And Dr. C.N. Makle sir has already come on the dais, and we'll be preparing just within 1 or 2 minutes. By the time I will introduce our speaker, Dr. C.N. Makle sir. Dr. C.N. Makle is an interventional cardiologist at Ruby Hall Clinic, Pune. He is also a professor of cardiology and director of cardiac cath lab, which is one of the premier cath lab department in country. He graduated and post-graduated MBBS and MD medicine from BJ Medical College, Pune. He did his DNB cardiology from National Board examination. He has been a bright student all throughout his career. He has been awarded FSCC Fellow of American College of Cardiology, FSCAI Fellow of the Society for Cardiovascular Angiography and Interventions, FCSI Fellow of Cardiovascular Society of India. His keen interest is in interventional cardiology. He has performed more than 1 lakh angiographies and 40,000 interventions. He is well acclaimed professor of cardiology and loves to teach. He has got more than 30 publications to his credit, and couple of which has been cited. Thank you. So just within 1 or 2 minutes, by the time we are arranging the laptop, and we'll start. इथे खाली आहे. हा. Click here to do. काय झालं सर ते फिजिकल आहे ना म्हणून तो मला की सर इकडे फिजिकल येणार आहे म्हणून तुम्हाला इंडिव्हिज्युअल पाठवलं नाही आम्ही. त्या लिंक सगळ्यांना पाठवतो आम्ही ऑनलाईन असतो ना तर पाठवतोच ना. नाही नाही. जो इंटरनेट काय होतं.
Recording in progress.
दिसतं. ऑनलाईन. येस. चेंज होतंय का बघा. चेंज कर. Yes. So sir will be speaking on hybrid OT advantages, when, how, all know how. So over to Dr. C.N. Makle sir. Sir, please start. Light sticker.
Good afternoon, everybody. At the outset, I'd like to thank all office bearers of IMA Pune and all faculties here for inviting me here and discussing about the new hybrid cath lab. Now, whether you call it as a hybrid OR or whether you call it as a hybrid cath lab is an individual choice, because it is the amalgamation of the two suites. One is a cath lab and one is a theater, but it is indicated for a particular type of procedures where there is a requirement of both specialties, or I'll put it both super specialties, for benefit of the patient. Now, here is a patient who was done in 2015. This particular gentleman who was a 44-year-old male and had acute dissection of the aorta, as you can see, which is starting just next to the subclavian artery. It is a multiplanar dissection which is going all the way down up to the side, up to the iliacs. He was shifted from all the way from Karad here. I remember it was the 30th of December 2015, and that time we did not have a hybrid OR or a hybrid cath lab. Now, how we proceeded with this particular patient, with the help of our vascular surgeons and cardiac surgeon also. The first, initially the patient was taken to the cardiac theater, where Dr. Ranjit Jagtap did the debranching, what we call it as, that he connected the ascending aorta to both carotids. Whereas Dr. Nachiket Purandare and Dr. Kamerkar, they did extracorporeal graft, which was from the subclavian artery going down right up to the iliac artery and also going up to the contralateral iliac artery. They also did one carotid to subclavian bypass. So all these particular external circulations, they were initially taken care of. This particular procedure required something like, we started somewhere around 1 o'clock. Patient reported to us in the morning hours around 7 o'clock. He was taken for the first surgery around 1 o'clock, and by 12 midnight this was done. And after that, we put a graft which was extending from the ascending aorta, going down up to the descending aorta, sealing the dissections. So it took practically more than, I remember it was the 30th of December, 30th, 31st, everything was with us, we spent on this particular procedure in a 2 different operation theaters and cath lab, etc., etc. Now, with hybrid cath lab or hybrid OR, it can be done in the hybrid OR itself. Because whatever the surgical procedures they were there, they were done in a theater, whereas the endovascular grafting, which was done in a cath lab. So here it is a combination of the two, and this patient has been doing well. He is on regular follow-up with us, and he is doing well. So you can see this particular dissection, which was extending right from starting from the subclavian going down all the way to the iliac, was being taken care, and he's really doing good for last 5 or 6 years. So here is the importance of the hybrid cath lab, where there is a cath lab where you can do not only the angiographic procedures, but also you can do the surgeries, be it a minor surgery or major surgery. There are the certain surgeries where you need the imaging, where you need to know the flow across the vessel, where you do, while you are putting the grafts, etc. So therefore, these type of units are important for us. When as the evolution of the medicine, as the evolution of the procedures has started, initially it was with the interventional radiology, then it came to the neuroradiology, cardiology, oncology, etc. So the other different disciplines which can do interventional procedures here in this particular suites. Whereas there are surgical disciplines also like vascular surgery, Dr. Kamerkar, cardiothoracic surgery, neurosurgery, or trauma or orthopedic surgery. So it is a combination. This particular unit can be used by both specialties, all the specialties, where there is a requirement of the imaging, where there is a requirement of the surgery. It can be, you can do the more complex procedure, but or it can be, you can make it less invasive also. Now, this particular environment, what it needs is the basically either interventional cardiologist or radiologist, a radiographer, technical team. Basic thing is high-end interventional X-ray system. The X-ray system which is used in this particular system is a high-end digital X-rays at a low X-ray radiation. That means you get the images which are by algorithms, they are excellent as of today, but the amount of the radiation is definitely less. So it is safer for the patients as well as for the operators. And then of course you need the consumables, etc. And you need like a surgeons, both the surgeon here, we mean both surgeons as well as cardiologists or interventionists. You need the OR staff, nursing staff. You need a clean air. We are proud to tell you that our unit has got the HEPA filters, which can take care of like any 6 Sigma surgical theaters with all those international criteria and maintaining the high pressure and maintaining the positive pressure balance. Sterility is of utmost important, and surgical lights with the surgical table, surgical equipments, etc., and instruments, along with the interventional equipments which are being used in this particular typical procedure. Now, who are the faculties which can use? It can be the cardiac surgery. It can be the vascular surgery, as Dr. Kamerkar has shown, where you can do the surgical graft at the same time that distally you can do the intervention in the same sitting. You can see the fruit of the surgery at the end of the procedure, whether flow is good down distally or not. You can do the neurosurgical procedures with the clipping, etc., with simultaneous coiling through the catheters. You can do the spine surgery, you can do the thoracic surgery, or you can do the other surgeries also orthopedic surgery. So there are the different specialties or disciplines which can use this particular facility, where you need both imaging, interventions, as well as surgical procedures. So these are the different types of procedures which can be done, like vascular, what Dr. Kamerkar was saying, the EVAR, or the endovascular repair of the aortic aneurysm or dissections. The first case what I have shown you. The cardiac procedures, the tower we have been doing regularly, that is a transcatheter aortic valve replacement, which can be done through the, where you need to expose the femoral arteries surgically at times. So there, this can be definitely used. It can be, in the future, will be the mitral replacement or complex pediatric cases, complex electrophysiological procedures. There can be the neuro or spine operations, particularly those which are the fixation, where you want to see the simultaneously what is happening to the vascular supply or the neuro organs, etc. And other applications can also be there, and it can be also used for the robotic hybrid suit. We also have got a robotic angioplasty also. So far we don't have, but we'll be getting it soon. So all these things where angioplasty can be done, I'm sitting here and angioplasty can be done there. So they are the things which are evolving over a period of time. This needs a particular space. It needs a certain cath lab table, injectors, intravascular ultrasounds, FFR, IFR. These are all the equipments we have got with us. We have got the OR table, OR lights. Yes, definitely the anesthesia equipment, the trolleys, lighting, laminar flow, which I have already alluded to, and of course the inventory, etc. So these are the things which are required, and of course with the organizational structure with administration to help you out. And education and training is of utmost importance, because we want to create the next generation who can advance further. So these are the, for example, in the cardiac surgery, we can need the bypass equipment, or we can see the ECMO. We can need these different types of the imaging instrumentation. And this cath lab will be busy like this when we are actually using. Whereas in a vascular surgery, Dr. Kamerkar, Dr. Nupur had shown you, the IVUS has definitely come into the play. The IVUS we have got, and these can be used during the same procedure, and during the neurosurgery, surgical navigations can be also used. So it is an optimal utilization of the space, positioning the flexibility. Say when you are operating on a particular patient, your imaging is there, but at the same time, the imaging should go off physically at particular point when you can operate and you can get the imaging back there. So this is what is more important here. That is a flexibility. It should be the workflow without compromises, because patient safety, sterility is utmost important. And every patient, you can have the full body coverage where you can do any particular procedure from head to toe in this particular group. So here is this is a cath lab which we have got. It has been inaugurated just at the this week itself. We are waiting for the clearance from the infectious department for the bacteriological cultures, because without that we cannot start, and it is not safe for the patient. But we will be using it in the possibly in the early of this next week itself. The advantage, this has got a 20-inch large image intensifier. See, mind well, we had a cath lab previously with the large detector, etc. We were using it, but now we are advancing it further with the surgical environment. So these are the certain pictures where it can be parked in a different directions. These are not our photographs. I'll show you afterwards my photographs also. So this is what it is now, that you can see the C-arm, you can see the imaging system, you can see the patient stable, you can see the technical room, etc. in a given situation. This is what exactly it is. Here is an example of one particular coronary angiography. I, being the cardiologist, at this stage, now this particular table also, it moves in different directions. It can go back and forth, it can go up and down, it can tilt, it can go through the 90-degree along the side, or it can go into the swivel movement also there. So there are the different types of the movements which can be done with this particular table. They are all electrically motorized, automated, and they are for the comfort for the interventionist as well as for the surgeon. Because for the surgeon, at times giving a particular position on a table is equally important. Now, I'll go further. So here is a situation where you need a smart technology, you need a more control, and you need to have the better awareness. Basically, you have to have a system which can be used for a benefit of the patient, benefit of the procedure, ease of operation, maintaining the sterility, etc. And therefore, there are the different types of the modalities which are there, which can be either can be the high and grid switch detectors, etc. The clear spectra beam where the beam is concentrated. So these are the certain things which are radiologically very important and safety as per AERB guidelines. We strictly follow the Atomic Energy Radiation Control Board's guidelines. In fact, we are ahead even beyond the Indian standards also. Now here it is a full flexibility and patient access, because it should not happen that patient is covered completely and you can't go near the patient. That's where exactly you can do. At the same time, you can use the different gadgets and you can have the ease of surgery. So it is a free positioning of the staff, easy to reposition, have the good sort of predictable movements of all the equipments, and with this you can do any of these type of surgeries or any of these procedures, be it interventional or you can do it with the surgically also. So you are transforming the complex PCI with the biggest innovative tools. Here, for example, we have been using this particular stent boost technology where you can see the stent much better. It is a stent enhancement where you can see the stent positioning. When here there are the two stents, one stent is going like this and there is other stent going across. So you know that it is a not only a millimeter, it is a sub-millimeter positioning is the most important, and therefore it can avoid the dystenosis. So therefore this is the angiographic depiction, whereas this is the stent boost, and you can have the combine called as a stent boost subtract. So also this is a live stent boost where you can see the edge of the stent clearly, as you can see here. But this is what is a routine picture, what we see. But with the stent boost, when the moment you put a foot pedal on the stent boost, this will give you this type of pictures. So there is better clarity what exactly you are doing, because it is a point of no return at time. You have to be very perfect at that particular positioning of the stent. The same thing can be used in the vascular surgery also. For example, hepatic artery embolization here is an example where you can have, because of the patient's breath, everything is moving continuously, but you can have the median images as it is seen here. Now here what we call is a dynamic coronary roadmap. Previously we were having the coronary roadmap, which was, I'll show you the next one. So this is what was the coronary roadmap, what was there, and you can see, compare it simultaneously and keep on moving the guide wire. Now, so this is what was till yesterday. Now tomorrow onwards, we'll have this particular wiring where we are wiring it here, and we will get the background image, a moving image, where we can move the wire exactly. This, what is the advantage? The contrast injections are reduced. So the contrast related problem with the patient are definitely reduced. So this is a dynamic coronary roadmap where you can precisely enter the branch and you can have a better comfort of the procedure, and even in the complex cases you can do it better, as you can see here. So this is what exactly it will be there available now. For the valve implantation, we have done so far 32. Right now the 33rd case is on the table going on. So while we are using the TAVI, we call it as a trans-catheter aortic valve implantation or replacement. TAVI are the same. So here the CT images are imported through the cable network and they are projected here, and they can be sort of used simultaneously so that it reduces the contrast load for the patient. More precision movements can be there and you can use it better with a better clinical outcome. The precision is of most importance. Now here we are implanting a valve, as you can see here on right side. On the left side is an image from the CT scan. The CT scan is on the ground floor and the images are transferred, or they can be transferred across the globe from anywhere for that particular patient. And that will give me much of the comfort and precision, because every millimeter here counts. So also we have got the interventional tools for the neuroradiology. where you can treat these aneurysms, be it by the coils or be it by the covered stents or the flow guards, etc. This particular system can also do the CT scan in the same time. So far, we are sending the patients after the procedure to the CT scan for the follow-up if there is a bleed or something like that. But those CT scans can be done here on the table itself, and which allows whether the patient has got bleed or whether patient has got any complications. Now, here is an example where we are doing the brain imaging. Now, how does it compare? Now, this is the CT scan, what we are doing otherwise, and here is a CT, which is an expert CT, which is coming from the CAT system. So they're almost comparable. You can have the clear decision, is it? So these are the different CT features. These patients, they do have got a coils at times or some metallic objects which have been implanted previously. So they also can be negated and they can have the better outcomes or better results. So here is the metal artifact reduction, and you can get the better images at the end of the procedure, whether it has done correctly or not. Now, it is a planning, treatment, and evaluation where you can see in different types of the procedures, and you can see the embolization of the liver mass, and you can also have the vaso-CT, that is a vascular CT. Now, previously, suppose if you are injecting into the vessel, and if the vessel is blocked here, we'll be getting only the antegrade images, but there are the collaterals which are supplied. So here I get a collateral supply which is coming from the other side, and I can make out where exactly the total length of the block is there, and that will definitely help, definitely guide in which direction to go. And these are the different types of the images what a vaso-CT will give you. So here is a case of the flow diverter which is used in the for the intracranial use. You can also use it for the aortic aneurysms also. The vessel navigators, while you are going through combining the CT images along with the procedures, they can give you the combination of the two, where the CT scan which has been done on the CT scan department and can be combined here simultaneously by importing the images. So therefore, it will give you the correct navigation. This is to do the endovascular grafts, which along with Dr. Kamerkar, we do in our department. It will reduce the number of the radiation doses. They look at the contrast dose used here is 36 ml, whereas in the other situations, it would have been something like 200 ml of the contrast. And here is a deployment of the graft. You can also see the grafts through the stents which have gone to the renal arteries. So all these things can be done with more precision and ease for a particular given patient without opening an abdomen. So we will also get the smart CT, the various images, what I can show you here, and they will be definitely of use here in given scenarios. Here is a scenario where you can see the images which are moving back and forth, and you can have the correct three-dimensional sort of imaging where you can see these patients clearly. Here is an aneurysm, what you can see, and you can plan your therapy based on this, what type of the coils or what type of the devices you are going to use, how many devices you are going to use, will definitely give you the guidance. So this is a coarctation of the aorta which has developed the recoarctation. Anyway, I think I can't move this here from there. So these are the different images of the pulmonary artery also. You can see the pulmonary artery branch stenosis, which you can dilate with the balloon, or if required, you can put a stent. So these are the situations where this is another case who had a pulmonary artery occlusion. Here you can see, and which you can see these type of images, and you can plan your cases accordingly. This is the coarctation of the aorta which has undergone the cork treatment. So you can also get the 2D images. Dr. Kamerkar had shown you the previous case, the chronic limb ischemia, where you can see these type of the images, but you can get definitely much better details because of the algorithms of the computer, because of the algorithms and at a low radiation but a better quality. So this is how you will get the images, and they will be definitely helpful for the patient. Our aim is save a limb.
save a life, save a heart. So for the while saving the limb, it is better that you know what is the vascular supply, and that will definitely save the level of the amputations also. So is this enough? You can get it through. I'm not going to go into the details of the angiosomes, etc. But I think our aim is to have the better quality of the life for the patient with as much as any amputations, etc. they can be avoided. Now here is a case where we have done the abdominal aortic aneurysm. One of the famous celebrity from the film industry. You can see here this particular case which has been done here. We have put this particular grafts, stent grafts, and it has gone also. We have put into the renals and other side branches also. So this is the another patient for whom we have got the customized graft from Australia for this particular patient, and we did it because it had the celiac as well as mesenteric artery also. So those particular grafts we needed to do it here. So Dr. Kamerkar and we all working together in this particular program. We have got something called as a aortic program center where we can treat all these various situations. I'm not going to go through each and every right now, but let us come down that aortic situation, aortic related problem. Yes, we have got solutions for these type of diseases. It is a multidisciplinary with a endovascular surgery, open if required, a hybrid, minimally invasive, the teams which are involved from the different disciplines. It can be used for the diagnostic as well as for the therapeutic. And you can go through the various stages. The patient will go through the various stages, the screening, the basic investigations, etc. And after that, he will go for the EVAR, TEVAR, etc. or a medical management. So I'm not going to go through this particular busy slide, but in a nutshell, let me tell you that it will be the program where patient based on the symptoms, signs will be evaluated, investigated, and then we plan a particular definitive therapy which can be done in this particular type of hybrid ORs. So addressing the patient pathways, it is only the pain. So finding the various abdominal aortic aneurysms or dissections, etc., it can be definitely used. So it is so far we are talking about the tertiary center. Now let me call it as a quaternary center, where we have gone a step ahead, where we can have all the support, not only the imaging and cath lab, but also the blood bank, surgical theater, etc., post-operative recovery room, etc. We all have got nephrology. We all have got. The team will be the vascular and endovascular surgeon, the cardiologist, the radiologist, cardiac anesthetist, sonologist, etc., and nursing staff. So we have got our teams already defined. The vascular surgeon is Dr. Kamerkar, and the cardiology, myself, Dr. Grant, Dr. Hiramat, all. Dr. Cardiac surgeons, Dr. Ashish Khanijo, Dr. Jagtap. We have got interventional radiologist with us, Dr. Yadav Munde and Rahul Sheikh. Then we have got a radiologist. The cardiac anesthetist team is there. The common diseases what we manage here is the aneurysms, dissections, and occlusive diseases and TAVR. And these are the different types of the procedures which can be done or which we have been doing. And now we are confident that we can do it more with the hybrid OR. The cost, yes, is going to be a little more. One is because of the grafts itself. The graft itself is costly. So far, all the grafts are manufactured abroad. We have to import them. There are certain customized grafts which are meant for or manufactured for that particular patient. So obviously, it is going to be the costly. Now, last week we did the opening. This is a real life picture of our cath lab. This is how it looks in different directions. And this is what was at the time of the completion of the cath lab. These are our teams. Dr. Kamerkar that time was busy in the theater, so we could not take him in the picture. But we work together. This is what we are here today to offer for the patient for the best of the services. Thank you very much.
Any questions from the audience? Sweet. I think there are two chat, but I don't think there are not questions.
There are the two chat box questions. You start the thrombosis.
Nice. Should we have clinical work?
For the thrombosis and intravascular modality. A nice team.
Thank you. So thank you very much, sir, for your excellent talk. Really, it was very much appreciated because it was a real wonder for the patient also, isn't it? Because
we ourselves are fascinated.
yeah, we are fascinated with this. So thank you very much. I request our president, Dr. B.L. Deshmukh, sir, and our past president, Dr. Hilary Rodriguez, sir, to come on the dais to felicitate our speaker, Dr. C.N. Makle. Acha, Chitade Tasamukhale. Oh, we were thinking it is Makle. Sorry, sir. Makle. So thank you very much, sir. Now I will request our Joint Secretary, Dr. Gitanjali Sharma, to give vote of thanks.
Hello, everyone. So we have come to the end of an excellent academic session today. And I have this pleasant task of giving vote of thanks. So first, let me thank Dr. Kamerkar, sir, and the whole team, everybody, for this informative session. Makle, sir, thank you for excellent talk. Something really new that today we have learned. And today this was on the occasion of diary release. And Kamerkar sir was the chairman of diary release. And he always said, let it not be just the financial thing, let it be academic. So if you notice on the front page, it is written academic. So this was a wonderful day and a very fruitful day. I would also like to thank the team Pathkind Labs because they also had an excellent session in the morning. It was a very informative and interactive session. I would like to thank, on behalf of IMA Pune, all the delegates who joined online as well as who are present today. Because of your enthusiasm, it is our encouragement to Team IMA to organize more and more academic sessions like this. Team IMA would also like to thank MMC Observer today, Dr. Rajan Sancheti. No work is possible without the teamwork. And today's teamwork was, of course, by the diary release committee, Dr. Raju Variani sir, Dr. Sanjay Patil, Dr. Navrange sir, our past presidents, all the past presidents, and the present president, Dr. Deshmukh sir. Nimkar madam, Padma Iyer madam left her main function and she attended today's release function and the academic feast. So thank you, Padma madam. Then our president-elect, who is going to be president in first week of April, Dr. Meenakshi. So it was the whole teamwork that we put in to make this program successful. So from the team, I thank everyone. Again, कुठलंही सॉन्ग आणता येतं पण पैशाचं सॉन्ग आणता येत नाही असं म्हणतात. So Team IMA is grateful to Abbott and Yashka Infotronics, who are manufacturers of ventilators, for their academic grant support for today's activity. Today's was a hybrid CME. Hybrid CME is possible only with a strong digital support. We thank IMA Pune, thanks DigiShield for this support, and Mr. Miraskar and his engineer son for the audio visual support for today's program. And then सगळ्यात खुश होतं तो म्हणजे पोटोबा. So today's caterers were excellent for breakfast as well as for lunch. So Sukhatme sir, thank you very much for मकळे सर तुमचं झालं नाही का जेवण तर नाही तर सारखं वाटतं. Okay, and last but not the least, our IMA staff. I would again like to invite them. Aniket, Santosh Bhau, please come on the stage because they are the main support system for us. They work behind पडद्याच्या मागचे कलाकार, पण त्यांच्याशिवाय कुठलाच प्रोग्राम सक्सेसफुल होत नाही. सो लेट्स या सगळे या स्टेजवर प्लीज.
शिडे काका
या काका या सगळेजण या. ओके, आपण त्यांच्यासाठी सगळ्यांनी टाळ्या वाजवूया. थँक्यू एव्हरीवन. अँड हा, लेट्स हॅव अ ग्रुप फोटोग्राफ.
Thank you very much, our observer, Dr. Rajan Sancheti, for today's program, today's webinar.
फोटो शायद तो टाय है मास्क में ओके थँक यू. हे अध्यक्ष फक्त मराठी त्याच्यामुळे सगळं आणि इंग्लिश आणि हिंदी मध्ये आणि म्हणून मी आता लोकांना सांगतो, लोकांना चितळे माहिती असतं. मखले होतं परावळे काय काय वाटेल मला सगळी सवय कशाने माखले